Hello everyone. Thank you for joining us at INFODEMIC, a Stanford conference on COVID-19 misinformation and social media. My name is Rachel Barber. I'm a junior here at Stanford, and I am co-principal investigator on the project. We are grateful to Stanford's Ethics, Society, and Technology Hub for providing funding to investigate how COVID-19 misinformation affects vaccination rates.
And I'm Dr. Michael Gisandi, Vice Chair of Education in the Department of Emergency Medicine here at Stanford. Along with Rachel, it's my pleasure to welcome you to the Stanford INFODEMIC Conference. This is a unique conference in many ways. You'll enjoy hearing from experts in social media, ethics, public health, and medicine in a consensus conference format. Consensus conferences are designed to generate new knowledge, not just inform the audience. And that's one of the goals of INFODEMIC. It's to identify new ways to combat COVID-19 disinformation. It's a public health crisis, and we need to learn to mitigate it.
During this conference, there are a few key terms that will be used. For instance, the CDC defines an infodemic as an abundance of false or misleading information in a digital or physical environment during a disease outbreak. Another important distinction to be made is between misinformation and disinformation. Misinformation refers to unintentional mistakes making false information. However, disinformation refers to the manipulation of content with the intent to harm.
Dr. Vivek Murthy, U.S. Surgeon General, recently called health disinformation a public health threat. One of the goals of the INFODEMIC conference is to examine the ethical mandate that we all have to address this issue and improve vaccine equity. Therefore, we ask that you consider the bioethical implications of the COVID-19 vaccine crisis and other topics discussed in the consensus conference today.
Today, you will hear from numerous experts about COVID-19. We will begin with a COVID-19 update and transition into vaccine hesitancy and global health equity. Next, we will hear from social media companies and healthcare influencers about their powerful actions. Finally, we will hear from politicians and ethicists about the nuances of misinformation. We will close with a summary of the lessons learned today. Thank you again for joining us today at Stanford INFODEMIC Conference.
Please welcome our host, Emmy Award-winning journalist, CNN medical contributor, and the director of the Stanford Health Communications Initiative, Dr. Seema Yasmin.
Good morning, everyone. A warm welcome to INFODEMIC, a Stanford conference on social media and COVID misinformation and disinformation. I'm Dr. Seema Yasmin. I'm director of the Stanford Health Communication Initiative, clinical assistant professor in the Department of Medicine in the Division of Primary Care and Population Health. And I am so excited to be your host during today's INFODEMIC conference. So on behalf of the entire INFODEMIC team who've been working tirelessly to put together today's agenda, a warm welcome to you. Before we get started with our fantastic lineup of speakers and roundtable discussions, I have just two quick housekeeping topics to share. First off, I want you to know that our conference hashtag is Stanford INFODEMIC, and we encourage you to use that throughout the day when you're live tweeting the conference. We also have a few poll questions that will now be displayed on the right of your screen. If you scroll down, you can see there's 10 questions there. Please take a few moments to answer as many of those questions that you are comfortable with. This is basically just to help us get a sense of the audience as the day progresses, find out a little bit more about you, why you're joining today, and where you are joining us from. The fact that we are in an infodemic, or I would call it a misinfodemic, is no big news to us. It's been a dominant feature of the pandemic for the last almost 2 years. Rachel very eloquently stated what an infodemic was, and she shared, of course, the CDC's definition of an infodemic. However, I think it's really important to start the day by talking about how public health institutions, both domestic and international, have neglected the threat, the public health threat that the spread of false information poses. And I can say this because I used to work at the CDC, and it was that neglect about the public health threat of false information that led me to eventually leave the CDC and train as a journalist, and also to do research about the spread of misinformation and disinformation as it relates to health and science, and to really investigate how false information has been and continues to unravel significant gains that we have made in public health. So I want to share that because for so many of us and many of the voices that you'll hear throughout the day, we've been working on these topics for sometimes a decade, sometimes longer than that. Having been told in frustrated times by public health officials at many of these organizations that we perhaps were over-exaggerating or overstating the threat that false information posed to public health. And unfortunately, here we are in a pandemic where we are seeing that there's not just spread of a pathogen, but there's the concurrent spread of misinformation and disinformation about the pathogen that is spreading in tandem and is really fueling the spread of the pandemic. With that said, we will now be joined by our first speaker of the day, who will set the scene in terms of giving us a really thorough and comprehensive COVID-19 update. Our first invited speaker is Dr. Bonnie Maldonado, a professor in the Department of Pediatric Infectious Disease and Senior Associate Dean for Faculty Development and Diversity right here at Stanford University School of Medicine. Dr. Maldonado's Pediatric Infectious Disease Research Group at Stanford Medicine is involved in a really broad variety of local and international epidemiological and prevention activities focusing on disease areas including HIV/AIDS, polio, vaccines, and of course, COVID-19. So today, as I mentioned, Dr. Maldonado will be providing a COVID update to set the stage for the rest of our discussions throughout this day. Welcome, Dr. Maldonado.
And really, thank you, Dr. Yasmin. And thanks to all of you who are listening today. And I also trained at the CDC, and it's unfortunate to hear the message that Dr. Yasmin received from CDC, because I worked constantly with my colleagues at CDC whom I trained with and who are now leadership. And they actually now do acknowledge the impact of misinformation, but it's very hard for them within the constraints of their agencies to try to do the work that you all are doing. So I think we should partner with public health and not dissociate ourselves from them, because they are critical and we need to build that public health infrastructure. So I just wanted to advocate for that partnership because it's critical for us to get through not only this pandemic, but all of our public health issues. So today I want to talk a little bit before we start, just to set the stage, as you heard, what are the stakes? So I'm going to give you just a brief overview of what the data look like so far and why this is so critical. So this is something that may be familiar to you. This is the Johns Hopkins graphic that you can pull up on the internet. And the Johns Hopkins team at the Center for Systems Science and Engineering has been looking at the pandemic for since the very beginning. And you can see that they can track by country, by region, or globally, and that we've seen over 213 million cases now documented, with almost 4.5 million deaths. And in a positive note, over 5 million doses of vaccine given. In the US, you can see that we are at 38 million plus cases and counting, with almost 3.5 million deaths. So clearly, this is a ravaging pandemic all around the world. Now, if you look at what's going on in the US, you can see here over the course of the pandemic, we are in basically our fourth wave and hoping to avoid a fifth. But the biggest wave we saw was in our winter time, that is between November and January, November 2020 and January of 2021. But with the rise of the Delta variant and the reduction in masking and distancing mandates, in fact, discouragement of those, even though we are seeing vaccinations, we have seen just since the 1st of July, at least a 700% increase in the 7-day average for cases. So you can see the case rate is going up in the US. And if you look at hospitalizations and deaths, fortunately, while they are going up, we are not seeing them rise to the level that we had seen during our terrible winter surge. Although we are surging more than we did last summer, even with the fact that vaccinations are available. I'll talk about that in a bit. Now, if you look overall at the global COVID-19 death rates, this is from our World Mapper website, you can see that the world is displayed proportionally based on the number of deaths. And this is deaths in the numerator and the number of cases in that region as a denominator. So you can see that virtually all parts of the world have been affected, but you can see that our colleagues in Sub-Saharan Africa and Southeast Asia have been affected most significantly, but the US has not gone without its impact as well. On the positive note, we have some things that we can work for and advocate for. And that is when we look at global COVID-19 vaccinations, over a third of the world population, which has received at least one dose, and about a quarter is fully vaccinated. So that is some progress with, as I mentioned earlier, about 5 billion doses. I'm sorry, I said million earlier. I meant billion doses have been administered globally, with 33 million now being administered each day. However, only 1.4% of people in low-income countries have received at least one dose. Now, here in the United States, we have been very fortunate, and I feel like in some ways we're squandering this resources that we have. We have administered over 350 million doses of vaccine in the United States, which have been found to be highly safe and effective. And you can see on the left there the number of vaccine doses of Pfizer, Moderna, Johnson & Johnson. And we see that the population over 65 years old has been highly vaccinated around the U.S. That over 18 is over 60% vaccinated, and even children over 12, almost 60% vaccinated. So we are reaching a decent level. But unfortunately, as you've all heard, the Delta variant is highly transmissible and has really been driving the pandemic, especially among the unvaccinated. And this is really where the misinformation has come in, because while we have a high percentage of people who are listening to the science, listening to our public health experts and others, there is a substantial portion of the population that is not listening to that and are listening instead to these really, I would have to say, wild claims that really defy belief in my view, but clearly not in many others' view, because we are seeing a good 30% of the population overall that are listening to misinformation. And I just want to touch base on a few my other issues that I think are really important in driving the pandemic. And this is a book that came out in 2011. It's written by Bill Foege, who was critical. He's an infectious disease epidemiologist like I am. He wrote this book about the house on fire, the fight to eradicate smallpox. And what one of his Indian colleagues said when they were working on smallpox in India is, if a house is on fire, no one wastes time putting water out on nearby houses just in case the fire spreads. They rush to pour water where it will do most good, on the burning house. We have a burning house now in many, many ways, but one of the burning houses we have is the COVID pandemic, and we need to address that now. We need to douse that fire, and we need to really be advocates and active in doing that. And I think his words hold true for many issues, but especially today with this pandemic. And what we're facing as well is a convergence of crisis with simultaneous epidemics. And what are those epidemics? There's social vulnerability and social determinants of health. Now, if you look at health disparities, the CDC has developed this index that includes 15 different social vulnerability factors that include socioeconomics, housing, racial and ethnic minorities, and housing and transportation. And you can use that map to basically define areas at risk for poor health outcomes. And nowhere is that more apparent than when you look at the overall social vulnerability of all our 3,008 counties in the US. They're on the left in blue, rated by highest vulnerability to lowest. And you can superimpose that map on the number of COVID cases, and you can see that they overlap very well. So we know the areas at risk, although most of the country is facing this disease, these areas will disproportionately affect them, will be affected. And these have to do with social determinants of health and lack of access to good information. So this has really been a concern. And I think we know how to target the entire US, but these are pockets that we can really focus on as well. What are social determinants of health? Things like poverty, frontline jobs, crowded living spaces, crowded public transit, food deserts, inadequate insurance coverage. All of these things lead to higher risk for COVID disease, but also serve to alienate and isolate people from good information and leave them vulnerable to local pockets of misinformation. In addition, infectious diseases in general face issues around health equity, just like every other area. Occupation, housing conditions, poor infrastructure, and chronic illness around the world and in the US can lead to people being disproportionately affected by poor health conditions. The New York Times writer here really pointed out that Calcutta, her city of birth, was originally set up for the monsoon season waters to flow into the Ganges River, which flows through the city. But more recent disarrayed planning or lack of planning of housing led to trapping of water, so that the monsoon season no longer left the water draining. It left water in pockets around the city so that more waterborne, foodborne, and insect-borne diseases could proliferate. So we need to think about planning as well and how information can get out to those places. Hand washing, access to hand washing around the world. You can see lack of access in the yellow in sub-Saharan Africa, and more access to hand washing in high-income countries. That clearly is associated with vulnerability to diseases, especially COVID. And you can see that there's a big disparity here when you look at no access to hand washing and sociodemographic influence. These are simple steps, but they are critical steps to getting our populations healthy. And if you look at pediatric deaths in particular around the world from COVID, you can see that low and middle income countries have 2.5 and more times the risk of deaths than high income countries for many of the reasons that we just outlined. And then when you look at the number of vaccine doses purchased by income level, you can see that overall high income countries are really represent the majority of percent doses purchased. This is really an inequity that we really need to solve. So finally, I'd like to end by saying we need to reach our marginalized populations in particular, although everybody is a target of misinformation. And there are many ways to do that by using existing community engagement structures, local leaders, community and faith-based organizations, community groups, and health centers. And it's critical. This is what I've been doing my whole career in global health. Disseminate transparent and comprehensive information, but working with and not for communities. They know best what their culture is, what their practices are, and we can't go in and tell people what to do. We need to work with them to understand in a human-centered design way what they need and what will work for them. And that's how we can best partner, not only in the US, but all around the world. And so what does the future hold? Combination therapies, prevention in the form of vaccines, and non-pharmacological interventions. This is an old slide, but it's still true 18 months later, and it will be true, I would imagine, 18 months from now. And so restoring immunizations next steps, for example, will be just to restore basic services, help health workers communicate, rectify gaps in coverage and immunity, and expand routine services that have been missed out because of the pandemic. And the way forward is using science and equity to conquer the virus and those yet to come. Scientific and other advocacy collaborations around the world. We have unprecedented use of technology, but it needs to be distributed equally. Equity is critical and preparedness is mandatory. So I'd like to stop there and thank you so much for your attention.
Thank you so much to Dr. Maldonado for setting the stage from an infectious disease perspective. And I certainly echo her remarks about the need to collaborate with public health. And I certainly think that's more possible now than it was a decade ago when I was at CDC, given we have this acknowledgement that we never or rarely have isolated spread of a pathogen. There's always concurrent spread of misinformation and disinformation about that pathogen whenever we have an epidemic that we're trying to control. So now that we've had the scene set from an ID perspective, we're going to have the scene set from a more anthropological perspective. Dr. Heidi Larson, who is founding director of the Vaccine Confidence Project in the UK, has recorded some remarks to kick us off. Dr. Larson previously headed the Global Immunization Communication at UNICEF. She's now Professor of Anthropology at the London School of Hygiene and Tropical Medicine and author of Stuck: How Vaccine Rumors Start and Why They Don't Go Away. So let's hear her welcoming remarks for INFODEMIC now.
Good morning. It's an honor to share a few thoughts with you at the beginning of this important meeting. There are many things I could say about vaccine confidence, particularly in the context of the current COVID pandemic and all its uncertainties and vulnerabilities, and the amount of information and misinformation that the public and we all are confronted with. But given today's context and the theme of infodemics, I'll keep my comments about vaccine confidence to the relevance to information and infodemics. Infodemics are often defined as too much information, an abundance, an overabundance, good and bad, although there's been more recent attention largely to the risks and negative consequences of too much mis- and disinformation. But what is even more important than the sheer quantity of information is its dynamic, fast-moving, and fast-changing nature. Like epidemics, which spread quickly through populations, spread viruses and disease as we're experiencing now. They're challenging when they're negative, but there's also an opportunity we can't forget where credible information and trusted voices can also have a viral nature, which will be important. In the context of the rampant mis- and disinformation alongside credible but ever-changing scientific information around COVID, a crucial factor which determines the spread of this information is trust. At the Vaccine Confidence Project and in my recent book, Stuck: How Rumors Start and Why They Don't Go Away, I talk about triggers, fertile ground, and the impact of rumors. And it's one of the things that we frame and investigate at the Confidence Project. Where do things start? What sparks them like wildfires? What gives them traction to keep going? And what are the consequences and impacts? We've seen the same rumor, the same piece of information in 3 different settings, vastly different countries, and they play out totally differently. In one country, they can fizzle and die. In another country, it disrupts a program, and in another, it can totally shut down a vaccination initiative. It all depends on that receptivity and fertile ground that either amplifies or mitigates the spread. In populations which have high confidence, it can drown out misinformation. In populations that are more hesitant, skeptical, even doubting, they're much more receptive. And for those who are the lowest to no confidence, they can be amplifiers. They are often the creators of alternative narratives that can undermine credible information. I'm sorry not to join you in person today, but you have a fantastic lineup of speakers coming. And as you listen to the different perspectives and angles, because each panel takes a different institutional or individual angle on this issue, think about the triggers, think about the sparks which lead to these wildfires of infodemics. What is the fertile ground and what is it in different countries that keep it more under wraps than in others, which things go viral much more quickly? And what are those impacts? And what are the best places to intervene? And what can we learn from each other? Thanks so much.
everybody, and welcome back. Thank you for your patience as we sorted out a few technical issues behind the scenes. I'm really excited about our next panel. It segues really nicely from Dr. Larson's comments about vaccine confidence and vaccine hesitancy, because we have a truly global panel of 3 phenomenal women joining us to talk about this very topic. Right now, you are seeing only one of these phenomenal women, but the other 2 will be joining us. So let me try and do them justice by briefly introducing them. The person you are seeing on screen now is Dr. Gloria Geraldo. She's an international public health consultant focusing on Latin America and the Caribbean, and she currently serves as a consultant on COVID-19 vaccine education to Latino Health Access, which is based right here in California. Dr. Geraldo brings invaluable context to our roundtable discussion today because she's someone who's worked at the local, state, and international levels on projects ranging from pediatric injury prevention to chronic disease management. And for the last almost 2 decades, she's been dedicated to developing and managing public health programs with a real emphasis on Latinx, low income, and vulnerable populations. So very excited to have her here today. I will introduce the other 2 panelists who will hopefully be joining us in just a few minutes once Gloria and I get the conversation going. We will be joined in a few moments by Professor Agnes Binawaho, who's a physician and also holds a PhD. She's the Vice Chancellor and co-founder of the University of Global Health Equity in Kigali in Rwanda, which is an initiative of Partners in Health. She previously served as the Executive Secretary of Rwanda's National AIDS Control Mission, also as Permanent Secretary of the Ministry of Health, and she served as Minister of Health for Rwanda. She's a professor of pediatrics at UGHE, a senior lecturer at Harvard Medical School, and an adjunct clinical professor at Dartmouth. And then last but not least, the other panelist who will be joining us is Dr. Aida Habtezian. She is the Pfizer Pharmaceuticals Chief Medical Officer, also Professor of Medicine in Gastroenterology and Hepatology, and Associate Dean of Academic Affairs right here at Stanford. She's on the Board of Governors of the New York Academy of Sciences and is President-elect of the American Pancreatic Association. So we hopefully, there we have Dr. Habtezian. Hopefully we will also have Agnes join us shortly. But let's get the conversation going now with the 3 of us. First, thank you so much for joining us today. Welcome. I'm really excited that we have you on the panel because we really do have a global the scope for global discussion because of the expertise that you bring. So I actually wanted to start off by just asking you about the semantics of this discussion, because we had Dr. Heidi Larson, an anthropologist, talk about vaccine confidence and not so much vaccine hesitancy. And I've seen some physicians in the US, especially Black physicians, lean into a conversation more about vaccine confidence as an opportunity versus vaccine hesitancy as a challenge. So I just wanted to start off by kind of having this discussion about the language. And Gloria, if I can start with you, if you can perhaps talk to how you're framing these discussions within your community and what are the opportunities and challenges that you're seeing?
Thank you so much, Seaman. Thank you so much for the very generous introduction, and very honored to be part of this panel. Very great question to start with, because we actually have really struggled understanding that vaccine hesitancy has been a term that has been around now maybe for a decade or so, much before COVID-19, but really is a concept that has many dimensions. It's not a static concept. It's not that a person, it's a condition where a person would be vaccine hesitant as a permanent condition. And it really needs to be unpacked. In our communities here in Southern California, mostly immigrant, low-income communities, that is really very much an academic term. So it really just became popular through media in the recent months. It's not a term that people use in their daily conversations. But when we, in our conversation with community health workers, with promotores de salud who are out there talking to lay people and community members, we really see that that hesitancy started to be used as this umbrella term for many of the issues that Dr. Maldonado was addressing earlier today, as well as Dr. Larson. Is it, are people hesitant because there is a gap of understanding and information? Are there fears about adverse effects? And more importantly, in the community that I work with, are we talking about an issue of access? And is that not because the person is hesitant to obtain it, but is it because that the conditions around them are facilitating or not their ability to get the vaccine? So I hope that we discuss a little bit more about those today, but it's really unpacking this term, and it has very nuanced meanings. And I actually appreciate the confidence take on it, but also addressing access, and also at some point early on, when there were great difficulties in accessing vaccine for communities of color, lower income communities, was there some hesitancy on the part of providers to get the mechanisms ready for people to access it? So we can discuss a little further, and I'll leave it as that, but we can come back.
Thank you so much, Gloria. And I appreciate you bringing up access, because it's not an issue that's gone away. And access isn't just about physical access to a vaccine. It's about the very many barriers that might exist between a person and all of the steps in their decision making. Dr. Habtesian, if I can come to you, for example, I think it was a few days ago, maybe it was last week, that the Lieutenant Governor of Texas, Dan Patrick, blamed low vaccination uptake on Black Americans, kind of completely ignorant of the issues around access, neglecting to understand what factors might be in play when somebody from a particular community, a Black person, a person of color, is grappling with that decision about how much they might trust the medical establishment, how much they might trust what's inside the vial and what's being told to them of government. Can you talk more about these issues, and also just tell us more about the work that you're doing in this area?
Thank you. I hope you can hear me, because I have difficulty. So I'm using my iPhone.
We can hear you really well. Thank you.
I'm glad you can. Thank you so much again. I want to thank you and the organizers for giving me this opportunity to participate in this important conference and panel. So going to the question in terms of addressing equity and trying to understand about the information, and as you mentioned, why we have a vaccine hesitancy, I think it's important to understand that there are multifactorial, there are multiple issues that have led perhaps to the reason why we have a low uptake. And I think it's not one size fits all. So it's very important to understand the root and the source of this misinformation. And I'd like to say a few things. And I think some of the misinformation around our vaccine, the Pfizer-BioNTech vaccine, is, first of all, to put it in the context of the disease, the COVID-19, as we heard from Dr. Maldonado, the impact of COVID-19 and why we need to be taking this vaccine. What does this common threat means? And globally, as well as in US, we know that there have been more than 600 deaths and over 4.4 million deaths globally. And this has impacted especially also minority, marginalized communities, even to a greater proportion. So I think the other thing that we need to combat this misinformation is by giving the scientific and medical evidence and trying to bring that to light. What was the vaccine? How did the vaccine actually come to play? So there are, as you mentioned, there might be groups who would say this does not impact me, or diverse groups were not involved in the development of the vaccine. There is also misinformation with regards to cutting corners because it was developed fast. There's concerns that maybe there is some cutting corners. So I'd like to talk a little bit about the vaccine development and the diversity involved in the clinical trials. So this mRNA technology, as we talk about it in terms of the vaccine makeup technology, has had actually years of studies in preclinical studies and data. And the partnership with BioNTech, in fact, goes back to 2018, where this development was towards flu vaccine or influenza, but this was extended to partner for the COVID-19 because of the pandemic. So I think we have to also be very thankful for those 44,000 and more courageous clinical trial volunteers and participants that enrolled in more than 150 clinical trial sites around the world. So it's not just in the United States, but also, many places like Turkey, Brazil, Argentina, South Africa. So this is a global pandemic, and also there is. It was really important for Pfizer to put that effort to really involve and ensure diverse population are included. And so I think when we come to diversity in the US, also when we look at clinical trials, we talk about census, for example. What is the proportion of African Americans or Black Americans in the study, and what is it in the census? So in the clinical trials, there were 10%, and that's also overall when we look at US population. Amongst Hispanics, there were 13% in the clinical trials. And overall, we know that, in the US population, it's about 13%, but we had 26%. And similarly, also important for Native American and Alaskan Native that were also included in the trial. So these are very important information to really to know who was participating and how these trials were done, which is very important. And I think into this panel, and also to contribute to vaccine confidence.
Thank you so much, Dr. Habtezian. We're delighted that Dr. Binawa has been able to join us now. Thank you so much, and a warm welcome to you. Agnes, I hope it's okay if I'm calling you all by your first names. I got very friendly and familiar very quickly. But Agnes, I'd like to ask you the same question as well regarding what challenges you're seeing, but particularly in Rwanda, in parts of Africa where you've been involved with programs around vaccine education and vaccine uptake. What particular opportunities and challenges are you facing?
So the opportunity, I can say, in my country and and generally, vaccine hesitancy is not a pressing challenge in many African countries. Let me tell you why. A study done by Africa CDC showed that 80% of the population in African countries is willing to get vaccinated. It is 65% in the US, 60% in France, as of May 2021. So knowing that now, today, only 2% of the African population has got access to vaccine, our problem is not vaccine hesitancy. Our problem is clearly vaccine access, and also to have equity in access. So if we focus today as African activists on vaccine hesitancy, we are losing our energy. We better focus really on access to vaccine. I don't know if my argument is clear here.
Oh, no, that's crystal clear. And I think you're re-emphasizing a point that's been made, Agnes, about how nothing to do with this pandemic is equal, from mortality and morbidity rates, from who's most susceptible to infection, but then also the inequitable access to vaccine. So it just shows how context is so important and how nuanced this conversation has to be, given which communities we're talking about, which parts of the world we're talking about. So you're having a conversation about access. We're having similar conversations for some communities here in the US, but globally, we're also dealing with a situation where Israel, the UK, the US is on track or already doling out third shots, booster shots, while so much of the world has still not received a first shot. Gloria, I wonder if I can come to you and ask about how we have conversations about these ethical challenges, given that this is such an uneven playing field to begin with, and that the pandemic is simply highlighting all of these broken parts of our society.
Absolutely. And I think that in communities in the United States also that are traditionally, unfortunately, have been marginalized, have less resources. There are also a very high number of immigrant communities. And so they're very conscious of what they are living in the United States, and the issues we mentioned about access, that I'd like to touch upon them a little bit more, but also because they have their families and relatives and very close people that are experiencing the very same type of situations that Dr. Binagawa is mentioning, where family members, their parents, their grandparents in Latin America, for example, have not been able to receive the vaccine or are in very long waiting periods to arrive to the age group where they'll be able to receive it. So there is a sense of understanding that obviously that we have been affected very differently. And there's so in very blatant ways in the communities here, where sometimes it's only a 15-mile difference. So this is also another context where industrialized and developed countries is not, if there's no equity either, right? We have, as I was mentioning, just a 15-mile difference where people have continuous access to the medical system. And that is one of the factors that also has underlined some of this mistrust that we were talking about before. If you don't have a regular doctor, it's obvious, and it is normal to have fear of the unknown, to have been a little bit worried about this brand new vaccine. But you didn't have a trusted source in the medical field to resort to ask questions. So those long-lasting disparities that have been mentioned in this morning as well are playing out every day and continue to fuel those issues of equity. They had to do with, since the very beginning, equity in the distribution of testing sites, equity in the distribution of the vaccines themselves. And now we have to see what the mechanisms will be in the equity. If we're moving towards, as it seems, the third shot, how to continue setting effective mechanisms in the communities that haven't received it. I mean, it took a lot of organizing, grassroots organizing, to be able to level the field a little bit, and it's not completely leveled, as we know. The vaccination rates are different in different communities.
Yeah, no, thank you so much for clarifying that. And I think it's important to raise that issue. Yes, we're having a roundtable about vaccine hesitancy, but as Agnes has said, and as you're saying as well, Gloria, it's not just about hesitancy, it's about very basic access to the vaccine. One of the things that I study is inequitable access to accurate information about health and science. And what we've discovered in a mapping project we're doing at Stanford is that in the same way that some communities are more vulnerable to disease itself, there are some communities who are more vulnerable to being targeted by disinformation campaigns and are more susceptible to believing misinformation. So a question for you, Ida, because you really nicely pointed out some of the misinformation and disinformation that spread about mRNA vaccines in particular, and you countered that with some of the information that helps us contextualize why this misinformation arises in the first place. But my question for you, because I've been so critical of public health for many years before the pandemic, but throughout the pandemic too, that in public health, we have often neglected, or we've relegated communication of public health, communication of health and science to very far down the list compared to the research, the basic science, right? And one of my frustrations as we were fast-tracking development of a vaccine was, you know, this is great. We're going to probably develop a vaccine in record time. Many of us in public health had a lot of confidence in that. But my frustration was, well, is there a concurrent vaccine communication strategy? Because we could have predicted, right, some of the health hoaxes and the medical myths and the rumors that are spreading now. So since I've been critical of public health, I want to be critical of industry too. And I wonder if you can take us behind the scenes, Ida, to help us understand whether those conversations about vaccine communication were happening at Pfizer, and perhaps if not, then the why not and what might be different in the future.
Yeah, I think this is also an important question to address. And I can say what we have been doing at Pfizer. And I think it's very important, as you mentioned, to get the right message across. So, separating the message from the messenger. And I think we've worked hard to be as transparent as possible in the development, safety, and efficacy of our vaccine. And we're continuing to do that through various channels. So, for example, the data that was published, not only presented to regulators, of course, which is important for us to do, was also to make it publicly available as soon as possible. And this is why it was available at the same time as it was available almost to regulators. So this was another important, and there is also channels that we use, for example, in our Pfizer website. There is also, for example, in my organization, Global Medical Information, that anyone can call or access the website in many countries where we are committed really to try to address equity in information, because it's also important to really give the scientific and medical evidence so that way we can combat this hesitancy. We also believe public education in collaborating with patient organization, medical and public health institutions is critical. And this is globally. And we've had many interactions, including in the clinical trials, because that was unprecedented, for example, to include, minority groups, because that meant to go out and also partner with trusted civil societies and NGO organizations like the NAACP, the National Black Nurses Association, the National Hispanic Medical Association, because in order to have a culturally sensitive way also, whether it's the consents or whether it's how we do our, to remove barriers in our enrollment, like language, for example, and translation and whatever the materials were necessary. So it was really a heroic effort, to really be including all those sites, to partner really to go in depth, work with investigators in such an unprecedented time. So this was also important in terms of having access in an equitable manner to the clinical trials and information.
Thank you. And Agnes, as you're hearing more of this discussion, you're setting the scene for us that in your part of the world at the moment, access remains the most critical issue. Do you, however, think about vaccine hesitancy as a challenge that could arise in the future, that will arise? And if so, I wonder what efforts or plans are being made by yourself and your teams to perhaps counter that future challenge. Oh, Agnes, you're muted.
To be disciplined. Sorry. Yasmin, this is an important question. And despite what my fellow colleagues are saying in this panel, I repeat, vaccine hesitancy is not a problem now in Africa. And in Rwanda, it's even more deep. In 2019, before COVID, there was a study done by Wellcome Trust and Gallup Institute in the US, showing that my country, with the really not great, let's say, sophisticated health system, is the country where the population has the highest trust on the health system as it is. And why is it? They did a study, they did triangulate, and when you have a trust in your government, in your judiciary system, you have trust in science, you have trust in unknown medical tools that they are presenting to you to save you for a recent, very new and unknown disease. And I want to say that in the US, what happened? There is a historical lack of trust by some communities because they have been mistreated by science, mistreated by the politician, mistreated by the judiciary system, and they are still mistreated by the security system. So they don't trust and they don't come to seek services. And for this, I want to remind, because it's in the subconscious of each and every Black person in your country, the Tuskegee syphilis trial, where people were unethically exploiting a minority, knowing that they were killing them, and the scientists passed through this through the judiciary system without any accountability. And it was known they will have never done that to white people. So this explains why people, because of the economic situation, are more vulnerable, and because also there is so many studies showing and demonstrating that Black people in the US are not treated the same way than white people in health system. So what do you want to have? You have no trust. And the last 3 years, it has been shown that trust is one of the biggest social determinants of health. I will trust you for things I don't know if I know you are a good person for me. And this, the US have lost it because of political activities where people have lied for their own things, where people have been lost because they have been lied without, again, accountability. So rebuild trust, but not in the middle of the crisis, on a day-to-day basis. Be a more equal society. Don't believe you bring equal distribution of vaccine or opportunities or of health system when there is no equality elsewhere.
Yeah.
Everything is linked.
Yeah, and I appreciate you talking about the historical context, but also stating very clearly that that medical mistreatment of Black Americans especially, but also Indigenous and other minoritized groups continues. We have so many studies showing how Black patients' pain is under-believed, under-treated, and that medical mismanagement and abuse continues. Agnes, you talk about not trying to perhaps build trust in the middle of a crisis because it's extremely hard then. But I want to ask you, Gloria, a question about this, because we've talked about government, we've talked about public health agencies, we've talked about industry, but you also work with promotoras and other kinds of community health workers who really are trying to be that bridge, really are trying to build trust. So can you tell us more about those workers' efforts around vaccine education and uptake?
Absolutely. And yes, within a crisis, there are so many unpredictable factors. However, community-based organizations that have been there, in the case of Latino Health Access here in Southern California, we've been there for 30 years. So that trust, that process of building that trust has been built day to day. The other aspect is that we're not newcomers or people external to the communities. These are people that live, study, work, play, pray in the very same context, in the very same churches, and they shop at the same little markets. So there is that shared experience, that shared lived experience among the people that we partner with, and it's all about partnering. So we had the ability, because of those deep roots in the community, to grow from about 80 staff, community health workers or promotores, to 150 during the pandemic. And these were the youth that came to help us to set up a call center. And what that was done in about less than a month, because when the lockdown began, our way of communicating with folks was face-to-face, was door-to-door. And during the pandemic, that couldn't be done. So where were people going to find trusted information? We needed to set up a phone line that really became a lifeline for many people, trying to find out where to get a test, how to isolate, could they get a voucher to a hotel. So it's also all the wraparound services. It's not a medical crisis. It has all the implications that we've seen. People that lived in crowded housing needed to be isolated because they obviously could not stay in the same space, and that needed support. So the community health workers were the trusted agents that could help them relocate to a hotel, help them with groceries because they couldn't go out and get the groceries, and help them with all the other many necessities that arose. On the other hand, I do see an opportunity, and it is an opportunity for our public health departments and our health authorities to restore trust. And I think some are taking that seriously and taking that to heart by immediately, through the pressure of the community-based organizations from many different backgrounds, the Asian Pacific Islanders, from African Americans, from every group, parents also as a group of concerned citizens, pressuring their health authorities through building health equity initiatives, and having them walk the talk. Were they going to have vaccination site distributions in the communities that had the highest positivity? So we had to mobilize, we had to hold the health authorities accountable, but it was up to the health authorities as well to respond positively. So there might be opportunities to continue along that road, to continue building that trust, but it will take time.
Yeah. Yes, please.
Sorry, if I may add, I think a very important point in terms of that. What are we doing? I would like to focus in terms of, because all of us need to partner, need to go to the communities. I think what Dr. Maldonado said is very important. One is that we serve the community. So I think I would like to also note that there are certain things that Pfizer is doing. For example, the Pfizer Foundation that created New Social Determinants of Health grant program, which funded 10 organizations working to advance health equity and reduce racial disparities and health outcomes amongst African Americans, for example. And I'd also mention the grant and the partnership with the Black Nurses Association is a program that is called Rethink Program, which aims to increase vaccine confidence among the Black community. And there was a $1 million award that was given by the Pfizer Foundation. So I think definitely there is a huge problem, but we need to start somewhere. And I think we need to really work with partnering with the communities that are really impacted. So I just would like to highlight that we all need to have a stake, and we all need to be involved, and we have to find innovative way, just like how we came up with this vaccine, is to really come with innovative ways also to solve these barriers.
Thank you.
And also to do that on day-to-day basis, not during the crisis. Because what Garcia says, sorry, is your first name Garcia? No.
Gloria.
What Gloria is saying, they are there for 30 years. So they have built the trust that I'm talking to. It's not that is important. They are building on what they are doing on day-to-day basis. And what the lesson learned out of it is, starting now, you have to do, but never stop.
It's definitely a process, and we've talked about trust so many. We should have played a game where everyone drank a sip of water every time we talked about trust, because it's so pivotal. And Ida, you answered my question before I even got a chance to ask it, because Gloria was talking earlier about restoring trust. And I was thinking in terms of industry, pharmaceutical companies in particular, it may not even be restoring trust with publics. It might be building trust for the first time, given long histories of exploitation, long histories of a perception, or evidence about exploitative practices. And you were saying earlier about improvements, gradual, but some improvements in terms of the diversity and inclusivity of clinical trials. I read a while back some groups of Black health activists and advocates saying those increases in diversity in some of the vaccine clinical trials, they believe only happened because they so strongly advocated to industry for that and actually took clinical trial participants or took stakeholders to industry. You did mention those grants, and I wondered if you could talk more though about in the future, since we're saying, look, we're in a crisis, it's going to take time to get out of this, but thinking about a different future where there perhaps is more collaboration, even between industry, even between the promotores that Gloria is talking about, what do you think, dare I ask, might look different in the next pandemic, Ida?
Hopefully we won't have a next pandemic, but we've learned a lot from this pandemic. And I think it's important that we apply these learning lessons to actually to day in terms of activities. And I think there is a lot that has been learned in terms of partnering. So one of the things, for example, we talked about access is even having the vaccine in such an unprecedented time. How do you even make vaccines to that extent, that billions of, because the population of the world would be waiting for these vaccines. So this also required partnership with other manufacturing, other companies, for example, which, this wasn't really something that was done very frequently. And then partnering with communities, as we talked about. This is very important. Now we know that this is how we should be. We should be serving the communities, going into the communities and partnering. And when it comes to really clinical trial initiatives, diversity initiatives, this is also another one that we will continue to build beyond the pandemic for all our clinical trials, to ensure that we have community partnership and that we are enriching that diversity. So there is many things that we are learning also from this pandemic in terms of how also we can develop safe and effective medicines and vaccines. There's a lot of lessons to be learned. Mm-hmm. And I think we talked also about access to the world, is that how can industry partner to bring this equity into place? And I know that Pfizer is actively working with governments all around the world, as well as global partners, to work to equitable access to the COVID-19 vaccine. And there are a few things I can, this is a start. This is initiation in terms of what we are doing. For example, the Pfizer and BioNTech collaboration is to supply multiple pathways, including direct supply, whether it's with the country governments, whether it's agreements with COVAX, whether it's agreement with the U.S. government for, to be supplied to low and middle income countries. And more recently as well was one of the things that Pfizer had with BioNTech is partnering also with a company in Cape Town in South Africa, BioVac. This is a company that Pfizer has worked in the past to since 2015, for example, to do to bring in a formulation for the pneumonia vaccine, Prevnar 13. So this is another one where there is now Pfizer and BioNTech are working to incorporate into vaccine supply chain that would be actually in the Cape Town facility. So to include that facility as a manufacturing and finishing doses. So these are certain things that, there are many, of course, things in here. And I just would like to highlight that the equity started from the development, from the clinical trials early on, making sure that there is diversity, inclusion, and equity, and then going on all the way, right? So in terms of, and we'll continue to do, and these are just some of the things that I just mentioned that are ongoing, including information equity.
Mm-hmm. Yeah, small, gradual changes. Agnes, you talked earlier about there being multiple studies showing that in Rwanda, there is trust among the public towards the government. So I wondered if you could tell us how the public is perceiving the lack of access to vaccine and whether that changes or whether that impacts how the public trusts or doesn't trust the government. Is it being framed as a government failure?
No, it has been framed really and understood as high countries' mismanagement. First of all, there was COVAX, and we disseminate the information, etc. 20% of the people at risk, etc. And after that, all the countries that are rich got more, some of them 600 times more than what they need, without ordering that, with knowing 1 billion of doses in high-income countries that will be stocked when other countries are dying. So this is known. So this is a global solidarity and a Western supremacy problem by who don't want to sharing something that will bounce back to them anyway. Because if we have variants, it's because we didn't manage to stop the pandemic. And we didn't stop the pandemic because we didn't apply what the scientific world have said. COVAX was a very good thing. Stop the pandemic all over by vaccinating the people at risk and the people who give the services. We missed it. So now we have variants that bounce back and come back to kill the people in high income countries. And we are facing, and unfortunately, Aida, there will be other pandemic. There is a pandemic every 10 years. We know that. Some are well managed. This one is totally mismanaged. But there will be a pandemic regularly in our life, and we need to be ready to not do the same issues. That means it's a pandemic, it's a global problem, a global solution. Let the scientific lead the way and distribute the vaccine according to the priority list to stop the pandemic.
Agnes,
Because,
what can you? Oh, sorry,
yes.
go ahead.
No, I think I have say what I want to say.
I wanted to ask you, Agnes, what you can tell us about what the future weeks, months, next year might look like in Rwanda and neighboring countries in terms of vaccine access. What do you know about that?
So we are in Rwanda. We are quite a little bit lucky because we are well organized about distributing the vaccine, following the list as it is, and because of the trust the people have, you should see the line now. We have started vaccinated in hotspot young people above 18. It's so touching to see how people are waiting all the day to be vaccinated, but massively. So it depends of what the world will be able to produce, because there is a lack of vaccine that we doesn't have to say something. Pfizer, you do your best, and we upload the fact that you have partnered with a team in South Africa to create vaccine, and others. We need more place in the world to produce the vaccine we need today. And we are hopeful because in Rwanda, people are very disciplined. It's a culture where we will put the mask, even vaccinated, just to protect the people who are not, because we still don't know how we can contaminate somebody even when we are vaccinated. There is a high solidarity also in the community, because by all the poor people make sure that they are not homeless, they have food on the table, etc. And all the country support the economic rebirth. And this is the biggest problem, because in the time to come, the economic damage created by the pandemic, we don't know how big it is and how it's going to be bounced back to the health gain we had in the previous years. If, and I have to say if, we don't have a variant that responds to none of the vaccine we have now, because the world has been so self-centered that they wanted to vaccinate their people first, when creating the condition to have variants like the Delta. And one day, and we know as scientists that it may come, we have a variant that responds to none of the vaccine we have now. So starting again. So the situation in Rwanda is totally linked with the fact that it's a pandemic and it's a global issue.
Absolutely. And Rachel's popping in because we have just 2 minutes, maybe 3 minutes left. Thank you so much for a riveting discussion so far. And I wonder if in the last few minutes, I could ask each of you, and I'll start with you, Gloria, first, what the major challenges and opportunities you foresee in the next year, and how you feel your organization will play a role in countering or taking advantage of some of those opportunities. So just a minute each, please. Gloria.
Thank you. Absolutely. I think this has shown us, and I agree completely, I think historically we know there will be more pandemics, but not only pandemics, there are emergencies, disasters, and communities that are vulnerable are always most vulnerable in those situations. Therefore, not only next year, but in the long run, we're also calling upon academics and scientists and governments on how to sustain the infrastructure, the local infrastructure, because what this also has shown us so blatantly is that what happens at the local level, how is that managed once the policies at macro levels are in place, but how is it deployed in the ground? So building the infrastructure, supporting community-based organizations, working with local governments and in a partnered way need to be in place, and addressing those other social determinants. We had obesity, diabetes, and many others that need to be addressed and continue addressing.
Yeah, none of those are new, and we're layering new challenges just on top of old challenges. And Ada, I'll come to you next.
Yes, absolutely, Seema. And I meant to say that we haven't seen a pandemic, over 100 years. I wasn't talking about the pandemics in terms of emergencies and et cetera, but I do agree there will be more pandemics. And I think Pfizer colleagues have worked relentlessly to leverage decades of experience and expertise in developing and manufacturing, as well as partnering to provide this safe and effective vaccine for all. So I think I'm very proud of, the successes. And also, I think it's important to highlight, I think, because we are talking about vaccine hesitancies, that we continue to evaluate the benefit risk profile of this vaccine by following and monitoring not only our clinical trial participants, but also through additional studies, following reports from real world experience, as the risk and disease evolves over time, because new variants do emerge and have shown us that they are emerging. So we can be ahead of this pandemic.
Mm-hmm.
So let's be safe, protect not only ourselves, but also our loved ones and also our community. And I also urge that we consult our healthcare professionals and lean on the science and medical evidence. Thank you, Seema.
Thank you so much. And the last word to you, Agnes.
So I want that Africa will be more self-reliant, meaning we have to start, and we have learned that it's the first time we face this. Not stop being served when the rest of the world can give what is remaining. Start building, start manufacturing what we need. That's one. And Africa have started, and I hope it will be a wave. Second, we take the good experience all over the world. There are so many good experiences that are not enough told. Third, we know where we are reaching here. I want a system, a global system, to make all those people who lie to the people, who make them die, to be accountable. They have killed more people than the terrorists, and they are going with it. So we need international law to make people accountable when they lie by purpose, if they kill people.
Thank you so much, all of you, for joining from your respective parts of the world. It's a real privilege and honor to hear your expertise and your experiences. And it's clear to me from this discussion that we can never be talking about vaccine hesitancy without talking about vaccine access and inequitable access here in parts of the US and globally as well, especially in the global South. So thank you all. Thanks to our audience for your attention. I'll hand it over to Rachel now.
Thank you once again. Next up, we will be hearing from Dr. Italo Brown, who is Assistant Professor of Emergency Medicine at the Stanford School of Medicine.
Hello, hi, I'm Dr. Italo Brown. I'm an assistant professor in emergency medicine at Stanford. Such a pleasure to be here today. Today, I'm going to be talking to you all about vaccine hesitancy and the distrust of healthcare. And before I start, I always say I'm bringing greetings from Stanford University, the Department of Emergency Medicine, and a huge shout out to Mike Gisandi for being an excellent colleague and for having the insight to lead such a conversation through this platform of INFODEMIC. I also usually begin by giving what I would consider to be a trigger warning. I believe that these conversations can have a sensitive nature. And so let's exercise a little bit of grace with one another. I acknowledge that I have biases as a male, as also a person who is of Black origin. So my conversation today may come from a place of bias. And I just ask that as we all navigate our own biases, give me a little bit of grace in that conversation as well. All right. So big numbers that we need to know right now is 72%, right? So 72% of the US adult population is considered vaccinated. But when you start to look at the demographics and break that down from a race or ethnic lens, you see that less than 50% or about 50% of that number are white. And according to the KFF or Kaiser Family Foundation, on August 16th, we have less than 50% of Black, Hispanic, and white people receiving that dose. But 1.4 times is the biggest magnitude. When you look at Black people specifically, we are 1.4 times less likely to be vaccinated, or whites have a 1.4 times greater likelihood of being vaccinated. And you start to wonder, like, what really is at the core of this issue? And what we talk about is this lingering theory or thought of vaccine hesitancy, and maybe even that is due to embedded distrust of the healthcare system. That question has come up over and over, and I'm going to shed some insight with you all today about why that distrust exists and why vaccine hesitancy is a real thing. You know, we can't continue to gaslight communities of color around this topic. So for the next 12 minutes or so, we're going to explore that topic together. So when we think about the roots of distrust, I want you to factor in all of the lived experiences, like generational lived experiences of people of color. All right. So you can't start in the last 100 years. You have to really go back from a historical context point to take inventory of all of the different events where Black lives and Black bodies were devalued. So if we did that, we could start with the slave trade, where in general, Black bodies were considered subhuman, and it created a baseline for behavior for America. And then you see several instances over the next 300 to 400 years where Black bodies were mutilated, experimented on, and eventually told that they were less than the average human in order to justify practices, right? So 1845 to 1849, this is just a brief history. 1845, 1849, James Marion Sims, father of OBGYN. You've heard of him before. Those procedures were often practiced on Black women without anesthesia, using the underlying premise that Black women or Black people in general didn't feel pain. 1850s to 1890s, the robbing of Negro grave sites, of cadavers from Negro grave sites in the Medical College of Georgia. This happened. And then the more common one that most people are familiar with is the Tuskegee syphilis study. We hear that, and the misconception is that we were giving, or that the federal government was giving syphilis to these subjects, when in actuality they were withholding treatment. And so everything we know about syphilis, specifically the full extent of it, comes from watching older Black men or Black men in the South deteriorate while withholding the treatment. I can go on and on about the legacy of distrust and abuse of Black bodies, but that creates the bedrock for this distrust. And it doesn't stop there. Like, currently, we still see elements of mistreatment in the medical system. So it would make complete sense to know that Black communities have a lasting and lingering distrust of healthcare providers, of the systems and institutions that have supported it. And it's really a matter of compounding that distrust with things like racism or race baked into the medical education system, and not to mention social determinants of health as a modifier of these different distrusts, the different distrust and hesitancy. So it deepens it, right? That's what we went into a pandemic with. And so where we're left now is fighting what I consider to be the misinformation Olympics, right? There are communities that have access to adequate information, and then there are communities that are at a disadvantage to having good information and trusted messengers, as well as having real-time fact checking. So I'm going to explore a couple of things with that in a second. We have to acknowledge that source matters here, right? When messages were immediately coming out around COVID-19, think back to, I would say, like February, March. Within the Black community, there was a general belief that we were immune to this illness, right? And I think that was partially because there were no reported cases or things that we could see where people of color were being found to have this disease, right? We were thinking about it in a very modular, myopic way. But that is also partially due to the way that media portrays people of color. And not having the full access to it gives us a little bit of that, the roots of that misinformation as well. Now, as we explored a little deeper, understand that having trusted messengers, people who can interpret messaging, who can deliver adequate, truthful information, is a commodity. It is a rarity, and it's scarce in Black communities. We often have fewer people of color in medicine. 4% is the going number, between 4 and 5%. We often have fewer people who are participating in scientific research, fewer grant-funded people. So the communicators, the people who can actually break down this information, are not at an abundance. The other thing is, in communities of color, we have a weird relationship or tug of war between faith and fact. We're often put in a position where we have to rely on our faith without having sufficient information and fact. And I was on Clubhouse one time, and this conversation essentially erupted, where people were feeling as though their faith was going to get them through this pandemic. And when you communicate with people of color, when you communicate specifically with the Black community, you have to honor that both can exist. And so, born out of that relationship, there was often a little bit of struggle. And then finally, our culture tends to be very viral. And I mean that in the sense of how we have traditionally passed messages. We know that oral tradition is a feature of a lot of longstanding civilizations. And in Black communities, oral tradition is as common to us as knowing, that what the sound that a hot comb makes when you put it on a stove, or as inherent to us as realizing how to do double Dutch, or any of those things that come with our culture. So when we learn stories, when we learn about information, it's often passed down a chain. And just like the childhood game of telephone, that information can change and transmogrify. So we struggle because that chain of information very seldom has fact checkers, people who we trust, who can give us adequate information in the languages with a sense of cultural competency and linguistic appropriateness tailored to the Black community. So the messages end up being distorted. And then there's finally the viral nature of memes and social media, where it can travel faster. They say the saying is that a lie will travel faster than the truth, or the truth will stand still in tying its shoes while a lie travels. That is so prevalent, and we have a difficult time catching up with truth. And the last part is the illusion of equity. So this idea that equity is truly actualized. I don't want to dismiss the efforts of all of our healthcare workers, of all of the public health community in trying to create an equitable environment for fighting COVID-19, which includes expanding access to the vaccine and for screening. But I would be remiss not to acknowledge that initial rollouts of vaccines, initial rollouts did not have equitable measures in place. And I'm talking about broadly, because the furrows of communities, the vulnerable communities, often were displaced from the vaccine. I mean, we can look at examples such as in Philadelphia, where the vaccine rollout was basically handed to a 22-year-old young white man who had a startup and eventually was displaced from Black communities. We can also see examples in places like here in the Bay Area. The Oakland Coliseum has about 40% of their doses that were given out at the Coliseum did not go to people who were indigenous to Oakland. So these issues, when you hear about them from the lens of a Black community member, it separates you from the idea that the system is working for you and that it is equitable. I think that it's important to acknowledge as well that we don't have enough people who are able to fight this fight. Fatigue has set in to some degree, and this allows us to miss the opportunities, or this creates missed opportunities to educate appropriately. So not having the resources, not having the capacity in an equitable fashion also leads to further distrust of healthcare and also increases vaccine hesitancy. So with the last 3 minutes that I have here, I just want to highlight 3 very important things that I think that anyone who accesses social media, calls themselves an influencer, or chooses to be a medical professional that is skilled in delivering messages to communities that are vulnerable can actually employ. The number one thing that I would say is facilitate conversation around restorative justice. You've heard this word restoring trust. This happens through facilitated conversation. We acknowledge the wrongdoing. We make sure that it is on record, or on wax, as we like to say in the community. Make sure that people know that there is significant distrust and a troubled relationship between specifically the Black community and the healthcare system, and that it is warranted. And we understand that we're a part of the problem and can be a part of the solution. The second step is to identify and activate trusted messengers. So it's not enough to just say, hey, I know somebody who can speak that language. We need to mobilize and get those trusted messengers in front of people consistently so that they can deliver information in a way, in a tone, and with a texture that is relevant to the communities that are seeing the greatest disease burden and also seeing lower numbers in vaccination. And then finally, we have to amplify disruptive models. As I said, to really get through misinformation, you have to think creatively. To get through the resource issues, you have to think creatively. And these disruptive models can be anything from taking traditional settings of these conversations and putting them into community hubs, putting them in trusted spaces, or creating virtual touch points where communication can be open and people who are there can be vulnerable and not judged. So disruptive models of transmitting information are going to be the key. One thing that we've been able to do through barbershop-based health interventions, specifically with the group that I work with, Trap Medicine, under the leadership of Jamil Lacey, is in the South Central LA area, been able to address these things through having conversations around that and then amplifying on our social media. So I say this to say, we don't have we don't have a precedent for how to address these issues. But what we do know is that the energy is there. We are familiar with tactics that work. And we do have people who are committed and devoted to making sure that Black communities are seen consistently and that the information is transmitted in a way that is equitable. And then finally, I believe that we are seeing a change in those trends. As we get numbers that Delta variant continues to increase, the intrigue of the Black community has also increased around this. You've seen young Black men, myself, Dr. Jamie Rutland, have conversations with Dr. Fauci, something that's never been done before. 2 young Black male physicians having a conversation with the world's leading expert on the pandemic, and that has impact. We've got to replicate those messages. We've got to be able to extend that, and everybody's capable of taking part in it. I'm Italo Brown, emergency physician, but most specifically, I'm a member of the community. I represent Trap Medicine, and I thank you all for coming to my talk today. All right? Take care.
All right, hello everybody. Please open your microphones, Thomas and Daniela. Thank you, Thomas. Thank you. I'm very pleased to have you here on this very interesting occasion. And I don't know if you've had an opportunity to listen to the INFODEMIC talks earlier, but they've been absolutely fascinating. And I expect we can continue that here. I'm Bill Hazeltine. I'm a scientist, been a businessman in the for-profit and not-for-profit worlds. I'm currently the chair and president of Access Health International. Tom, why don't you begin, and then we'll go around the circle. Just introduce yourself very briefly.
Great. I'm Tom Boyke. I direct the Global Health Program at the Council on Foreign Relations. I also teach at Georgetown, and it's my great pleasure to be here with this group.
All right. Next up is Daniela.
Hi, it is such a pleasure to be here. Thank you so much for inviting me and hosting this wonderful conference. My name is Danielle Pasha. I'm currently research staff at the Hastings Center, a bioethics think tank, where I work on several different projects, but one that's particularly salient for this conference is one that is exploring community health centers in the United States and how they are dealing with access and attitudes for COVID vaccines.
Right, and Lisa?
Hi, everyone. And it's also an absolute pleasure to join you all for these discussions. So I'm with WHO in Geneva at headquarters, and I lead our work on vaccine acceptance and uptake, which concerns looking at all the behavioral and social drivers that contribute to confidence and coverage of vaccines around the world. Thank you very much.
And all of our expertise is a bit tangential to the actual talk, the title of the talk, which is global equity. It's a concern for all of us. I think it's very clear that everyone in the world is pretty much in the same boat when it comes to the issues of what the virus, SARS-CoV-2, can do. Some countries have responded, let me put it this way, countries have responded very, very differently. But one of the most salient questions today is on vaccine equity. We've heard talks and discussion of equity within countries. Now we're focusing on equity between countries. And what are some of the issues? And I will serve as a moderator. I may make some comments as we go along, but I'd like the bulk of the discussion to be carried by you three. And let's start in reverse order, because WHO has taken a pretty definite position on the issues related to the vaccine availability, and in particular, in recent days, the recommendation in some countries and practice in some countries to make third boosters available to some or all of their citizens. So, Lisa, why don't you begin with that? And if you have any time you'd like to intervene, just raise your hand so I can see it, and I'll be happy to recognize your intervention. Lisa?
Yeah, thank you so much, Bill, for kicking it off and the question. So to start with, just to say that we know that a global approach to vaccination is morally the right thing to do, and it's scientifically right as well. And we know that in places where there's going to be uncontrollable virus spread, the virus will have opportunities to generate more diversity and trigger the evolution of viruses that are much worse, more contagious, more transmissible, more virulent than we have already today. So we need a global approach to be able to ensure an equitable distribution of vaccines around the world. And so far, globally, we know that there's been about 4.8 billion COVID vaccine doses that have been delivered worldwide to date. But the challenge is that only about 75% of those vaccines have gone to 10 countries. Those are the 10 generally most high income, the wealthiest countries around the world. And for example, the converse of that is that in Africa, for example, We have less than 2% of the continent's population that have received even a first dose. Less than 2%. So we have a grotesque inequity in the distribution of vaccines around the world, and that is in no one's interest when it comes to stopping this pandemic. So I'll leave it there and hear from other panelists for their thoughts on the matter, and there'll be much more to explore on this as we go, I'm sure.
Daniela, you want to pick it up from there?
Yeah, I think all of those thoughts are well heard. I think they were beautifully encapsulated. I think something I would add is, now that the Biden administration is really supporting the use of boosters in the United States, I think it just underscores this idea of complete inequity on a global scale, of people in the United States getting these booster shots so they don't have as bad of a reaction to COVID-19 infection, while there are literally health providers in several countries that don't have their first dose. And secondly, I want to mention the TRIPS waiver discussions and just how the United States and other countries can help build capacity to make sure that other countries can start making their own vaccines, distributing their own vaccines, and really building that infrastructure up so it's sustainable change, God forbid, if another pandemic happens. So this global inequity is happening, I think, on two levels. One, just the rote distribution of vaccines has been completely inequitable, but also knowledge sharing, infrastructure sharing has also been quite inequitable, as we've seen.
Tom?
Great. Thank you for the good question, and thank you for the good discussion so far. So Isaac Asimov has a great quote that science gathers knowledge faster than society gathers wisdom. And I'm afraid that's very much what we've seen with regard to the global vaccination campaign. It's been remarkable how quickly they were developed in under a year, which, the previous record had been 4 years to develop a novel vaccine from sequence. It's remarkable how many doses we've produced and administered. So by today's numbers, it's actually, we just surpassed 5 billion globally. And a lot of people considered 5 billion in a year a stretch goal heading into once we had the approvals or authorization rather of these vaccines. It's remarkable that we've been able to do that, but the speakers have been right. We 3 out of every 4 of those doses have gone to just 10 countries, and that's problematic. It's problematic for a couple of reasons. Certainly, well, the first is that ultimately the purpose of these vaccines should be preventing unnecessary harm, and most notably death. And where these vaccines have gone have not been the countries at the greatest risk. So it's, on one hand, not surprising that high-income countries have used more than their share, considering they also account for 43% of the cases. But you've had vaccines not going to places that have had high burdens of cases and are considered high risk of surges moving forward, and notably Southern Africa, non-EU, Eastern European and Central European states, Middle East and North Africa, and parts of Latin and Central America, not only have suffered high numbers of cases and been under-vaccinated, they are forecast to continue to do so. So that's been a real challenge. But in terms of moving forward with what we want to see, the previous speaker mentioned, the next pandemic. The second problem that we see from this is this lack of equity in how this has proceeded undermines the amount of the international cooperation we need to see to make progress in the later stages of this pandemic and future ones. So it's bad in terms of what we've been able to do in terms of getting the public health benefit of all that science has wrought here. Also bad in terms of making us safer in the later stages of this pandemic and in the future.
Well, thank you all for that. I think you've done a great job of outlining the current situation. Let's dig a little deeper. And I'll go in the same order to discuss why this has happened. What are the underlying causes for this? We'll then go on to discuss some things we may do to change some of those underlying causes. But first, what we can do in the meantime. But I'd like your thoughts on why you think this has happened.
Well, yeah, thank you. And it's great to really take a closer look at some of these underlying factors. And I think that at a global level, we've seen the problem that high-income countries have ordered high volumes of doses and volumes that go far beyond the needs of their population. They've essentially over-ordered doses of multiple vaccine options. They've also essentially hoarded them, restricted exports, and not adequately shared them with other countries. And Danielle referred to TRIPS. And we've seen also some high-income countries, not all, but some high-income countries oppose certain calls for these IP rights to be temporarily waived. So there's, at many levels, been inadequate sharing of the vaccines and the IP that goes behind them. And the mix of these different factors has led to this situation. I have to recognize that there have been some wealthier countries that have contributed to sharing or donating the doses that they have purchased and contributed to allocating those doses to lower income countries. But proportionally, that has been inadequate up until this point in time. So there have been some areas of progress here, but still not enough to really make a difference in this overall picture.
Danielle?
Yeah, and just to zoom in, I guess, on more a national scale, I think Dr. Brown, the previous speaker, spoke to this really well, and it's the fact that while the United States has all of these doses, they're still not being distributed in an equitable manner. You have some states like California that have very specific targeted campaigns at low-income counties where they said, we're going to give 40% of our shares to low-income counties. However, in other states, there's no such plan. And so you'll find that a lot of higher income people are able to navigate the vaccine search engines and are able to find those vaccines much easier than lower income people.
But Danielle, I'd like you to focus on the international aspect.
Yeah. Okay, that's
on the inequities within country, but this is really a different topic. What is at the root of what you've all described is unequal distribution of the current vaccines? What are the causes that you see for that?
Yeah, I mean, I think in short, it's a bit of nationalism. I think it's hard for us to have compassion. I think, there's a lot of psychological blocks, I think, for having compassion for people in outside countries that aren't our own, especially in wealthier countries, where I think a lot of people in the United States and other wealthier countries have been conditioned to put their country first. I mean, this was a huge slogan in the past presidency in the United States for people to constantly say, America first. And so for people to, have that immediate switch during a pandemic, I think is kind of a really intense psychological barrier into to ensuring equitable vaccine access globally.
Let me probe that a little bit more. The 4 countries or the 4 areas that can produce vaccines in very large number are the United States, the UK, and some parts of Europe, India, and China. Those could all contribute equally to the distribution. So it's not just a problem in the United States. There's some other dynamic going on there. Do you have thoughts about that?
Yeah, and I guess I just mentioned the United States as a case study, as I am a citizen of the United States, but I do think it is a problem throughout all of those countries you mentioned. This idea of nationalism, when, as has been mentioned throughout this conference, this virus doesn't, carry a passport or anything like that. It serves in our best interest to make sure these vaccines are donated equitably on an international scale, but truly, I use the United States as a case study because I do think that it's a recurring problem across nation states.
Tom, I know you've thought about this issue, but there's another side to the issue. One of it is, of course, the distribution, and that it's a problem of many countries. But on the other hand, at least at the beginning, it seemed like there's almost going to be a diplomatic war on the topic of who could give more vaccines. Could the Chinese be advancing their geopolitical purposes by providing countries with vaccines? Shouldn't the U.S. catch up? Shouldn't Europe catch up? It was actually an unusual situation. So I'd like you to address both issues. First, what you think the cause might be for this, and second of all, what's happened to the diplomatic war for giving away the most vaccines?
Great. Good questions and good discussion. So on the cause side, I think people need to acknowledge that in nearly every other global health crisis in which there's been scarce supplies of a medical intervention that would make a difference, wealthy nations have hoarded it. It is not a surprise that we've had hoarding in this case. In fact, the opposite. If we had managed to overcome those impulses, would have been more of a surprise. And I don't think we had the systems set up that were capable of doing it in two regards. I think it's remarkable what occurred with COVAX. To build it on the fly at the same time that you're trying to get it to reverse what is a historical trend. At this point, I think, I'll have to look at the exact number, but I think it's roughly 230 million doses COVAX has delivered so far. My colleague or co-speaker from the WHO will correct me if I've gotten that wrong, but I think that's about right. We're still a year since authorization. That is faster, certainly than what we saw with antiretroviral drugs around HIV, faster than what we've seen in other instances with novel drugs. Where I think COVAX had bet on was that it had a larger portfolio of vaccines, and therefore wealthy countries would rely on it as a hedge, that they would be left out of the vaccine race by betting on the wrong horse. But what happened instead was wealthy countries bought a portfolio of vaccines, which not only locked up capacity, but starved COVAX of resources it needed to be able to lock up those supplies. So this gets to the two challenges COVAX wasn't able to overcome. One was money. My good friend and colleague Nikki Lurie likes to say that you can't pass around a tin cup in a crisis. COVAX was very much in that situation of being starved with resources when they might have made a difference. The second is that countries hoarded. That's not a surprise. They hoarded earlier in the pandemic. They hoarded PPE, masks and protective equipment, other essential medical supplies. So therefore, we couldn't get doses out of countries. That's not just a US or European phenomenon. It's occurred with India and a host of other countries. With PPE and essential medical supplies, 80 nations hoarded them in the early stages of the pandemic. COVAX never had an answer to how we would stop countries from hoarding. And I think that was the other area went wrong.
Tom, let me explore that word hoarding. My memory might be a little different. But my memory is there seemed to be an acute shortage for quite a long time of PPE. And to say that the United States hoarding means you keep it but don't use it. There might be a better word than hoarding to describe a situation in which people acquire a limited resource preferentially.
Yeah.
And that is also certainly true at the beginning of the vaccine. It isn't so much they hoarded it and they kept it and didn't use it. That may be a fair description of some of the things that are happening right now. But I think a lot of the issues, and maybe let's discuss it, is limited supply. And how much is the limit in the actual supply contributed to the inequities? And is that going to change over time?
So I would say too.
Let's go in the reverse direction now, since you start, and then we'll have Lisa.
So, did you want me to start, or someone else?
Go ahead and respond directly.
So it's a fair point on the hoarding side. I would say a couple of things there. What I'm referring to are largely formal and informal export restrictions, and those were applied against governments who had purchased those supplies. So those were not supplies acquired by wealthy countries per se. Those were supplies being produced within their borders and then were not able to leave. And I consider that different than the phenomenon of buying something up and then using it for yourself and not sharing it. And when I refer to the 80 countries, it's 80 countries who did that.
Yeah.
Earlier
and even I might point out that if you look at India, there were some states, for example, that where they limited manufacturers of amphotericin to treat black fungal disease, and they forbid that drug to leave their state.
Right.
Even within the country. So people in other parts of India couldn't get the drug that was in short supply. So
yeah. So fundamentally, this is a problem because, if every country is, I'm sorry.
Go ahead.
If you have every country, assuming every other country is going to behave like a nationalist, they're going to behave like a nationalist too. The only way to overcome that is reciprocity and dependence. And unfortunately, we have countries wanting to move in the other direction, which is to be able to produce everything themselves instead of cooperating. And that is going to leave countries out that are a long way away from being in the position to be able to make vaccines or vaccine-related inputs.
Okay, Danielle, your comment on this?
Yeah, thank you so much. Could you just clarify your question really fast, just to make sure I answer it?
I might be able to do that. The question is really has to do with to what extent is limitation of supplies, and we're going to be talking about vaccines now, not PPE. To what extent is limitation in total supply responsible for the perceived inequities or the actual inequities?
Yeah, I think it's a great question. Bioethicists often joke that we would be out of our jobs if there was no resource scarcity, because it just completely confounds the process of just and fair distribution, right? Suddenly it gets really kind of difficult to divvy up things. And in what ways is it correct to divvy up these materials that everybody desperately needs? And I think that's hard enough on a domestic scale, but then when you size it up to an international scale, just as the past panelists pointed out, I mean, nationalism is a huge, huge, huge issue. People want to feel like they have a responsibility for the citizens that elected them, the citizens that are part of the same nation state as them. And that's always going to be very difficult in a resource scarce situation, especially when only a few countries hold the materials, the knowledge, and the tools to actually make these vaccines. And then they play a huge hand in ensuring that these materials are distributed equitably on a national scale. That's always just going to be so difficult with resource scarcity.
All right, and so Lisa, your take on this?
So absolutely, there are not enough vaccines, and the thing is, there's been some evolution of the variants that have played a contributing factor here, as well as the available vaccines. So rewind back to a time when AstraZeneca was starting to be used. And then we had this emergence of these very rare but severe side effects of this blood clotting disorder associated with the AstraZeneca vaccine. So there were countries globally, and COVAX was relying heavily on AstraZeneca vaccines manufactured in India. And we then hit a situation where the science on those vaccines evolved, and many of the regulatory groups around the world essentially recommended that those vaccines would only be used in adults over the age of 60, as they were weighing up the risks and benefits of those vaccines. Also considering that COVID is much more severe for those older population groups, they're much greater at risk. So there was a situation where there was a great dependency on AstraZeneca vaccines for low and middle income countries. And the ability to use those vaccines in the younger population groups, particularly also for health workers who were the frontline workers who were prioritized for vaccines to begin with, that became problematic. So the science around AstraZeneca vaccines was an initial problem. Next, we had the Delta variant, and also the Delta variant taking off in Asia and India in particular. So India was and is the major manufacturer, Serum Institute, for these AstraZeneca vaccines, and they closed the export of those vaccines. And India, enormous population, 1 billion people, and ever since February, March this year, they're no longer exporting these necessary vaccines, right? And this then has put COVAX in an incredibly difficult position and has now been relying on all of these other manufacturers. And the last factor to consider here really is Delta. And what this is doing now is that there is data showing that the available vaccines are slightly less efficacious against the Delta variant. And this is now, coming back to your original question, Bill, about the boosters. So because of this lower efficacy of the vaccines against the Delta variant, and also this consideration of these vaccines, the efficaciousness of the vaccines waning over time, this is now leading countries to consider the booster doses, right? And we're just really not at all in a position yet for that to be considered. The bottom line with the boosters as well is that there's no conclusive evidence that we have this waning over time, and that this difference in efficacy is really going to, I have to say it properly, efficacy is really going to change over time. So this all means that, we have kind of a different kind of pressure on available vaccines, and WHO has said that essentially there should be a moratorium against use of these boosters before the end of September, whilst we, continue to increase the level of coverage and availability of supply in these low-income settings in particular.
Let me make a couple of comments here. First of all, I think, Lisa, at the very beginning, there were two arguments you propounded. One is just an ethical argument. Everybody is equal in the world, and we should have equal access to protection. Second argument is, if you don't do that, you and your rich countries are going to suffer, because the viruses that they create there are going to get you over here. And so it's in your interest to make sure that everybody, those are two very strong arguments. I want to take the conversation to maybe a left turn here, or right turn. But it is, our vaccine is the answer. And it looks like, I'm a virologist, I've looked at this from the very beginning and always recognized the weakness of vaccines. This is going to be like flu, in my view. And I wrote about that. There is no such thing as herd immunity. It's a fantasy. It was a lethal fantasy for a while, and it still is in some countries. Vaccines aren't going to solve the problem entirely, any more than they solve flu. You'll need a multi-layered approach. Yeah. Take a country of 1.4 billion people that has 1,000 times less infection rate than the United States. That exists. Are we really barking up the wrong tree when we focus on vaccines rather than social control of this disease? Because that's what's worked. Vaccines, we now know, as resistance, they're limited supplies. There would be seemingly no limit to the ability of a government to help its people. There are limits, of course, because we see that in the US, but is it really the right question that we're asking? Or should we be putting our effort toward contact tracing, isolation, identification, contact tracing, isolation? Is that where we should go? Because that is what proved to be most effective. Interesting question. Let's take it from you, Tom, and go around the circle again.
Great. I'll say a couple of things. One, I think you're right that for people that have been watching this pandemic, and if the only lesson we have learned for future pandemics is we need a vaccine sooner, we haven't been paying attention. And there's no question that we do need a layered approach. I'm sure other entities are putting out strategies like this too, but USAID has in fact put out a strategy advocating for a layered approach to how it addresses the global challenges as well. That said, I think we also need to ask your question of Thailand or Vietnam or a number of countries that had done a very good job holding back the original virus, but have not been able to quite do so under the current circumstances. And I'd be nervous if I were a country that hasn't seen a lot of infection. I think it's a matter of time ultimately that you'll see this virus continue to spread. We do need vaccination. I agree with you that herd immunity is a fantasy in this instance, certainly how people have used it, but it is an incredibly effective tool at reducing severe health outcomes from this virus. And that is a tool that should be made available globally, because the countries that have just relied on the non-pharmaceutical interventions, many of them have not managed to do so successfully. Not all of them, but many of them. And that's particularly true in low and middle income countries. And again, the examples I would point out are Thailand and New Zealand, but Thailand and Vietnam, but there's certainly others.
Danielle?
Yeah, I think it's a really interesting question. And it just kind of reminds me of how messaging around COVID-19 could have been much clearer at the beginning. Like, I think it was quite obvious, or it was very probable that COVID-19 was going to become more of a flu-like thing rather than a blip in history. So I appreciate you bringing that up, but I do think that vaccines are important, especially for particularly vulnerable groups of people. It's a really great way to lessen the amount of illness, and God forbid, rates are going up in the United States and in other countries with the Delta variant, and health systems just really they can't actually take on these many patients. The ICUs are overloaded.
I find the question a little bit more for you, Lisa, which is, it's clear we need a multi-layered approach. Everybody, I think, I've published papers on something called multimodal control, COVID control, which is a 4-layered process, which includes globalization, by the way. But in the WHO messaging, it has not so much taken the Chinese example as the shining example of what humans can do to control a pandemic, even before you have a vaccine. And the question is there some more emphasis that might happen for the long run? Because the next epidemic is coming along. We may not have a vaccine so quickly. We may not have drugs so quickly, but we do have, and I created Access International with a fundamental understanding that we had solutions which nobody was using. And that people around the world don't have access because of the institutional structures. And what we've seen through this is a fundamental failing in most countries' public health services. Deep and fundamental. The way it's organized, the way it's executed. And that has been a greater failure, in my view, than the failure to distribute the vaccines equitably.
Yeah.
Almost everybody, but it's not everybody, but it's almost everybody. And Tom's point is well taken. You need a multi-layered approach. But one of the fundamental approaches, and I wonder what WHO position on that is, or what's the thinking within WHO about that?
Yeah, so that's a great point. And I think, so firstly, just to say, with vaccines, like, we're not going to be able to do it all with vaccines. We do need this multi-layered approach. We need to be testing, tracing. We need people to be wearing masks, distancing, hand washing, all of these public health and social measures at multiple levels. This is how we will start to end this pandemic. So all of these things need to take place together. Now, the next question is, what does it take to put all of this in place and to do it in a way where we're thinking about a scenario where there could be another virus, there could be the next variant of COVID, and how do we do this in a way where we really are set up for the future in a sustainable way? And WHO for a long time has been encouraging this. We've been putting various kinds of warnings out there about disease X, for example, and working to prepare countries to say, here are the pandemic preparedness systems you need to have in place, because this is inevitable. We know from history this will happen sooner or later. It will continue to happen. And I think that it comes back to parts of the discussion earlier on that, when we were talking about reasons why there's been unequal distribution of vaccines around the world. There's politics, there's the financial and economic interests, there's a societal interest, and there's complacency. And all of these things in various ways get tangled together for people to look out for their own interest, to think about the short term. And this is how we don't learn from science and from history about what needs to happen.
We have a lot of very rich things we've touched on, but let me bring up another couple. People have mentioned trips, but there's another related to what you just talked about. Not only are health systems around the world inadequate, even if you had the vaccine to use them, and there's great examples where vaccines arrived and virtually nobody got them. So that's a health system structure. But there's another warning that has been going out for the last, I've been involved in it and other people have. It's sort of like a relay race. You get tired, hand off the baton to someone else. But it is the warning that this is going to happen. And when I look around the world, I see tremendous deficits in vaccine manufacturing capacity. There are whole continents that can't even supply one country with a vaccine. And I refer to the continent of Africa and South America. They're completely deficient. It isn't that they don't have the money. It isn't they don't have the resources. They've never had the will to create that infrastructure. It isn't so hard to build a vaccine manufacturing facility. It's not that expensive, actually. If you can build a super highway, if you can build a high-rise building, you can surely build a manufacturing facility for vaccines. So the question is, can we take this problem we've got now, which is not just a question of rich countries giving away their vaccines, it's a question of who can make their own vaccines. What I'm seeing now is a lot of other countries beginning to build manufacturing capacity. I've been working with international banks to try to get them to lend the money so you can build the capacity. But one of the fundamental problems is not only are health systems intrinsically inequitable in many parts of the world, but they're not organized and we don't have the manufacturing capacity. Is there a way that we can see from getting where we are now to where for this and the next epidemic, and this is going to be going on, where we can see manufacturing facilities being built all over the world? And that's not exactly the TRIPS question, but it's pretty close to it. And Tom, you want to take that?
Sure. The short answer is I don't know. I think we will certainly try, and I think there's a lot of reason to have regional vaccine manufacturing hubs. I don't know if we're going to move to every country in the world, or if that's necessary, but I can certainly see the case for regional hubs. I think the challenges you're going to have there are a couple-fold. So there's the question, of course, of the business model and what they're going to do in non-pandemic times. There's the question of the supporting supply chain they need to have them, because one of the things that has become quite clear in this pandemic, given the delays have often not been vaccine manufacturing, they've been the supply of the inputs you need to make vaccine manufacturing, including the people. So how are you going to sustain those regionally? So all of that is a very worthwhile agenda, because Danielle is right. Anyone who's been paying attention to this pandemic, the countries that have gotten vaccines are the same ones making them, by and large.
Absolutely.
And it doesn't take a rocket scientist to draw those two lines to one another. I don't think for this particular pandemic that technology transfer, whether it happens through a trip waiver or other means, is going to be the solution, because I don't think there's enough time. The G7 talked about vaccinating 70% of the world by the end of 2022. That's far too late. We really need to be thinking March 2022, June 2022, in order to really make the headway we can. And to do that, we actually need to ramp up production in the places that have that production currently, and we need to invest in that to happen. It's frustrating that we're having that conversation, because frankly, we could have done that a long time ago, but we didn't. Right. We also need to invest in all the infrastructure needed to actually allocate, distribute, and administer doses once they have them.
Absolutely.
It's also frustrating that we are having that conversation now, because that is a non-competitive investment to wealthy countries' domestic vaccination. You could do it at the same time. It wouldn't hinder at all what is happening within wealthy countries domestically, and yet is largely not happened to the degree that it needs to.
You know, Tom, one thing that I've noticed on that last question, the distribution, is I'm sure you have done the same as I have, gone to very, very rural places. It may take you hours to get them by unusual forms of transportation. Once you get there, you find a small facility with a freezer full of vaccines and a very good registry for children's vaccines, all right? Not for adult vaccines, but for children's vaccines. That network is almost as ubiquitous as Coca-Cola and Pepsi-Cola distribution. It's really remarkable what's happened in the world for those vaccines. The question is also, it isn't that the capacity isn't actually there. It is there, it's just not used that way. And I think that's kind of a question maybe for WHO to take, for why aren't the distribution channels being used, basically the same ones, which I find to be very effective in almost all countries. And I've been way out of the way places.
Well, yeah, and I've been to some of those places too, Bill, in Asia and Africa, and it's incredible what they managed to do. Yeah, and the passion and energy and commitment of these vaccinators in incredibly difficult circumstances is really humbling. And I'm really privileged to have had those opportunities. And so what to say, though, is that within countries, and particularly for COVID vaccines, we've had to reach new target populations. We've had to reach older adults, frontline workers, and that's been the challenge, that they're not connected to immunization systems, to health systems even. The reach is just not there, and they don't have recent experiences of getting vaccinated. And so there's been a number of access and delivery related considerations that have been in various ways problematic. And I think that, you know, countries where vaccines have been available have done a remarkable job in ensuring that those vaccines have been used. And it's true, as you know, in the earlier session, we heard some discussion about hesitancy. Yes, there have been instances where people have had questions or concerns or decided to delay a little bit, but where the information, the conversations, the engagement, all of that interaction with the communities has evolved and responded, all of those barriers have been overcome. And, you know, at the end of the day, hesitancy is no longer the problem here where vaccines are available. And it's getting those delivery strategies right, the setup of those services and the reach to all of these populations, wherever they're located, and these different, adult groups that are not traditionally reached. So that has been a learning curve for programs, but I think that they've really overcome that challenge so far.
Danielle?
Yeah, I think I'll just quickly say something again, I guess, about resource scarcity. I think it's a good point that, a lot of these nations could potentially, create these vaccine manufacturing facilities, and they probably should have a long time ago. But there's always going to be an agenda, and everybody wants not to be preventative. They would rather do things that would benefit the country right then and there. So I just say all of this to say, like, hopefully after the COVID-19 pandemic, that's a lesson that can be moved forward in a lot of these nations that don't have proper vaccine manufacturing facilities. And hopefully, again, there can be knowledge sharing to help them do that as well.
Right, and I would say, I was talking to the people in the Philippines, and they dismantled their vaccine capacity in the late 90s, which they regret right at the moment. Let's use our last few minutes to get some ideas about what we could do that's positive. What can we do to overcome this? What would you like to see, Tom? Or what do you think is possible?
So I think what we need to do is set a more ambitious target and establish who's responsible and accountable for meeting it amongst the countries and institutions that have the ability to do so, and work backwards. Right now, there's not a lot of that responsibility and accountability going on. I mean, look, there are many challenges.
Who holds people accountable? What do you mean by? I can understand by saying who's responsible, but where does accountability come from?
Well, once people declare they're responsible for doing it, that in itself is source of accountability for actually achieving it, in terms of a public announcement. But right now, we're getting slow promises of donations that only a couple of countries have actually delivered on, and most recently, and that's really hurting us. But ultimately, this needs to be mapped out in the same way that it was mapped out domestically. We have an idea of how to build capacity and supply in a crisis. We've done it. The US and the UK, other countries have as well, using policy support and financing and logisticians to try to work out the process of moving this forward. We have not deployed any of that globally, and we need to do that with a more rigorous target. That is the only way this is going to happen. Otherwise, everyone's going to be sitting in a circle, shrugging their shoulders at each other.
Rachel's just appeared. Rachel, are you appearing to tell us that we're over, or do we have another 2 minutes?
We have another 2 minutes left of this panel, so I'll just welcome any final remarks now.
Yeah, that's what we're doing. That's exactly what you just interrupted. Okay, Danielle, your final remarks on this.
Yeah, thank you. I'll just say really quickly, I think there needs to be a better effort with the messaging on a more granular and individual level in these countries where vaccines are being hoarded, for lack of a better term right now. I think a lot of times people look at vaccines in a really autonomy-focused way, like I'm getting this vaccine because it helps me, when in fact, when you get a vaccine, it actually helps on a much larger scale. I think once people maybe understand that, there can be more motion and more efforts to actually ensure that there's equitable distribution across the globe. I truly think that's something that the average person doesn't quite understand yet. And it's largely because of sort of like the seatbelt metaphor that was used frequently during the beginning of the pandemic. It's not a seatbelt, it helps communities.
It's more like drunk driving regulations.
Precisely.
Okay, Lisa.
I would say two things. The first is no boosters, no use of boosters until there's better evidence, and at least for the next couple of months until we have greater coverage in low middle income settings. The second thing I would say is greater transparency around the availability of supply, the allocation and distribution, and the pricing of those vaccines and the related deals. So I think there's much greater transparency needed globally between countries and manufacturers.
Well, I want to thank you all. You've been a great panel. It's been fun to speak with you. I would say if I were to chip in my 2 bits on this, it would be everybody who can should ramp up manufacturing capacity to the max, so we don't have the ethical dilemmas that we have, and we don't have the understandable national trends that it currently exists. But I want to again thank you. I want to thank Stanford for the opportunity, and you've all been a great panel, and thank you very much.
Thank you.
Okay, Rachel, we're done.
Thank you, Bill. Yes, thank you very much. Next up, we'll be hearing from a panel of experts regarding social media companies' roles in mitigating disinformation.
All right, we are live. Hi, everybody. It is great to be here today. I am thrilled to be moderating this panel, and we are going to get started. I'm Renee DiResta. I'm the research manager at Stanford Internet Observatory, and I'm going to start by briefly introducing our panelists, and then we will dive right into a conversation. So we have Anne Merritt. Dr. Merritt is a product manager at Google Search, where she focuses on health and information quality. And then we have Brian Clark, and Brian is a senior manager in trust and safety focused on misinformation at Twitter. And then we have Aaron Berman, who's a product policy manager for misinformation at Facebook. So we have 3 platforms represented today, and I'm really looking forward to just diving right in and talking about their work to moderate and mitigate some of the false and misleading narratives that we've seen spreading around COVID, particularly given, I think, some really unique challenges that have come up earlier in this conference, but also a little bit more broadly about the challenge of handling moderation around misinformation at a time when we're still trying to learn all the facts. So a lot of really interesting questions to ask and discussions to have here on ideas like borderline content and how to think about fact-checking and moderation in a time of incomplete consensus where we're still trying to sort out the facts. So I wanted to just start right in. For those in the audience who I think maybe are not immersed in the nuances of platform moderation day in, day out, there's 2 policies I just wanted to kind of quickly call attention to and have the relevant platform representative explain them. And that is your money or your life, which I think is a really interesting framework to kind of couch this conversation. So we'll have Dr. Merritt from Google handle that one, and then remove, reduce, inform, which I think is actually kind of a foundational way of describing the policy, the options that platforms have when they're trying to think about whether to take down or throttle or put up interstitials over content to help users make sense of what's going on in the world, what the kind of most accurate information is. So maybe we can actually start with remove, reduce, inform, because it just gets at that moderation framework, and we can ask our friend from Facebook to start in with that one.
Sure. Thanks, Renee, and thanks for having me. I'm excited to be part of this conversation and this important topic. Yeah, so remove, reduce, inform in general, like at Facebook, that's a framework we think about for general content moderation, where we could remove content completely from the platform, reduce its distribution in some way such that people are less likely to see it in their feeds, or inform users in some way, such as by adding labels or warning screens or the like. I can explain briefly how we apply that philosophy to COVID-19 misinformation in particular, and I'm actually going to describe it backwards. I'll start with inform first, and then remove and reduce. So our 3-pronged strategy here for COVID misinformation is first, promoting vaccines and authoritative information. That's the inform pillar. Also removing harmful misinformation, and then addressing borderline content that could lead to vaccine hesitancy, which falls under the reduce idea. On the first part, promoting vaccines and authoritative information, I mean, Facebook is, obviously we have quite a large user base, so we've been able to direct more than 2 billion people worldwide to expert health resources through our coronavirus information center, which you can find in your Facebook app if you use Facebook. And just for some other examples, more specifically how we're informing people and getting authoritative information to people, we help people find vaccine appointments in their areas through messages and newsfeed. We help people get questions answered not only through the COVID Information Center, but also through ad impressions that we support partners on, such as facts about COVID ad campaigns. We enable social norming through profile frames. So in the United States, and I'm sure many people here have used this, more than 50% of Facebook users have seen someone that they follow use a profile frame and feed. And then in addition on informing, we're partnering with other organizations to reach low vaccination rate communities, such as with campaigns featuring Black doctors, nurses, or Spanish language campaigns. And we are using data that we're collecting in partnerships with academic institutions to judge the impact of this over time. I'll also note on the informed side, when it comes to users who have interacted with false or misleading claims, we also inform them in those situations. So just for some examples, we add labels on posts about COVID-19 and vaccines to show additional information from the WHO. When we do remove misinformation from the platform, which I'll talk about in a second, we built a tool so that we notify users who saw that misinformation before we removed it, so that they have access to the authoritative information that corrects it. So that's in a large bucket our part of our inform work here. On remove for COVID-19, we do have a policy to remove harmful misinformation related to this topic. Specifically, we remove content that has been debunked as false and leading to physical harm by public health experts related to the pandemic. So these are things like fake preventative measures, claims the virus doesn't exist, or this also includes a variety of claims about vaccines. The idea here is to remove misinformation that could lead to imminent physical harm by somebody maybe not receiving appropriate treatment or exposing themselves to the disease. So on vaccines specifically, in December last year, we started removing false claims about the vaccine, again, that fall within this category. And we've expanded the list of claims we remove about vaccines in general earlier this year in consultation with health experts. And we're continuing to make updates to these policies as trends emerge, including just this week, in fact. And we also remove pages, groups, and Instagram accounts that repeatedly violate these policies to get at those entities that might repeatedly spread this content. And then finally, the third part of the strategy, addressing borderline content, which could lead to vaccine hesitancy, which falls into the reduce area. So we do reduce the distribution of certain content about vaccines that doesn't otherwise violate our policies. And our approach here is really grounded in guidance that we've gotten from health experts that who've emphasized the idea that overcoming vaccine hesitancy really depends on people being able to ask legitimate questions about safety and efficacy and get those questions answered by trusted sources. But at the same time, we also realize that certain of this content could lead to hesitancy. So we reduce its distribution. And similarly, for content that, again, does not violate our policies, we also work with a global network of more than 80 fact-checking organizations around the world in more than 60 languages. And with these partners, when they find posts, including about COVID or vaccines, that they rate as false, we reduce their distribution. We also, this is part of our inform strategy, we add warning labels, and we make it less likely that people will see them in feed. And so that's the holistic strategy that we have of providing authoritative information or inform, removing harmful misinformation, and addressing this borderline content, which adds up to our whole strategy that ideally gets at better outcomes overall.
Thank you. I want to come back to a couple of things you said in there, but I'd love to have Anne perhaps introduce the idea of your money or your life, and then maybe Brian, for just kind of round it out. After that, perhaps we could just have you give Twitter's general rubric of how you guys are thinking about this.
That sounds great, Renee. Thanks. Very excited to be here. So delivering a high quality search experience is core to what makes Google search so helpful. And from the early days, understanding the quality of web content has been incredibly important to us. We have three key pillars when it comes to our approach to information quality and search. And the first one will touch on what Renee mentioned, YMYL. So first, we fundamentally design our ranking systems to identify information that people find useful and reliable. We recognize, however, that there are certain topics where quality is particularly important. And we call those topics at Google YMYL, or your money or your life. And these topics include a variety of subcategories that essentially encompass any web page that includes content that can affect someone's health, happiness, safety, or financial stability. So it includes things like shopping or financial transactions or information, legal matters, information about national government processes or policies, and most importantly for this conference and in the context of COVID, for health and crisis type situations. So when it comes to our ranking algorithms and when it comes to our approach to these topics, we place an even greater emphasis on factors related to expertise and trustworthiness. We've learned that sites that demonstrate authoritativeness on these topics are much less likely to publish false or misleading information. So we try to build our systems to identify signals of those characteristics so that we can continue to provide the most reliable information. Second, to complement the efforts in our ranking systems, we've developed a number of search features that help you make sense of all the information you're seeing online, but also provide direct access to information from health authorities in the case of COVID. We worked very closely with the World Health Organization and globally with national public health authorities to surface their content front and center on the search page in a more organized fashion. And then lastly, we do have specific medical policies for what can appear in some search features to make sure that what we're showing is high quality, medically accurate, and helpful. So for these features, we first and foremost design our automated ranking systems to show helpful content, but our systems aren't always perfect. And if they do fail, our enforcement team does take actions in accordance with those policies. And so for these specific Google features like knowledge panels and featured snippets, which often show up in a more prominent position on the search page, we don't allow content that contradicts or runs contrary to scientific or medical consensus and evidence-based practices. So with these three approaches, we're able to continue to improve search and really try to raise the bar on quality to deliver a trusted experience for people around the world. Since the COVID-19 outbreak, teams across Google have worked to provide quality information to help keep people safe and to provide public health scientists and medical professionals with the tools to combat the pandemic. So we've launched more than 200 new products, features, and initiatives, and we've pledged over $1 billion to assist our users, customers, and our partners around the world. In search in particular, going back to that features aspect, we've introduced a comprehensive experience for COVID-19 that provides easy access to information from health authorities alongside new data and visualizations. And we're continuing to iterate and build on that experience over time so that people can easily navigate to the resources that they need. For vaccines, we've also updated a feature which surfaces a list of authorized vaccine statistics, and more in users' locations in response to searches for specific information about COVID-19 vaccines. And then lastly, when it comes to misinformation on search, we continue to elevate the work of fact checkers in Google Search, as well as Google News and Images. We signal fact check articles in our results via dedicated tags and rich snippets that make it easy for users to understand. So that's just a bit of an overview. Thanks again, Renee.
All right, I'll talk a little bit about our approach to COVID-19 misinfo at Twitter. So first and foremost, we want to protect the integrity of the public conversation and ensure that Twitter is a place where folks can be exposed to different perspectives and engage in healthy discourse. I think our policy remediation options give us the flexibility to address a wide range of misinformation and the associated harms. And with a critical mass of expert organizations, government officials and accounts, health professionals, our goal at Twitter is to amplify those authoritative health information. Amplify authoritative health information as much as possible. So we have a wide range of enforcement options that give us that flexibility to be proportionate in our approach to combating COVID-19 misinfo. So the first thing is we remove content with the highest propensity of harm and content that may invoke deliberate conspiracy theories related to COVID-19 and COVID-19 vaccines. We also will label misleading content and provide a credible and authoritative information through curated moments. And some of the topics we cover with our curated moments would be vaccine safety, vaccine science, preventative measures, and unauthorized and unapproved treatments. With the labels, we also may prevent the tweet from being recommended and prevent users from engaging with the tweet by disabling replies, tweets, and likes. And I think that allows us to mitigate the spread while also providing those who are exposed to it with authoritative information through our labels. In addition, we also provide warning interstitials for content that may contain misleading information off-platform. And lastly, we implemented a strike policy to address users who are repeat offenders of the COVID-19 misinformation policy. Each strike accompanies escalated enforcement action with the final strike leading to permanent suspension. So another way of really just giving us the flexibility to address potential harms on the platform.
I'd love to focus in on this idea of harm. And this is a question that any or all of you can answer. How do you determine what is a harm? How are you defining that in the context of COVID? And particularly over what timeline are you thinking about that?
I can weigh in from Facebook. So as I mentioned, for our remove policies, by remove policies, when we remove content from the platform, we're basing this on a policy that we have to remove misinformation that leads to imminent physical harm. And so that's the standard we're looking at, and that's when we're doing these consultations with health experts, with the WHO. We're getting their feedback, both is the content debunked, is it false, and what is the harm that is likely to come from it. And that's the standard we use for removing misinformation.
And on this subject, particularly, we've seen so many different wild false cures, or they're originally, I remember when hydroxychloroquine became a thing, and I followed that in our work at Stanford. We looked at where that narrative originated, where these ideas about hydroxychloroquine come from. And it actually came from sort of Southeast Asia and then parts of Africa that had some familiarity with the drug and thought perhaps this was going to be a useful thing for combating COVID. And it didn't really make it into the American social media conversation until actually March, when the president started really talking about it, President Trump at the time. And one of the things that was sort of remarkable about that was the way in which this piece of information, this theory, kind of made its way around the world, and over time, even as they were finding that this was not going to be an effective treatment, unfortunately, that initial hope was not borne out. It was becoming a focus of hope in one country, even as it was as the sort of places where it had originated were beginning to move away from it for various reasons, as the scientific consensus began to show that it was ineffective. And then we saw that happen again with most recently ivermectin, but I feel like there have been 3 or 4 different ones of these. And I'm curious how you all think about moderation in that environment, particularly as you have this incomplete consensus and these narratives are global. And what is kind of seen as prevailing opinion from one group of scientists in one place maybe is not necessarily quite yet solidified at a global level.
Yeah, I'll jump in here. I think one of the ways we like to approach it, I think, from a Twitter standpoint, is really leaning on our curation team, who's able to monitor the conversation on the platform in real time and really be able to track where the discussion is going, and so that we have a good sense of like the different types of issues around it and where that's traveling, so that we have a better sense from a policy perspective, like where to start shifting our resources and where to start really understanding, the patterns associated with it. So I think, we have a huge benefit on our team that we have like such a powerful team from across the globe, who can really be able to capture that context in real time as it unfolds.
I can jump in as well on this one, Renee. I think it's been really interesting, and especially looking at this both from Google Search's perspective, but also as a clinician. We've seen the evidence and the guidance change so much over the last 18 months. And not only that, but what we've realized is that when you look at this globally, not only do national public health authorities differ in their guidance from one another, from the World Health Organization over time, but also even at the more local levels, often the guidance is different. And so I think, from the search side, we do have this medical topics policy that says when something goes against consensus, well, then we take action. But what about all of this other area where, COVID kind of threw us for a loop because information is changing. We don't have all the information. And even the national public health authorities are often trying to, create new guidance based on of the moment and of the minute research. So at least for us, I think it's really been about deepening our partnerships with these authorities and working in country to really try to understand what those different perspectives are. But it's certainly been, I think it's certainly presented really an unprecedented challenge when it comes to medical information, because it really does kind of force us to ask that question, what is medical misinformation? Or when it's evolving so rapidly, when do we actually call something, far enough at the end of a spectrum that we're comfortable saying, this fits into that category. So it's been challenging.
I'll also,
go ahead.
I was going to also jump in and say that I think, to the point about partnerships, I think, we've established a partnership with AP and Reuters exactly for this type of reason, because we'll be able to scale, that monitoring of the conversation. And I think it will provide like the context on different surfaces, whether it's trends, explore page, and prompts in our misinformation label. So I think that's been a core part of our ability to scale this as well.
One of the things I'd like to raise while we have representatives from 3 platforms all in one place is this idea of misinformation as networked, right? Particularly as a video, for example, that someone makes and posts to YouTube or Facebook. Let's use the example of Plandemic to kind of anchor it in a real example here. Highly misleading piece of content, took fact checkers about 2 days to go through the full half hour of material. In that time, 8 to 12 million views on YouTube, viral on Facebook, again, very, very quickly. We did some work looking at that, the way it traversed different groups, its hops to Twitter, the attempts to take it down kind of after the fact, as it was found to be misinformation, precipitating a whole second wave of it being reposted to kind of alt platforms like Rumble and a few of the other kind of video sharing smaller ones. How do we think about that idea of the way in which this blankets the ecosystem? And do you all at your respective companies think about those hops to other platforms? And what is that, if any, impact does that have on how you choose to moderate?
I can try to start here. I mean, the question of hops to other platforms is an interesting one, given that obviously our platforms are different. We're all independent companies, and each are unique in some ways. So we have sometimes differing or slightly different policies that meet those unique challenges. I will say on the question of content that can be spread virally. This is why we have the policies in place that we do. So where we can remove content if we find it, and we have AI systems that once we detect something that we can remove, can help us scale the impact of that. Similarly, we have AI systems that can help us predict content that we might later determine needs to be removed, or predict content that we can send to our fact-checking partners around the world, who then could rate content and reduce the distribution of it. So it's always going to be the case that no systems are perfect, and there will be their misses, but we're continually updating these over time. And I think the point that Anne mentioned earlier before is a really important one, that this is in the context of a pandemic. It's really unprecedented in terms of like the amount that guidance and information is changing so quickly. And so we're updating our systems and our policies over time to account for that. But because of that, we also look at the end at outcomes. And at least at Facebook, what we're looking at here, I don't know if I mentioned earlier that we are running what we think is actually the largest global health survey ever, in partnership with some academic institutions. And we've seen vaccine acceptance actually encouraging trends on that, at least in the US and a few other countries worldwide. So regardless of the specific content issues that can come up, we're focused on that overall outcome metric, and our systems layering up to improved outcomes over time.
Sorry, I'm muted. I think it's a really significant challenge that you all are facing. The pandemic has really shown the kind of front lines of the moderation question, particularly for the reasons we've discussed, with new emerging consensus, the global nature of it, the amount of attention that people are paying to it. I know that we're going to go to Q&A in just a minute, but I unfortunately have to drop off for a scheduling conflict, so Anne is going to moderate that. But I'd love to hear just, do you think, what learnings from the COVID specific environment do you feel are more broadly applicable as you move forward? But what kind of key learnings have you found, if any?
I think when you're dealing with sort of an issue that is a crisis that is global in nature, it's really important to make sure that you're understanding the different contexts in which these things play out. So it's not just about if you were talking about hydroxychloroquine or ivermectin, like the way in which that manifests in each place is very different, and being able to capture that and be able to really pinpoint those differences, I think, is the key to being able to do this at scale. And I think one of the things that I've learned and I take from this particular crisis is the importance of having those diverse teams and thinking about it in a diverse way, so that you are creating solutions that are tailor-made to each of the challenges that you may face across different contexts.
From the surge side, and I would imagine that that Brian and Aaron, you've seen this as well. I do feel like COVID was actually a great stress test for our existing systems in many ways, and it's pushed us and challenged us to grow and really emphasize the importance of flexibility and adaptability, as we continue to navigate the pandemic and this space, and continue to try to understand vaccine access and vaccine misinformation and how this is playing out across the globe. And I do think from the search standpoint, I can say, I do think that every day we have 15% of our searches are brand new searches that have never been done before. And so when you think about that and put that in the context of the pandemic, we really want to make sure that our automated systems are robust so that we can get people to the most relevant and reliable information, and when it comes to some of these topics that, like pandemic as an example, that kind of quickly gain attention and often will take a day or two for fact checkers to kind of chime in and get content on. I think, that's where developing the most robust systems kind of out of the gate is really the best and most scalable approach. And obviously it's not perfect, but the better we can do there, I think that the greater scale and impact we'll be able to drive.
Thank you so much for chatting with me. I know we're going to open it up to Q&A now, and I think people can just type questions in the chat, and then Anne is going to moderate this portion of the event. Thanks so much.
Great. Thank you, Renee.
Thank you, Renee.
Okay, Nia, where do you draw the line on harmful content? So this is something that I think we touched on around harm with one of Renee's earlier questions. I don't know if either of you want to take it.
Oh, go ahead, Brian.
I was going to say that it's kind of it's not a simple answer. I think it's quite complicated because I think there are different types of harms. I think earlier Aaron mentioned the idea of imminent harm, and I think when we think about imminent harm, we also take the approach of removal. But there are also, informational harms. There are things that are misleading that could eventually lead to a bad outcome. So I think our approach with labeling is to mitigate that harm through information, through authoritative and credible sourcing. So that we could address some of the potential for taking action on misinformation or bad content.
At Google, I would say, so I'm in search, but I have some visibility across the rest of the company in terms of how we think about and define harmful. There are different ways, and harmful is not misinformation versus harm. I think there's overlap there, but those are not always entirely happening together. So when it comes to our policies, you'll see that a lot of them cover harm, but also cover other types of dangerous or misinformation outside of the harm vector. And so YouTube has published their COVID-19 medical misinformation policy about a year back. And there you can actually see a list of claims very specifically related to COVID that they take action on. Google Ads has a policy that hinges quite heavily on harm. And so there, if you look into that policy, you can actually see how they define it. So there are different ways to approach this, but I think ultimately it's kind of a multi-pronged approach where harm is one vector, but there are other vectors that we need to cover as well.
Yeah, that's important, and thanks, Anne, for mentioning that. I want to flag also that Facebook as well. We've published under our help center, and we can find the link if needed, a full list of claims and policies that we have related to misinformation about COVID-19 that we remove for that imminent physical harm impact. And we've also listed our policies when I talked about content that we reduce because it could lead to vaccine hesitancy. We've listed our policies there as well. So we've listed these out online for those who are interested in learning more.
Great, Smelana, thank you. So given that social platforms deal with massive amounts of data, how effective is AI with sifting the vast majority of what constitutes misinformation?
I think, sorry to jump in here. I think from my perspective, and it's a common. It's never just AI by itself. It's never just machine learning by itself. It's like this. It's confluence, right? It's a relationship, and it's finding that right balance. There are certain contexts where human review is absolutely necessary, and it'll be able to capture that nuance. But there are things where, from whether it's detection or like things with common patterns, where AI and machine learning is incredible. And I think that human in the loop process is absolutely critical to being able to scale this. So I would always think about it not as just one tool, one instrument, but it's one tool in a larger toolbox.
Yeah, I fully agree with that. And I'll say, like, specific places where we've seen AI being particularly useful, as Briner said, like tuning our systems to try to predict content that we might later qualify for removal or for fact checking, and also to scale the impact when we do find content, and finding duplicates or very near exact duplicates of that content across platforms. We use our systems for that, and it can be very effective.
Yeah, and at Search, I'd say it's similar. It's a combination of AI with human raters. And so we work with search quality raters who measure the quality of search results on an ongoing basis for search. They are evaluating the results based on expertise, authoritativeness, and trustworthiness, that EAT or EAT that we really index heavily on for these YMYL topics. And so these ratings don't directly impact ranking, but they help us to benchmark the quality of our results on a continuous basis to ensure that they're meeting a high bar. So it's kind of always a combination of the algorithms, plus these ratings that help inform us as to how we're doing. Lola, how do you respond to the censorship narrative? I don't know if we need a little more context there, or is that enough to?
I can jump in. I mean, so at least at Facebook, our approach, and I would say our general approach in content moderation, we're always trying to balance the core value that Facebook is to enable people to express themselves freely with protecting the safety of our community and our user community. And our approach to COVID-19, is part and parcel of that balance. So, when we remove misinformation, as I've said before, it's that standard of health experts have told us that it is false and leading to imminent physical harm and is a safety risk. And that's also why we have these other approaches to balance the risks when we don't have that clear assessment from these outside experts, right? Where we can reduce the distribution of content that experts have told us could lead to vaccine hesitancy, but is important for people to engage with, where we can work with our fact-checking partners to find content to reduce its distribution and add labels, but not remove it. I think it's a broader question for social media and online communications platforms in general, that question about the right balance of all of these policies, but we're aiming to really balance that free expression and safety and those safety issues with the policies that we have.
Yeah, I think, just to piggyback off Aaron, I think it's important for us to allow discourse and debate, but we also want to create a safe environment for that to take place. So, we have different levers to pull. We have different approaches that will allow content to be left up with context or authoritative information. But ultimately, I think it's upon social media companies to be transparent as much as possible on their help center pages. We do that at Twitter to make sure that folks know exactly what we're looking to mitigate, the harms that we're looking to mitigate, and what we're looking to address, especially in the COVID-19 space.
Thanks, Brian. Yeah, and on search, I think things are perhaps a little bit different as a search engine, given that we're indexing the web and we're surfacing the content that's available. Our general approach is especially for health and other important topics like this, we need to really lean in on and show the high quality and authoritative results, both in features and also, more prominently on the search page. That's really, I think, how we best address that. Diversity is also important to us, and we want to make sure that, we're showing users not only high quality results, but also a diverse set of results so that they can, get the information that they need from different types of sources. So that's a bit from the search side. Travis, okay. Can any of you discuss the Disinformation Dozen as a case study of how your platform has or should respond to individuals responsible for significant disinformation?
I'll jump in on this one unless others would like to. This is referring to a report that 12 specific individuals are allegedly responsible for a large amount of misinformation about COVID-19. I'll say that we've looked into this, and I'm not sure that there is consensus that this is actually the case. Our look at this found that of these 12 people, their content, they were actually responsible for just 0.05% of all views of vaccine-related content on Facebook. So this includes vaccine-related posts they've shared, what's true or false, links associated with those people as well. So just to put that in context, all that said, we have taken action against these people, and we've removed over 3 dozen pages, groups, and Facebook or Instagram accounts linked to these people. We've placed restrictions on other accounts related to them as well. And this is part of our strategy of ensuring that if we find, if people are posting misinformation that violates our policies, we remove it, and we remove those pages or accounts or groups that repeatedly post that content.
Yeah, so I think, as far as the Disinformation Dozen, I think we've taken account level, enforcement action on a number of the accounts identified. And, we reviewed them, in accordance with our Twitter rules. So, if they violated our removals statute or our label statute, we enforced based on that. Several of the tweets referenced were predate our updated COVID-19 enforcement policy. And because we don't apply rules, the violations retroactively, we did not take enforcement action on the content posted prior to the expansion. But this is something that we're still keeping an eye on, and it's still important to us. So in any, if we do come across content that does violate our policy, we will enforce, in accordance with our policies.
Great, thanks. Yeah, and on the search side, I think I'm not sure specifically how search performed for this we have a case study or example. I would say that again, first we lean heavily on our ranking algorithms, but knowing that there are gaps there, our policies across Google Search, Google News, YouTube, as well as our advertising products, clearly outline types of behaviors that are prohibited. So, misrepresentation of ownership, or, a primary purpose on Google News of impersonation, or other things like that. We do have explicit policies that we act on in those instances.
Hi, everyone. I just wanted to let you know that there's about 5 minutes left in the session. So now I'll just open it up to final remarks.
Okay, I can jump in here. I think one of the things I've learned from this tackling COVID-19 misinformation at Twitter is I think the importance of trying to be innovative in the face of a crisis. And I think right now at Twitter, we have several different, pilot programs. You talk about Birdwatch, when being able to leverage the community to help with content moderation. When it comes to the way the design of our labels look, our redesigned label pilot, I think it shows like our like the sort of holistic, multi-pronged approach that you have to take in these crises to try new things, to try to tackle a very, very complex issue. So I think, one of the things that I'm really excited about with Twitter is that we're listening to users and listening to researchers and establishing those relationships and meeting users where they're at, so we can help mitigate some of the harm and help provide credible information. And I think one great example is our pilot user reporting flow. This is something that users have asked for a while. So I think we're piloting it in the U.S., South Korea, and Australia, and we'll be able to see what users have flagged as misinformation and see and give us an opportunity to zero in and take advantage of the user feedback. So I think for social media companies like us, we have to make sure that we're being innovative in the face of a crisis, especially a very complex crisis.
Yeah, I can just end by saying, first, I'm happy to be here, so I really appreciate the opportunity to participate on this panel. And I think one point that several of us raised throughout is, and that Brian just raised again, is like flexibility and the changing situation on the ground and needing to stay up with that. I think that's a really important issue, and one where we have seen the need and I think responded to be flexible over time to change our policies as the facts change and update our systems. Like one example is just the word Delta as related to coronavirus. It was not something that people probably would have thought about 8 months ago, and now is obviously a big topic of discussion. So that is one of my takeaways, and we're going to continue to apply our policies as we've in the three-pronged approach that I've laid out, but make adjustments over time as we need to. So.
I think on the Google side, I think one of the things that this pandemic really showed us was just how important all of these platforms are in a crisis like this and trying to get information out. We know that lots of our users search for health information all the time, but watching, and you can see on Google Trends, the escalation of COVID and vaccine queries over the last year, you can see that in these, in this environment, people are really trying to get the most accurate, the most up-to-date information that they can to make decisions. And so we really have an important role, as we look at this clinically, as we look at this from a public health perspective, we really have an important role in this pandemic and in this crisis. And I think it's actually been a really good thing and a great thing to see a lot of teams across our organization come together and work together on this. One thing I'll just highlight, I had seen some of the comments in the conference chat that you may want to look at is there was recently a paper that was published by the National Academy of Medicine. It was an expert panel that convened and basically published some guiding principles on identifying credible online health sources. And the paper is called Identifying Credible Sources of Health Information in Social Media, Principles and Attributes. It was recently published about a month ago. It's on the website at Google and YouTube, and you may want to check it out just to kind of see where we're at in terms of thinking about, what all of this means as we look ahead for, the next crisis.
Thank you once again. This is a great panel discussion. Next up, we will be hearing from Dr. Vin Gupta, who is a pulmonary critical care physician at the University of Washington, about the power of physician influencers on social media. Thank you once again.
Hello, everybody. Good afternoon or good evening for those of you maybe zooming in from a different country across the pond. It's great to be here, and I just really appreciate the privilege of being able to spend the next 15 or so minutes. I'll keep an eye on the clock so I don't exceed my time here. Talking about a topic that means a lot to me and that I've become more and more immersed in, which is what does effective communication look like, and how can we leverage all media, all different mediums in an effective way, and to better amplify the right information, and to really pick up on some of the themes that was discussed on just the prior panel here. I'm going to try to just talk about what best practices I've seen in my 20 or so months in various public platforms since the beginning of this pandemic, trying to dive into what's worked, what's not, when we really think about cutting through the noise and trying to have as much impact as possible. And so number one, I would say that more than anything, whether it's using Twitter, Facebook, any other popular social media platform, more than anything, I found that using these platforms to tell stories through videos, through Twitter threads, for example, has been really effective. And what I've tended to do is to share stories directly from the intensive care unit, or when I deploy as an officer in the Air Force, we've deployed our team, our reserve team consists of many ICU providers, respiratory therapists, nurses, and docs. So we've been scattered across the country during select times over the last 20 months. And what we'll do is we'll try to take moments from those experiences that are, of course, not violating HIPAA, but to prove a point or to help get a point across that's transmitted through visuals, through graphics, and not necessarily through words or opinions. In that way, what you're doing is, in my view, you're making it less about you and your specific opinion or the clickbaity nature of any tweet, which often some of the tweets that get a lot of attention are those where you're actually communicating an opinion. I think what cuts through some of the partisanship, some of the exhaustion with COVID is actually just sharing real life stories. And we're seeing a lot more of that now to great effect, especially with the rise of the Delta variant, with people feeling more and more vulnerable. You're seeing news media directly going in intensive care units to speak about the plight of the unvaccinated. And I think they're picking up on trends and on tactics that has worked powerfully well in other public health movements. And I speak as a pulmonologist. I've always been sort of surprised that we haven't leaned in more heavily on tactics that we used really effectively during the anti-smoking campaign to help convince more people to get vaccinated. And so again, to emphasize what worked previously, it was graphic images, lungs ravaged by smoking, lungs that are otherwise healthy, that side-by-side comparison. Obviously, we did something similar when you think about the egg frying on a fryer on any stove as a surrogate for what happens when your brain is on drugs. I mean, those are powerful ways to communicate a simple message, again, less through written word or spoken word and just through a visualization. And I think we've underutilized that tactic up until now. Now it's gaining more steam, but that has been an effective way to utilize social media, in my view, and something that I lean into as a physician, as a policymaker, and some of my other non-clinical roles, to help get the point across that if you're unvaccinated, regardless of whether you're 80 or 18, that you're at 25 times increased risk of ending up in the hospital and having lungs like those of my patients that I've cared for. And I've pinned a tweet to that effect. I wish I could share my screen because I show you something that really convinced me that the ways in which people consume information has fundamentally changed over the course of many years, but especially over the last 20 months. Is this tweet I like to show people where it's a comparison of the most viewed article in the New England Journal of Medicine about COVID-19 and a tweet I shared a few months ago is lungs with COVID, lungs without, from a patient of mine that sadly died in August of 2020 with COVID. It's really just a high resolution photo, lungs with COVID, lungs without. It was viewed 5.5 million times when I shared that, when I created this tweet. Comparing that level of engagement with just a simple graphic to the level of engagement and views on the most viewed article on the New England Journal of Medicine to date on COVID-19, which got about 1.5 million views. It's nothing to say about my tweet. There's many people who tweet out there who get a lot of engagement, far more than 5.5 million views. But the point is that people consume information differently now. I don't need to tell anybody listening in on this panel that that's reality, but how we leverage that power and that opportunity can matter when it comes to increasing engagement. Because I think much of academia, sadly, does not still engage with social media in an effective way. It's not something that we get taught about. We don't taught how to communicate to mass audiences in medical school or in public health school, unless you go out and seek out communication classes. I got an MPA, so I sought out this type of training very intentionally many years ago. But what I've noticed is that this is not a part of any curriculum. And there's many trainees I've been approached by over the course of the last several years saying, you know what, doc, I want a career in health policy or health advocacy or that intersection of data technology and information, public health education. I mean, you can imagine many different career paths that have some of these intersecting themes and focus areas. And it's only going to go more and more interesting and more diverse in the years and decades ahead. And yet we do not have a training pipeline to share best practices because we're developing those best practices in real time. But number one, storytelling. Again, threads on Twitter, videos, graphics. What I tend to do is if I have something that really sticks, like that tweet of lungs with and without COVID, I'll amplify it whenever I'm in my analyst role for NBC News. So that there's that dual amplification. What works if I do a segment that I feel really has traction or resonance on TV, which can reach many eyeballs, to share that segment then on social media to try to basically exert the impact or to leverage the impact of multiple forms of media to their greatest extent. And I think we can continue to do more of that. I think about just the segment I did with Wes Ely, who's an icon in pulmonary critical care medicine out in Vanderbilt, about visitation policies and how devastating they are for families and for patients when it comes to getting better in the ICU, and how we have restricted visitation policies that don't make sense in this era of very effective vaccines and great PPE, that we need patients at the bed, patients' families at the bedside of their loved ones that are struggling, because it can help with delirium. It can help with ultimately end outcomes like ventilator liberation and coming out of the ICU. Well, we gave voice to this issue through a segment that I worked on with my colleagues at the NBC medical unit. And I'm not sure how many people actually saw it, but then we shared it multiple times on Twitter and on Facebook, other mediums, and then it was viewed multiple more times. So amplification of just good content, high quality content across multiple mediums, makes it less about you and more about the content, and I think has a chance at engaging people. I'll also say, I know I'm already coming up here in 7 minutes left here, that actionable advice, not clickbait, is vital in gaining trust. At least that's what I've realized. That to be able to cross over and talk to people who may not necessarily agree with what they think your political views may be. Not that I ever try to be overtly political whenever I'm in public, but staying away from clickbait stuff, moving more towards these are the things that you can do to keep your family and your loved ones safe. Like, for example, I think about getting the word out on monoclonal antibodies, addressing information asymmetries when on something that could potentially be life-saving. I'm not saying it's a cure-all, but the big issue with monoclonals, especially back in January during the worst peak of this virus for the US, was people didn't know how to access the darn thing. And so I think it falls on all of us that have platforms that people trust. To further build that trust, people will say, wow, they're trying to just give us information in a nonpartisan way that can help us, because there's so many information asymmetries that exist out there. The process by which one can even access monoclonal antibody is actually kind of patently ridiculous, if you think about it. They have to go to a website, they have to type in their address, they have to make many phone calls, they have to know that they've pre-vetted themselves for meeting several criteria. We have to break down those barriers. But I think when people see that we're trying to do that through actionable advice on social media or on other media mediums, That builds trust. That shows that our heart is in the right place. I'll also say that I've used social media platforms, other platforms, just for idea generation. For example, just in the last few days, one of the topics that's become really top of mind for critical care providers and other policymakers is, well, do we really need to think about rationing care to interventions like ECMO or dialysis or even staffed ICU beds based on vaccination status? Because turns out there's more than just COVID filling up ICUs, and hard decisions need to get made. And do we start triaging based on vaccine status? It's something that we've been talking. I'm not saying that we were the first ones to talk about this, but this is something that I do believe utilizing social media platforms and other vehicles to idea generate can be really useful. Ways to expand monoclonal access to monoclonal antibodies, different ways to brand market the purpose of vaccines. The thing that drives me crazy is that many media outlets, frankly, members of the Biden administration, continue to perseverate on the fact that the vaccines are not 100% effective at preventing infection. Versus even 9 months out, when I got the vaccine 9 months ago, healthcare workers like myself remain durably protected, if you're otherwise healthy, less than 65, from hospitalization. We can't even get the simple message on the purpose of vaccination correct. So setting the record straight. Why do you get vaccinated? It's not about preventing a positive test. It's about keeping you out of the hospital. And ways to concisely convey that through graphics, through storytelling. This idea generation paradigm, I think you're going to see that being built out, being more heavily invested in, so we can develop best practices. I hope I can work with many of you that are zooming into this call. So maybe we can develop a community of individuals that can develop these best practices for the next generation. I'll also just say, very quickly, what do you call out, engage with, and what do you not? I recently called out the governor of Texas for what I thought was his willingness to govern his own health and his own body and his own welfare in a very science-based approach. Triple vaccinated, got monoclonals, was asymptomatic, did a wonderful job caring for himself. What does he do for the people of Texas? Nothing even remotely approaching a science-based approach. Actively prohibiting things like mask mandates in schools. Doesn't make any sense. It's hypocritical. What you do and what you do not call out, I think, is important because it's going to affect your reputation and credibility. If you're constantly doing it, you're going to be viewed as somebody that's just adding to noise. But if you do it tactically, I think it's important and can actually elevate you. Something that you're willing to call things out and you're not too cautious. I think often people in our profession, especially on the academic side, err on the side of being too cautious, end up saying nothing meaningful in public domains, end up qualifying everything. And the person on the other side of the screen has no idea what they just said. We have to show the courage of our convictions sometimes. Again, I've talked about providing actionable advice, not clickbait. And lastly, I'll say in just the 90 seconds I have left here, accountability for misinformation and governance structures in the social media space and TV writ large. I recognize the distinguished panel that preceded me was talking about that. Those governance structures need to be clearer. We need to hold physicians, I'll just talk about my own ilk, more accountable if they're willingly putting out nonsense information to the public domain. I love what I've seen the Federation of state licensing boards do recently, saying that you are at risk of losing your medical license if you're trafficking in misinformation, whether it's in the social media space or otherwise. That's a great move there. We need deterrence. And lastly, I'll just say we need to invest in communication programs and other media literacy efforts for our younger professionals who are coming up the ranks, public health schools, medical schools, because this is going to be the great challenge of our times. How do we communicate to the public? The public is demanding better communication from all of us. What are best practices? How can we teach it? Because we can all be better. So with that, I will defer back to Rachel, and I just want to be mindful of my time here. Thank you so much. I hope folks will reach out, and I'm looking forward to building community together.
What's up, everybody?
Hey, how are y'all?
How are you guys? Nice to meet you guys. I mean, at least face to face.
Yeah.
Yeah, we've been all, I think, connected on social media and just heard some awesome words from Dr. Gupta. A lot of points I wish we had a long time to discuss. I'm really glad he discussed those topics.
I'm glad he discussed those topics. I can't say that I was listening to every single one. I'm in the middle of the clinic.
Go ahead.
We are live.
Mm-hmm.
Okay. All right, guys. So listen, what we're going to talk about today, obviously, is we're going to talk about whether or not social media has an influence of whether or not people are going to get vaccinated. So again, we got a couple of guests. I'll let you guys introduce yourselves. I'm Cedric Jamie Rutland. I'm a pulmonary critical care physician in Southern California.
I can go. My name is Jessica Malati Rivera. I'm an infectious disease epidemiologist and science communicator and currently at Boston Children's Hospital.
And I'm Dr. Sanjay Juneja. I'm a hematologist and medical oncologist in Southern Louisiana and the Onc Doc on social media.
What I think is interesting about the group that we have right now, we've got different aspects of the country. We've got different goggles on in terms of what's going on in terms of this pandemic. And again, the major question that I have for you guys is, do you think that social media makes an impact on educating people enough to want to get vaccinated? Jessica, what do you think?
Yes, absolutely. I have actually seen firsthand the fruit of effective science communication to transform people's minds, to bring them out of fear and into confidence about the vaccine. Everything from flu to even COVID-19 and HPV. I've seen these transformations happen right before my eyes in a wide spectrum of people, right? I've seen it happening among vaccine hesitants. I've even seen it from people who were historically anti-vaccine, which is just to tell you kind of the power of how people, the power of the platforms and the sources in which people get information, and the power of effective science communication.
Yeah, I agree. I mean, we live in a time now where people feel a lot more like proactive about wanting to learn about things and engage and be collaborative about their health rather than just, maybe 50 years ago, just this is what you need to do. And part of that kind of trust is just like the education factor. And I think that people feel more confident. People are entitled to mistrust in general across the field. Everything is, has more to be desired. So part of building that trust is with that education. And, instead of asking questions like, well, we said the vaccine, why wouldn't you get vaccinated? It's like, why would you? Let's tell you all the reasons and how this works and how, it can have a big impact on the community, people you love, and on yourself, even on a, biochemical level. And those are the blocks that way we can kind of bridge this, gap on things in the past and show and involve people in collaboration with their decisions rather than kind of just a patriarchal, this is what you need to do.
Yeah, I agree with you guys. I mean, and Jessica, your point of seeing firsthand people change their minds through the pandemic with vaccination. I know you get those messages, Dr. Juneja, I know you get those messages of people who have said, hey, I got vaccinated because of you and because of what you said. And those are great messages to receive. More than that, for social media, it provides access. It provides access for so many others to be able to get the education that they want. I always say to people, we want to teach before telling. We want to teach people the process of what it means to get infected, what it means to get vaccinated, and what we're doing before we tell them to, because they're probably going to get to the same conclusion that we all got to long ago.
Mm-hmm. Yeah, I feel very strongly that the work that we do should not be dumbing things down, right? I want to give people the benefit of the doubt that they want to understand, that they want to make these choices out of a place of knowledge. And so my goal in my education is to increase people's science literacy and to increase people's ability to discern what is good data, what is bad data, even how to read charts, because the anti-vaccine movement and misinformers are very savvy and have been able to use some of the resources that the science community has used for so long to demonstrate efficacy of things and safety of things, and they'll manipulate them. So teaching people to be discerners of that truth is much more powerful than just dumbing it down.
Agreed. Yeah. And the dangerous part is where a bit of you have a little knowledge or a bit of information, but but it can be used in either side. One thing I was confused about a lot was I don't want to get the vaccine. It's going to be encoded into my own DNA, and that makes me scared. When we know that it's viruses that get encoded in your DNA and cause problems. 95 Hodgkin's is or EBV related, head and neck cancer, several cancers are HPV. So we know the viruses do that, but somehow the knowledge of DNA, RNA, virus encoding, it somehow got swapped by saying the virus does that, when in fact it's just a blueprint to create a protein like we do all the time. So that's where that education is huge. And for me personally, all my content, you'll see anything relating to the vaccine is explaining what the statistics mean, or why they're broken down, why we need a booster with IgG versus IgM, and then it can kind of appreciate, okay, this is like foundationally where these things come from, and people deserve that and have a right to question until they have some understanding that's their bodies, and that's one way we can really facilitate that.
Yeah.
Yeah, I think one of the strategies that a lot of misinformers use is they try to weave in some truth to what they're saying and what they're presenting, in addition to increasing that production value. But then there's always this gap where they go from point A to point G. And there's always that explanation that needs to take place to explain how they got there. And I really find it also interesting that a lot of these informers aren't the ones who are directly relating to these patients on a daily basis, like we are, like we see, whether in Louisiana or California or Boston. So I really feel like, and I wanted to ask you guys this, do you really feel that we have to respond to every single video that gets put out of someone at a school board or someone at the assembly committee hearing? How do you guys feel about that?
Absolutely no. I think that if we were in a position to be constantly debunking everything, we would never sleep, because the work is truly endless. And I do think that there can be some additional harm by breathing more oxygen into these lies, giving it more airspace and giving it more time. That's why I think instead of just doing the game of whack-a-mole and debunking, which is necessary at times when things are getting pretty sticky online, front-loading social media with the good data and almost anticipating the logical fallacy traps that people are going to fall into, because we're expecting some, snake oil salesperson to come on the internet in the next week to misinterpret this reading from a clinical trial, et cetera. But it's definitely requires discernment to know which things are worth the time to break down and really debunk.
Yeah, it's important to address to a degree, because when we use the term misinformers, I like to say, like, they have information that they people believe, and they make an argument. Maybe it's naive, but I don't think there's an intention on people that are sharing to like do bad for mankind. It's more they sought out respectably information, but then when that information is extrapolated and used incorrectly, that's where there's detriment. So the strategy is one, like validate the things that are basically precipitating this say one theory, because there is some truth there, like you said, and then where the evolution of that may be problematic or not factual, to just say, oh, that does make sense, but this is why the next phase doesn't. For example, I had a comment yesterday that said, like, you're spreading misinformation. It wasn't the Pfizer that was approved, it was BioNTech, the one that they made the vaccine together, obviously, and now that it's FDA approved as a new brand name, and they were like, and plus this vaccine hasn't even been made, it just got created. And I had a whole bunch of people supporting that. I don't think they're supporting that in malice or like whatever, but they just believe that. So then my response was just very, I appreciate that actually there were two different companies that made the same vaccine, and then it has a new name only because it's now FDA approved. So again, it may be naive, but if we believe that people just want the best for people, and someone truly believes it's for some reason that it's not supported or whatnot, then to validate the concerns, take the truth that's true, that may make sense, but and then debunk that extrapolation is key. Somebody commented that saying, like, you don't have the time to talk about all the dense stuff that came to what we're talking about. And it is difficult. And that's where, social media is nice because you can break it down and have, mini series. But even something like statistics, it's a difficult field. Like med students, biostats is the thing they dread on their board exams, because you really have to have a sound appreciation for standard deviation and error and things like that. And those are things that are a little more difficult to address. But I think overall, the more factual information and the breakdown is, it has to just kind of seep into your skin. And I think we're seeing that. I'm seeing that in my clinic, where I'm in Louisiana. We're the least vaccinated state in the country for quite some time, and I'm seeing people that felt strongly one way, just learning over multiple visits, and say, hey, I want to tell you I got my first one because of all the things you broke down in the last 3 visits. Because they're usually on chemo, so it's every week or whatever, and that's really encouraging. So I extrapolate that, maybe incorrectly, to think of the population as a whole and believe that other people are doing the same.
When the pandemic first started in the beginning of 2020, and the government and the respective leaders of this country were delivering information, I want to ask you guys something. Do you think, and hindsight's 2020, but do you think that the information that they provided, do you think the way that they provided the information was the best way? Or do you think that an alternate strategy should have been done?
I'll let you take it.
I know it's hard. But I think hearing people talk about this, I think it's important.
Yeah. So I sort of misheard the first part of your question because I have a little kiddo screaming in the background. But were you asking about the administration communicating?
Yeah.
Yeah. So I have gone on the record multiple times criticizing the lack of investment in things like science communication from a federal level, especially because we provided such deep pockets, such amazing resources for Operation Warp Speed to manufacture and produce and distribute the vaccines. What was missing was a complementary vaccine communication package with that to go with each state, so that the states weren't once again kind of fending for themselves to create their own public health trust campaigns and social media campaigns and influencer campaigns. It just felt very much like how we were managing the pandemic, pretty patchwork. And so we're seeing kind of now the investment, or at least the acknowledgement, with the U.S. Surgeon General mentioning that misinformation is a public health emergency, that we need to be addressing it. But I will say that many of us in my space, especially those who've worked on vaccine science for a while, anticipated this. We knew this was going to happen, and to see it be an afterthought means that many of us are kind of doing damage control in a constant, hamster circle, it seems.
Yeah, it's challenging because, on one hand, and this was a hard thing for me to accept, but we're all somewhat narrow-minded from the healthcare industry, as far as we obviously operate with healthcare and the health of our community first. But then if we're somebody that doesn't have any healthcare, experience or background, you think economically first or financially. So having the humility to realize there are factors that I don't understand. Surely there's a more ideal way in hindsight, how something could be addressed. And then you have the problem with, what is the metric of this is bad? That varies between people. So if somebody says this is, a lot of people say it's not that bad because, the percentage of people that actually die from it are XYZ. But then you have people that had stroke. You had all these people that, we have a waiting list to get into our hospital for people that are young and dying because our ICUs are full. So there's all these metrics that can vary, and that part I think we're all very humbled by, and hopefully will continue to come out and bleed out over time, not literally, to where at least this generation or anyone involved in this realize that there's just more to it than any single metric, oh, it's not that fatal. And then I wonder sometimes, what is that threshold when people say how long it took to get approved, it wasn't studied? What is the threshold for a virus that comes in lethality or whatever your metric is, where it's bad enough to where somebody says, I need it right now, like give it to me, this is a world crisis? Because to a lot of people, including us, it was a world crisis. It is currently, it's terrible still in Louisiana, and it's it hurts. You see people that you love just overnight turning south. Clearly that's not enough to ring the alarms, even really in Louisiana, to get vaccinated, even though it's happening in our, literally in our home. So that's a curious question, is where does that switch flip to say, this is something that's really bad and I need it? And when we can appreciate people's metrics and maybe like be able to hone in on those more, then we can say like, this is why this is so important, because people vary on those metrics.
All excellent points. You know, again, as we all know, the pandemic is ongoing. And Dr. Junasia, in your state right now, I am sure that you are bombarded with a lot of clinical issues that you have to deal with on a daily basis. I want to ask you from a personal perspective, how do you deal with that pressure, and how do you use that pressure to drive your education and teaching within your practice?
Yeah, you know, it's really hard because, like you said, I mean, we have so many people that would be curative intent and their whole lives ahead of them, you know, 30s, 40s, that would be addressed properly by standard of care if they were able to get their treatments in time, get their biopsies. And they have to, it's such a burden to live with a cancer diagnosis for a family, but also have a superimposed burden of, if this weren't in 2021, maybe my son or daughter would be alive, or my spouse. Like, I hate that they're burdened on top of already something so scary with something like that. It's definitely, you know, led to, you know, I collaborate closely with Mayor Broom in Baton Rouge, and I've worked with the governor's office, because again, you have to highlight, I guess I've learned over time, like, people really, you don't know what someone doesn't know because they're not there. And so the more you can share and shed light on that, I do believe people are intrinsically good. I believe that we have, like, you know, we're just good people. Humans are good. And that the more they become aware, and you kind of, you know, probe into those empathetic cues by highlighting those problems, the mind only knows what the eyes can see. So that's kind of what I'm trying to do or share on social media. And, you know, it hurts, but you've seen a lot of things now circulating on social media of the people in the ICU saying, this is what I believe. This is the, you know, the whereabouts where I grew up in my community and how we feel about something. And now here I am. And I wish, you know, if this message reaches one person, I hope this is it to spare you from where I'm at now. And I'm very humbled by those people and the strength it takes. So I think, you know, in different fashions, all of us are just trying to show a piece of something that somebody may not see, you know, in Minnesota or wherever, and probe into that, you know, human empathy. I think that will help us, you know, work together towards something in a collaborative way.
And Jessica, for you too, you know, you have a very large social media following, nationally known. You explain a lot of difficult statistical concepts. What about that pressure on you to continue to put out content that is consistent with what you previously have done to deliver that same message? I mean, how do you deal with it on a daily basis? I heard you earlier, you know, you've got a kiddo screaming in the background. So I know that can be difficult too, kids of my own. So tell me about it.
I mean, it's not easy. And I think that there have been times when I've been working too hard and I've had to take breaks. You know, I'm thankful that I'm not doing this work alone. I know that the burden does not fall completely on my shoulders. There are so many like-minded science communicators and scientists who are on social media who are doing this work. And in many ways, we have created this kind of network of support to help each other and to kind of back each other up if it gets overwhelming or if we do need a break. But it's the work that I've been preparing for my entire career, to be completely honest. I studied emerging infectious diseases in graduate school and worked a lot on pandemic prediction. And so it really still feels like an honor of a lifetime to do this work. And I think that also having boundaries is something that I'm working on, because I know that there is this pressure to constantly produce content and constantly respond, but I can't. I have a family, I have 2 young kiddos who need me to be available. I have a spouse. I have work that I need to do throughout the day. And my mental health is a priority too. And, you know, I worked at the COVID tracking project throughout the pandemic, which was truly the best experience of my career. But that work weighed very heavily on a lot of us there too. And having real burnout from being immersed in very depressing data was a lot. So I'm very aware of the need for breaks. And I try to exercise that discipline as often as possible.
Yeah, I agree with you guys. This is such a difficult thing to do. Sorry, partners in the office. Other questions that I have for you guys is, if you could deliver one message to your audience, what would that message be?
I think by far, the message would be feel good about something, and the way you can feel good about anything when it relates to medical and health decisions, and I see that a lot with cancer and treatments and chemo and non-chemo options, is just really to learn and to educate. And now, we live in a time where we have the World Wide Web, which is good and bad because there is no of fact versus fiction. Anyone can make a statement and you wouldn't know any different. But it really does, I think, provide security. And it's corny, but the phrase education is empowerment. You get empowered with education. And I think in my case, with the vaccine and everything else, I remember when I was first giving vaccines to my first son, 5 years ago, I was nervous. I was like, oh, but I've heard that, so that was very humbling to me too, like about the human aspect and the emotional aspect, because when you're making an active decision for something versus letting the world happen in a passive sense, sometimes that can be uncomfortable. So I was also humbled because I realized I have an understanding of like statistics and data and stuff to like be able to make an informed decision, but somebody may not have those, same like biostats background. So it's challenging. There's no doubt about it. But if you seek it out and if you want to learn, there's stuff up there. You could, DM me and I can direct you to whatever. But if you're moved and you did have a change and you learn something, and then you facilitate that to the people around you that may have shared the same sentiment you did before that, taken on that journey yourself, that's how we survive as people. Every civilizations have come and gone in the past, and you read all this stuff in history. That's how we survive. Potentiate something that you have like learned with an active grind. And again, it goes back to the misinformed and misinformers. Like they're trying to do that too with something that they've like truly believe and learned. And then, but if we can continue to educate ourselves and respect one another and not antagonize, but rather address, you want to believe, fingers crossed, that we'll all together be moving in a right and healthy direction.
I agree with everything you said, Sanjay. And I would add that, I think that we are in an age where expertise is kind of a subjective term, and people just love to jump on soapboxes and opine on things that are really outside of their expertise. We've seen an emergence of armchair epidemiologists and armchair virologists and armchair every kind of expert you can imagine. And I would say in the context of social media, I would encourage, my followers to pause and to investigate, right? I think that there's a lot of power in waiting to say something before you jump on a clickbait, really intensely triggering topic, really probably outdated and not verified source. But there's power in knowing that having a moment to recognize that you're having a visceral emotional reaction to something is probably a good sign that you need to wait and read it a little bit more, because we are very aware that the pandemic itself is very frightening, and if it's not frightening to you, I would think that that was strange. But we also know that misinformation feeds on fear. And so to be able to discern, am I reacting because this is something that is so alarming and so outside of consensus that I need to know the truth and I'm being lied to? Or is this just really deeply upsetting because the situation is actually deeply upsetting and I need to look into this further? There's, I think in science, and I can say this as a member of the science community, trust science is kind of a meaningless term, and believe consensus can be kind of bullyish. And so I think that that's why we can say to folks, hey, I'm not saying to just follow us and just repeat what we're saying, but just wait before you react, wait before you spread something that could potentially be much more harmful than good.
You nailed it. I mean, that's so right. And, visceral reaction, if anyone doesn't know, that's that emotional kind of feel that jumps, the rational, feeling. And you're exactly right. We're emotional beings, and that's should be a huge checkpoint for all of us. And just like, quote unquote, misinformers, but really, as we said about where their harm may be at. On the other side, like you said, there are those that mean well, but it seems more like bullying or pressing on about why wouldn't you, and guilting someone, and that's also emotional driven as well. So the more we can remove that and just trust, the backbones of science and data and collaboration, you have to believe that we all feel more comfortable going in a direction together.
Yeah, I mean, if we're causing people to feel shame and to feel like they're being judged for not having the same kind of degrees that we have or the same kind of expertise, we're losing. We're not actually helping people. And I think that empathy, like you mentioned earlier, has to be one of the kind of undertones of the way in which we communicate and the way in which we empower people to seek this information out, because shame-based kind of motivation to seek information sends you to the darkest places of the internet.
100%.
Yeah, you guys make excellent points. As you guys know, I have to hop off. I really appreciate you guys answering the questions and participating in the pandemic and contributing in a very positive way. Not all of us get that thank you. So honestly, thank you, Jessica, so very much for everything that you provide on your social platforms and in life in general, especially as a mom. And Dr. Junasia, thank you so much for everything that you provide your patients, being in the oncology world and educating them on what they should be doing to take care of themselves. I really appreciate being here. Thank you guys for having me. I'm gonna let you guys continue the discussion, and I look forward to interacting with you guys again in the near future.
Thank you so much, Dr. Rutland, for everything you do
Take care.
have done. And I think we have 5 minutes left for any questions that people had in the comment box on the right. If y'all had something y'all wanted to discuss, either conceptually or more directed.
You know, Sanjay, something that you mentioned earlier made me think of a science communication workshop that I attended that mentioned the truth sandwich. Have you heard of this concept of helping?
I haven't.
With, you know, it's like a method in debunking where instead of it just being focusing on all the bad things, you start with the truth, you kind of state the facts, the reality, the data, the points in which you're trying to make, you recognize the misinformation and you say how incorrect it is, and then you kind of close again with a validation of what is actually true and correct sources to look at, so that you're not just spending the whole time giving the misinformer, the misinformation, whatever it is, that much airtime, but you're kind of, again, starting with the truth and ending with the truth.
Right, exactly. You're validating the points, because a lot of times they are points, and that's why, again, I don't think it's naive. Like, I think that's where somebody deep down, like, they mean well, and then that truth is there. But then, you know, from, like Dr. Rutland said, A to G, then in somewhere in there, you've the points were, you know, defunct or whatnot. Are there any good websites for information and states about the vaccines and COVID in general? I bet you can answer that better, Jessica.
There are many. In fact, it's probably not really helpful to just state them. I can type them up and put them in the comment section for the whole group later, because there's tons of really great resources, including the CDC and the FDA, who both have Q&A sections answering specifics about the detail about the vaccines.
Yeah, they both have really good details. I actually have seen some interesting articles from National Geographic, actually, that talks about it. Osmosis is a big health oriented place on YouTube. Facebook Health has a place as well where you can talk about learn about COVID more fundamentally. And there's a startup I'm with, Dr. Pedia, where we've had a lot of COVID and ID experts on YouTube. You can find them. So there's a lot of information. YouTube is really taking a big initiative, as well as Facebook, to put stuff out there, as well as many academic institutions, for sure.
Public Health Communications Collaborative just popped up in my email, actually. That's a great resource. They've got a really robust website with lots of details on the vaccines.
Yeah. This is a popular question. Oh. Well, I was going to say, there's one question, like how to deal with haters on social media, and do you guys just ignore them or provide the accurate info? You know, I get that a lot too. The question, well, haters probably too, but no, I don't call it hating. I joke, but my friends ask me that, and I think it doesn't just apply to social media, but it applies to life in general. If you're ever unsure about something, decision you're making, whether it's like relationship-wise, career, whatever, you really have to take a step back and say, like, are you operating with integrity? Like, what is the deep core aim for what you're doing? And I know, like, you know, I have 3 children and my wife's also a hemonc, so we're very busy, but I definitely feel moved to give this information that I know, and I appreciate people have kind of reinforced with, like, value, or said it's kind of changed their life in one way, with either iron deficiency and their restless legs is gone because they were on 4 meds and they saw the video. When you can do something where, as long as it's, you know, not, I believe, like, fully in vain. I told myself, if it ever becomes less about other people and then it becomes for me about numbers, this and that, and I think a lot of us, and Jessica, I'm sure you agree, are truly blessed beyond we deserve. So like that's the checkpoint for really anybody that I tell people in mentorship is like, for the most part, across the world, we're blessed beyond we deserve, especially if we're on the internet in 2022 during the day, 2021. So when you have something that seems like it's not somehow giving back, I think that's a dangerous place, both for emotional health and everything like that, because then the backbone for why you're doing it becomes less about others and more about you, and then therefore those things will hurt more because it is just about you. I don't know if that makes sense, but it's an application I've had in my life that really I think protects me more so with that stuff. How do you feel about it, Jessica?
I think we probably have different experiences with haters too. The vitriol that I am exposed to, as a woman, I think even as a different kind of mark on me is pretty horrendous. And I am grateful that there are ways to kind of create boundaries on these platforms, whether it's restricting them or blocking them or reporting them if it becomes abusive. But I have had to do that a number of times. I will say that the good absolutely outweighs the bad. The vast majority of feedback and content and questions that I get sent to me are really, really supportive. But I'm also very emotional. And, if one bad comment will stick with me for the rest of the day because it kills me to make somebody feel like I'm against them or something. But I also have to understand too, that a lot of these situations are not based from like a logical, playing ground. It's very emotional. And that's why I have said, I'm not going to I will continue to repeat myself and answer these questions over and over again, because I think that sometimes it takes that 14th time for somebody to hear it with grace and patience that these vaccines are safe, that these vaccines are effective. Yeah. So it doesn't stop me from doing my work, but it does kind of factor into like, if it gets too much, then I have to set up some more boundaries.
Yeah, it's a challenge, but you know why you're doing it. Like that's the key when you say, "Oh, big pharma, you're sellout, you're getting money every time someone gets a vaccine shot." It's like that's not the case, and
Right.
why. There's no kickback, and I hope that's something that I'm grateful for, and everyone else I'm sure is very grateful for that you do that. And the second part is it's really neat how people support you, and like I empathize a lot with some of the things you mentioned, but when people support you and on the comments and and come to your defense, it's encouraging.
Yeah.
And the third thing is you hope that people see something that's ugly, recognize something in themselves, like I don't identify with how somebody said that or how they treat, or this is foul, and they hopefully grow even collaterally. But I respect you a lot, Jessica, for that piece of it. Well, for everything.
Likewise. Yeah. So I think leading by example is a great way to show empathy on platforms, because I think that pre-COVID, even just based on elections and political drama and dissension and division that we were seeing there, people speak with a sense of impunity that they probably would never embrace if they were talking to that person in person. And refraining from name calling and shame-based language and getting into a comments war with somebody are ways that I can model how I don't tolerate that kind of behavior, but that I can also kind of be kind to people who are very different than me, if they're not being abusive, of course, and to listen and to constantly and be open to having people ask questions if they mean them well, right? So I think that some people will look at me and say like, why aren't you so mad right now? And I'm like, well, sometimes I am, but I don't think that coming off as mad and rageful in a debunk is actually very effective, at least not for me. I find that if I'm going to do it with patience, I mean, sometimes it does really get under my skin and I'll, invoke some sass, but I think that leading by example is probably the best way that I can continue to have the trust of my followers, and also make it so that people know that I'm a human, that I have feelings too. I have kids that I love and hobbies that I love. I think a lot of times people like you and I get this bad rap of like, we're just people here trying to ruin people's lives and tell them that nothing can be fun ever again. And I'm like, I miss indoor dining more than anybody probably. And I want to do it as soon as I can, but I'm not doing it because it's too high risk for me. But people think that I just hate restaurants, right? And so to engage in a way that shows people that I am also deeply affected by this pandemic, and this hurts me and my family and my, enjoyment of my life right now, I think normalizes the fact that we are not just these like bots of science.
Yeah, and on the other piece, you nailed it as far as the personal aspect. Like there are some I don't engage often. I think there's a distinction between just overt antagonism and somebody that may have like a preconceived kind of understanding or feelings about something that's a little aggressive. But a couple of times that very respectfully, I think of it as like a way like, okay, let's just get out this knot in the back. Like it's a knot that you just can't get out and stubborn. And 4 out of 5 times it's been successful eventually. And I think it's more I do that because I know other people may share the same sentiment, and then they learn just by reading it, even though they didn't put the post. So but you have to channel that very safely. But again, maybe it's naive, but I just believe people are intrinsically good. And then when you find that ground, if you're introducing with something that is met with fervent antagonism at its surface, you find something else that you do connect on. I mean, we're the same species, and there's no way, if you believe at all in evolution, that there isn't some connection that can be facilitated. And I think social media has hurt that a lot, because people do just kind of, it's one thing and on to the next rather than deep engagement. And then if you can get deeper that way, I think it's pretty constructive as well.
Yeah.
Let's see. What role do you feel industry can play in collaborating with physicians and academics in combating online information? Have you seen any good examples? I think this is where, like, honestly, social, medical influencers, whatever you want to call them, educators. I think this is where that unique niche is, and where it's something that's needed, because you have, this kind of partition in your mind. Like, these are the things that I read as far as articles and reports and news and media. And then you have this other side where it's like, okay, these are what physicians are saying through the CDC and this and that. And then you have people that are actually, like, I'm triple board certified, I'm a practicing physician, but at the same time, like, I try to make my content more fun and relatable, so it's somewhat entertaining, but then also like be a source of information as a bridge. And it's very humbling to me and my wife. Like, she would never get in front of a camera, but she's always the one who's like, oh, people really need to know about this. This is a cute way to like maybe like help people appreciate it from this angle. She is also now thinking about those things to how can we present this in a way that's fun and engaging. And that's why it's, I think, so humbling and an honor to be in the position that we're in, because we can provide something, almost a threading the needle, that people really want and need. But then the classic ways of delivery, again, are met sometimes with a little bit of antagonism, even on our parts to some degree, depending on the source, what channel somebody's citing on news. If you hear they're from Fox, some people might say, oh, I'm not going to believe at all. And then that's not fair either, right? That's the same thing, but in the other direction. So it kind of goes back to the same thing before. It's just the less we can have knee-jerk emotion, make things more relatable, it can really kind of fill that void, which is otherwise has a lot of kind of fervent magnetism, or opposite. North Pole. Yeah.
Yeah, I've seen a few good examples. I'll say even from like the industry of social media, I think the fact that some of the platforms have now created ways to report specific COVID-19 health misinformation. I think the more, specific we can get about reporting bad stuff is a good way to kind of protect the space. But I also seen like really great collaborations between big brands that are trying to elevate science communicators and doctors. The Uber did one really cool with, I participated in it to help kind of gain access, provide, more driving access to vaccination sites. I've seen, I could name a number of brands who have done that. And I think that we're seeing that more. I do think even the White House is trying to kind of do some more collaborations with people who are helping combat misinformation using subject matter experts like Dr. Fauci, doing Instagram lives with influencers to kind of help answer some questions in like 10 minutes or less. And so there are some good examples. I think, again, this is probably part of the damage control umbrella that I mentioned earlier, because had we gotten ahead of this and anticipated the kind of essential work of science communication and specifically vaccine communication in the Operation Warp Speed, so that states were prepared for these campaigns, I think it probably would have been a little bit better. Now, I will say vaccine misinformation has preceded, obviously, COVID-19 and kind of goes hand in hand with any infectious disease outbreak. So we knew it would happen, but we could have had more tools in our toolkit.
Indeed. And it's crazy. Like, I think social media is the way that that bridge happened because, I was on the Uber campaign too. I think Spike Lee was behind it as well
Yeah.
with getting education out there. And they reached out to me on social media. And then because of my social media, the mayor's office and the governor's office in Louisiana like saw, that article. So it's crazy that this actually is a platform, not just a social media platform, but a platform to bridge government and companies
Yes.
and influencers and doctors. It's just such a unique thing. I wonder if they need a degree in it because it's such a resourceful tool that we can really maximize things for communities small and big, and it's an honor to be a part of. And anyone listening to this, you're a part of it, and you have potentially a very unique way to deliver or facilitate something, even if it's not speaking in front of a camera or whatever. You obviously are a unique person, and you may have a unique way that people receive it better than anybody else. So if you're on the fence about like, I want to share this or I want to get, my thoughts out on this, but I'm not sure how, like, people have your thoughts and they need to hear those thoughts
Mhm.
and then be able to collaborate and build on it.
Mhm.
And that's the beauty of social media is you find both like-minded people, but people that are different enough to where you both grow and learn each other's points. And anyone has the capacity to do that. Yeah, so I do a lot of I try to do my education more towards like my demographics. I'll look at the demographics of the ages and male, female, etc., and talk about disease specific things. So like with anemia and iron deficiency, a lot of women are told, well, if you're having cycles, that's why you're anemic. There's nothing to do, which is just not true at all. Like you need to get an iron profile if you're iron deficient, even if you're not anemic. All the data shows you can still have marked fatigue, exhaustion, restless legs, and all these things. I have patients all the time that replete their iron and they're better. So that kind of goes into, the healthcare system has a lot left to be desired. And I don't know that it's necessarily even going in the right direction because it's so fragmented with insurance companies and pharma and all this. So unfortunately, that just means like patients do have to be proactive. And it goes back to what I said at the beginning. There's some degree of truth to mistrust, because of maybe, while we're still trying to work out the kinks is an understatement in the US at least, with the healthcare system. It needs to be collaborative. People want to be proactive with their health. And one way to do that is just to teach, somebody said you're just going to make hypochondriacs of everyone. But I've had a whole bunch of comments that say I was, iron deficient or B12 deficient, etc. And it kind of changed everything. So just get the education out there. People will trust doctors better, I think, feel more empowered about their health. And it's something that's, beautiful to see kind of unravel.
Yeah. I mean, to answer the question briefly, yes. I, plan on continuing. Well, one, I don't think COVID is getting out of the headlines anytime soon. And two, my work will be, ongoing with COVID as well. And I think that there'll still be a space for that work. But, I am a mom, and I think that in this next kind of phase of pediatric vaccines that are in the horizon, there's going to be a whole opportunity for more conversations about that. And then just in vaccines in general, just because that's what I especially love to talk about and to research. So I definitely think it'll be a primary story on my social media.
Hi, I just wanted to pop on and let you know that there's just a few minutes left of this panel. So I welcome any last remarks now.
Great. So I'm just really grateful that we had this opportunity to have this conversation. I think that, knowing that there are opportunities to have really good things happen on social media should make people feel confident that, it actually can be a great source for information. There was a Trust in Science research report that was actually done by 3M not too long ago that shocked me when their results showed that trust in science had actually increased in this last year. In a time where it seems so divisive and when it seems like the anti-science movement is growing, I do believe that there's good things happening on social media and that so much power can happen in really good content that is shared by trusted sources. So, this is a little bit out of character because I'm not usually the optimistic person, but I'm going to end with optimism.
Oh, I love that. Thank you for everything you do. And I just appreciate everyone being here and wanting to educate themselves and learn. And if you're, especially in college or younger, like you're definitely more ahead in life than I was at your age. So you're going to do great things. And now we have a platform to be able to do it and be heard and find people that just like, really constructively build you up. And I hope you use it as part of your, both professional, but even like character development, because it's something very unique that, that you can use in a productive way.
Thank you so much once again. Next up, we'll be talking about how government and religious leaders can help mitigate disinformation. Mitigate disinformation.
Thanks, Rachel.
Welcome. So thanks to everyone for coming to the COVID INFODEMIC conference put on by Stanford Emergency Medicine. I'm Dr. Matt Strelo. I am an associate professor of emergency medicine, vice chair of strategy, and the director of Stanford Emergency Medicine International. And I'm going to introduce our two guests for this panel. We have Reverend Dr. Gabriel Salguero, who is the founder of the National Latino Evangelical Coalition, which offers an important leadership voice to close to 8 million Latino evangelicals in our country. He serves on the board of directors of the National Association of Evangelicals and is a pastor in Orlando, Florida at the Gathering Place. He has been named one of the most influential Latino evangelical leaders by the Huffington Post and CNN. He's a feature writer for On Faith, and he served as an advisor to the White House on issues of immigration, healthcare, and the faith community. We're also joined by Adrian Perkins, who is the mayor of Shreveport, Louisiana. He attended West Point and was elected the first African-American class president in West Point's history. During his service, he was deployed to both Iraq and Afghanistan and was awarded the Bronze Star. Following his military service, he attended Harvard Law School. In 2018, he was elected mayor of Shreveport. Mayor Perkins was quick to act in response to the COVID-19 pandemic, utilizing technology to geolocate cases of COVID-19 in the city. Welcome, Mayor Perkins, and welcome, Reverend Salguero.
Thank you. Glad to be here.
Same. Thanks for having us.
Yeah, thanks for joining me. So let me start by asking you both a question, and maybe you can field it one at a time. But I know you've both been involved in a lot of efforts at how faith organizations and the government can combat misinformation. Can you tell us a little bit about some of the most successful efforts that you've been a part of in combating disinformation during the pandemic?
Well, Mayor Perkins, I would yield to you first if you'd like to begin.
I don't mind. The way that we're really combating disinformation out there is through relationships, honestly. If you think about it, people are bombarded with misinformation through their phones all day if they're on social media. We have some conservative radio stations here as well that put out misinformation, and they're constantly getting it. So what we're doing is not only using my platform as the mayor through our social media outlets, but also more formal outlets. We're talking about it at city council meetings. We're talking about it whenever leaders gather here, but we're really talking about it with our friends and family in our homes and at our, at gatherings that we have, and talking about why it's so important to get vaccinated and what vaccines mean. We're answering people's questions. We're being patient. It's through relationships of people that we really know. So we're not forcing anything down anyone's throat. We're just talking about the accurate information that we're getting from healthcare professionals. And we're seeing that incremental growth as far as adopting the vaccinations. We saw it as far as getting COVID tested. We saw it as far as making sure people were behaving responsibly all the way back to the beginning of quarantine. So relationships is a way that we're really combating that, a really effective way that we're combating that here.
Yeah, I think the mayor's quite right. I think it all begins and ends with relationships. I would add that partnerships are essential. So in the case of our coalition, we partner with the CDC, the Center for Disease Control, and the Office of Health and Human Services to have webinars in the target language. As you know, among Latinos, there's some historical vaccine hesitancy, and there's some historical distrust of healthcare systems because of some of the access hurdles they've had to jump. So what we've done is we've done webinars in Spanish with the CDC. We've also had, beyond the healthcare professionals and the epidemiologists, we've also had the grandmothers and the mothers who are really at the front line saying, hey, this is why I think my kids and my grandkids should do it. And then, of course, we've had Sundays where we've talked about the importance of loving your neighbor as yourself, and that vaccination is a step of loving your neighbor as yourself. And so we've had vaccine information Sundays. There is quite an avalanche, as the mayor says, of misinformation or disinformation that we have to overcome on WhatsApp, on media platforms. And so we need to partner with trusted voices, both in the medical professions, but on the local base, grandmas, barbershops, and pastors, of course.
Yeah, it's interesting. We had Italo Brown, a physician that I work with, on earlier, and I actually sought out his advice on talking to people and how to connect with people that were heavily against vaccination and masking and COVID, and were heavy into disinformation. And his response was, it's got to be a personal experience. And although the disinformation and misinformation is coming off from social media and other sources, the way that to be effective was going to be through those personal relationships. And it sounds like that's both of your experiences as well.
Absolutely.
Mayor Perkins, let me ask you, what is the responsibility of social media companies in combating misinformation? And what role does government play in regards to working with social media companies on misinformation?
Well, the current role is undefined, right? I can tell you what I wish their role would be, and I wish their role would be a lot more engaged and proactive about diffusing and neutralizing and even completely eradicating the misinformation that's online. You could see, I've seen some of the measures that they've put in place with, if there's a post about COVID-19, there'll be a little banner that'll give a warning that, hey, this could be misinformation. If you want accurate information, visit the CDC website, things of that nature. But how about we completely remove it from the equation? If you have the algorithms or even the manpower to completely search your platforms to find that, hey, this is about COVID-19, how about we build something that if somebody's putting out blatantly false information, that there is no need for a banner. You completely remove it, because whether or not that banner is there, people are still susceptible to that, especially if it's appealing to their, worser demons, or if they've heard it from, a political party or, some other trusted source that's putting out that misinformation. So I wish that social media platforms, the technology community, was a lot more engaged and active alongside us that are down here fighting it at the local level, so that we wouldn't have to put up as much of a fight, and we could all be working towards getting our community, protecting our communities as best as possible.
So do you think there's a role then for regulation of that and how that plays?
100%. There is a role for regulation. And I know, you got two ends of the political spectrum. One end doesn't believe in a lot of regulation. So I really wish that the tech community, the social media community would get together and build those regulations that are the same across the board. But like I said, I do know what I would want those regulations to look like, and I would want them to be a lot more proactive in combating misinformation and a lot more aggressive. This virus is extremely aggressive, and I think that their approach needs to be the same so that we can overcome it sooner rather than later.
Thank you. Reverend Salguero, why is it critical that faith leaders are involved in combating misinformation, and how are they being involved in these outreach campaigns?
Well, first, let me speak a little bit to this previous conversation you and the mayor were having. I think that social media platforms, as part of our democracy, have to engage in social responsibility. They are agents of our community, and there's a moral, ethical responsibility to the clientele that uses the media platforms. And so when you talk about regulation, I think that there should be much more self-regulation, and there should be much more a higher ethical. St. Augustine of Hippo, the famous African theologian of the 3rd century, says we have to seek the highest good. And part of that is social responsibility. In the democratization of social media platforms, that does not excuse us or exempt us from moral responsibility and truth telling, right? So democracy is not absent truth. You can't yell fire in a crowded theater just because you have freedom of speech. And I think that my moral call or invitation is for much more social responsibility and engagement of monitoring untruths that can lead to death or serious illness. In terms of the role of the pastor, the faith leader, the clergy person, the rabbi, the imam. Look, I as a pastor have 52 weekends a year. where I speak to people. In addition to our other platforms, we have, I hope they don't feel a captive audience, but we have a consistent audience where they trust us. We baptize their children, we marry, we bury. And so part of our social responsibility as trusted brokers is to speak the truth. I'm a Christian, and so I take from the words of Scripture, and you shall know the truth, and the truth shall set you free. And so part of that is, because we're trusted brokers, we should leverage that moral influence and platform to consistently bring the message of why vaccinations are part of our social responsibility and self-care.
Yeah, I like that lens of an ethical lens on why, companies need to act. That's always a challenge, though, when working with private companies, I think. And so finding that balance of regulation and having the ethics of the company. Mayor Perkins, what role does mistrust in government play, general mistrust in government play in the uptake of misinformation during the pandemic? Because there's been some discussion earlier today about how a general mistrust in government has potentially led to, a worsening uptake of information and a lack of trust in the government sources. And what is that role? And then how can the government potentially rebuild that trust?
Yeah, there is, especially if you talk about demographics within our society that have been historically marginalized. The number one case cited when wondering why African Americans aren't, adopting this vaccine as quickly as every other group is the Tuskegee experiment. That was a national organization that ran that experiment. But I'll tell you what's exacerbated that mistrust is the political nature of this particular virus and the politicization of this virus. It depends whether or not you're a Republican or a Democrat standing behind a podium and what you say on whether or not people actually are listening and whether or not they trust you. So now it's worse. They're not just, there's not just that normal distrust of government. You've pushed that gap even further if the person that's putting out the information isn't a part of your political party, and that's extremely unfortunate. One thing that I've done in response to that, because we have acknowledged that as well, is I've leveraged the faith community. Reverend Swagura, you couldn't have put it any better. Partnerships are extremely important. When they won't listen to an elected official, whether or not I have a D or an R behind my name, or they won't listen to one of my staff members or somebody that represents the state, they will listen to their pastors. They will listen to the grandmothers of the church. They'll listen to the mothers within the church as well. And we've had to leverage those partnerships around the community in order to create those relationships and push back on not just the disinformation, but also push back on that lack of trust between the government. That's how we've overcome that hurdle to date.
Reverend?
Yeah, look, I think that we cannot ignore, right? I think it behooves us to not ignore the historical distrust. In the African-American community, Tuskegee. In the Latino communities, the sterilization of Latina young women in the late 60s, early 70s. And so I think that if we're really going to overcome vaccine hesitancy in government and in the religion, we need to acknowledge some of these historically justifiable distrust. We also cannot ignore the distrust in institutions, mostly government. Robert Putnam, the Harvard sociologist, writes about this kind of distrust in institutions of the last 2 or 3 decades. And so we need to start to rebuild trust, number one, by addressing that health should not be a hyper-partisan or politicized issue. That whether you're a Democrat or Republican, and independent, wherever you fall on the political spectrum, whether you're disengaged politically, people's health are important. Your fellow citizens' health is important. And I think that we need much more collaboration across the political spectrum. But let me just say this. I'm a pastor, right? And I was trained as an ethicist. Courage is in high demand and low supply. But it takes courage sometimes to say, look, I know what you've heard. Independent of your political party, here are, as Dragnet would say, just the facts, ma'am, just the facts. And then people can make an informed decision. Once it becomes partisanized or hyper-politicized, it becomes almost intractable. And that's why you need the trusted partners, the grandma, the mother, the barbershop keeper to do this. And so we have to acknowledge, one, the historical justifiable incidences that created distrust. Number two, the hyper politicized nature of the conversations around health. And number three, that we need a broad coalition to reach a broad constituency around this issue, because it's life or death. It's just life or death.
Yeah. So am I hearing from both of you that you do think that religion is able to bridge the hyperpolarization in some respects, and that religion hasn't separated into its corners as well in a way that it's impossible to form that bridge or be that bridge?
I would add the adjective good religion. Right? Healthy religion. Right? Faith, like any other reality, can be co-opted, right? So faith leaders can become hyper political and hyper partisan. We're human beings. We're frail. We're fragile. And so if the pastor, if the rabbi, if the imam, if the local faith leader, clergy, priest is interested in the health of his or her community, they must resist the temptation of politicization and partisanship. And it is a very real temptation in the 21st century, in the second decade. And so it's not enough to say religion. St. James calls it good religion. Good religion, like a civil rights icon, called Good Trouble. Well, there's good religion and there's bad religion. Religion too can become an instrument of bifurcation and dichotomy and partisanship. And so we have to be good stewards of our influence to help and serve the people God has called us to serve.
I'm going to use the good reverence terminology on this and say for the good religion that we have here in Shreveport, we actually have a case of how that was leveraged to really improve the condition of our community. And it made the front page of the Washington Post. Early in the pandemic, when we were trying to figure out what was going on, everybody was trying to figure out exactly what we were dealing with. My office, we had the bright idea to geolocate where our COVID cases were. And we were able to identify the fact that it was in our high density neighborhoods. It happened to be African-American neighborhoods here in the inner city of Shreveport. So we were able to see that this was disproportionately impacting African-Americans. At the time, there was a bunch of rumors and disinformation that was out there that African-Americans were immune or not getting it as much. So we were the first people in our state and one of the first cities in the country to actually identify that this virus was disproportionately impacting communities of color, urban areas right here in Shreveport. The first thing that I did was I went to our faith community. The first call that I made, I was on a call with about 40 or 50 pastors. I brought them together and I said, hey, this is the information that we have. And we know for a fact that this is acutely affecting your congregations. I need you to help me get the messaging out so that everybody is adhering to CDC guidelines, staying away from each other, making sure they quarantine. And soon after that call and soon after my engagement with the faith community, we saw a precipitous drop in cases throughout our city. I do think that wasn't just correlation. I think there was some causation there because we went to such a trusted source. So even if they weren't listening to City Hall at the time, they were absolutely listening to the pastors that were preaching on Sundays. So that's an example of, good faith, good religion. But on the flip side, here in Louisiana, not in my particular community, there has been a lot of churches that have weaponized the political nature of this virus. And we've had church pastors make themselves, martyrs to get arrested to completely buck the governor's orders where churches shouldn't convene, still calling their entire congregations together and making a show out of it. So yeah, religion can very well be a force of good in this fight. And we've seen that here in Shreveport, and it can be a force for bad as well. And we see that throughout the state of Louisiana.
Are there clear next steps where our religious leaders and our government leaders can form partnerships and build bridges that either of you see?
Yeah, well, look, I think I'm going to highlight some best practices that I've been a part of, and I appreciate the mayor Shreveport, highlighting those good practices. I'm tempted to go to Shreveport and give him a Pentecostal hug.
I grew up Pentecostal. Come on down. We'd love to have you.
Yes. So I will say, look, we did a public service announcement together with the Ad Council, where we had African American clergy and Latino clergy because we were disproportionately impacted. And the New York Times covered it in the front page. It was shocking how much pushback we got on that. It was shocking, I always thought if I would be in the front cover in the New York Times, I would be lauded. Well, it wasn't all lauded, I assure you. And so there needs to be consistency and persistency. But I think that public service announcement with the Ad Council, and now the Pope Francis has made a public service announcement in English and Spanish talking about the positive of the vaccine. There is a weekly call with the White House and faith leaders, of which I'm a part, dealing with issues of vaccine hesitancy and other things. And then in my local jurisdiction in Orange County, Orlando, Florida, our Mayor Demings, is working with the faith leaders in creating those networks. And so there are already best practices. My encouragement to everyone who's listening and faith leaders is to build those best practices to scale. Partner with your local mayor, your local council person, partner with the CDC and HHS. There are plenty of things out there, and be consistent. Do not relent, because the disinformation is an avalanche on WhatsApp. I mean, the theories from the mark of the beast to Latinos are being tracked by the vaccine has been almost insurmountable. And so you have to be consistent, you have to be persistent, and you have to partner with those platforms that will put a megaphone to this good message of people really considering getting one of the vaccines to save their lives and the lives of the people around them.
Yeah.
We only have a couple more minutes before we'll take a few questions from the audience, but let me ask you, as we move from, and we're not there yet, or even close, but as we think to the future and when the COVID-19 crisis has passed, what are some of the commitments that we can make, or lessons that we've learned during this time that we can use to minimize health systems kind of retreating from tackling these inequities that exist within accessing general healthcare resources? Right. So I think there's been an effort now, to rephrase that, I think there's been an effort now to reach out to communities that have been underserved. And I think there's lessons that we need to take there to continue that forward, far beyond COVID-19. And so I'm wondering if you could take a moment and talk about some of those lessons you've learned, and maybe some ways you could see us, continuing those efforts.
Yeah, I'll say that if anything, we've learned from this particular virus and the way that it really preys on the comorbidities that already existed in our communities, especially the marginalized communities. Louisiana is nowhere near the top. As a matter of fact, we're at the bottom when it came to healthy states in the country. So it made us even more susceptible, our citizens even more susceptible of getting really sick. So if you think about, hey, the vaccinations is a way to protect us from this particular virus, we have to think in larger terms to say, hey, general health care and general health is a way to protect us from future viruses as well. We can't just say we want our community to survive this particular pandemic, but then not take the necessary steps to protect them in the future from other pandemics or other threats in general. So I think this has been a lesson learned to say, hey, just accepting these massive health disparities in neighborhoods, whether it's by racial or socioeconomic status, should be unacceptable to all of us, because you are setting them up for failure in the future just in case we experience something like this, or in general. Nobody should be put to that kind of faith because of what neighborhood they grew up in. So I think that this virus, unfortunately, has shown us some good things about the way that we need to move forward, and not just the bad side of this virus. And we're grateful for it here. And I know that our Louisiana Department of Health has been taking note as well. So I hope to see things like the Affordable Care Act strengthened as we move forward, so that everybody in America can have the opportunity to get affordable, accessible health care. And we don't have those comorbidities that exist, again, because of the neighborhood that you grow in. So I think there are some broader lessons to be learned here.
No, I think that's absolutely correct. there are historical chasms on issues of access to quality healthcare, dealing with pre-existing conditions and comorbidities. I was on a call with the Advent healthcare system in our state with the chief medical officer. And one of the questions is, what are the lessons learned for economically disadvantaged and racial ethnic minorities that have historically had challenges to access? It's not just about healthcare, it's about access to quality healthcare. And we have to move beyond, in what my estimation is kind of just token events of a clinic once every 3 years in our communities. There has to be kind of a interstitial systemic response, including deep and sustained conversations with insurance companies, with broad healthcare systems, with telehealth, because our communities are part of the digital divide, part of the economic, right, including pharmaceutical deserts and hospital deserts in certain communities where people have to drive and get on a bus for 40 minutes to get to a quality healthcare. And so if we've learned anything from COVID, and I'm sure we've learned a lot, one of the things is we have to deal with quality access to healthcare that is systemic, including payment, the cost of healthcare, access, and the communities we serve having that those access points more easily attainable.
I want to make sure I give some time. We only have a couple minutes left for if anybody in the audience wants to ask any questions of Mayor Perkins and Reverend Saguero. So while we're waiting,
I'll make a quick comment about while we wait. Just a quick comment, Reverend. You hit that mark on the head about doing a health clinic in our disadvantaged neighborhoods every 3 years. That adds to the distrust as well. Let's be clear. That will build on itself over time to where if they don't see the healthcare systems in your community, but once every couple of years, and then this pandemic breaks out and they start seeing very unfamiliar faces flooding their neighborhoods, asking them to take a vaccine, that's not going to bode well for a lot of people. So yet again, that's another lesson that we need to learn. This isn't a distrust that just sprouted up because of this particular thing. We have been systemically putting those seeds of doubt into our communities for some time now.
Do you both think that the focus on public health infrastructure and funding, healthcare access in our communities and equity of access will improve the appetite in this country for expanding healthcare services and increasing healthcare coverage?
My prayer is that it will. I am concerned that oftentimes when we have these ambitious projects, a certain segment, usually middle class, upper middle class, but the poor or the extremely poor are cut out of that. And so we often have these conversations. I'm a pastor, right? And so I always think about who is the most vulnerable, right? And often in these conversations, these help some access for middle class, but those who are really below the poverty line don't have it. And so I pray that it does, but I do pray that those who are below the poverty line, who are really barely making it, are able to benefit from these ambitious and I hope noble initiatives.
And I'd second that. I pray about it as well. I hope so as well. It would just be even a greater tragedy if we don't take the experiences that we've learned over the last year and a half and we don't invest those lessons learned into a better future for all of our citizens. It has been some very rough lessons. We need to make sure that we are setting up our future, the children of the future, the society of the future for success, and don't allow them to repeat some of the same mistakes that we did.
Thank you both. There is a question in the chat. Do I have time, Rachel, for a question in the chat?
Sure, yeah, one question.
How can we as physicians engage with religious and government leaders in a way that's productive and effective?
Well, I think number one, thank you for that question, we, the physicians. I think that number one is we really need to do a lot of work about physicians having a much more openness to religious leaders. All right. I think there are some presuppositions and assumptions about religious leaders that were anti-medicine, anti-science. Some of those justifiable, because there have been some leaders who've been anti-medicine and but that there are so many religious leaders who are pro-medicine, who want to partner with physicians, but there has to be intentionality. Those healthcare systems should go to the religious organizations, and most cities have interfaith councils and seek to have conversations with them. They have clergy associations and have that conversation with those clergy who are really, really allies in this fight for health and access.
Yeah, and I'll speak on behalf of government. I can tell you Shreveport, Louisiana is a case study on this partnership between government and the physicians. One of the largest parts of our economy is our healthcare system here, and our healthcare system has been right there alongside me from the beginning of this pandemic, marching forward. Not just the healthcare leadership and the administrators, but also the doctors, the nurses, you name it. Anytime we had a community event where we were putting out information and we were doing COVID testing, the doctors, the nurses were right there on the front line. Anytime we've had community events where we've encouraged the vaccine, we just did that. We were one of the first cities in the country to do the $100 giveaway for that. I was talking to doctors, nurses at the site. I was talking to medical school students at the site. So the physicians here in Shreveport, they have very much come together right beside government, and we have been working in lockstep moving forward. They are the healthcare experts. They're continually providing us with the necessary and the most up-to-date information. We have a medical school here in LSU Medical School, and we have LSU Health Sciences that actually participated in the trials for the for the vaccine. So I can brag about my community all day, but we wouldn't have made the progress that we made without that partnership, that very close bond between government, elected officials, and the physicians. So thank you all for your service as well, jumping into this career that's very dangerous right now. But we need you, communities need you, this country needs you. So thank you all for what you do.
Mayor and Reverend, thank you for joining us at the INFODEMIC conference, and we really appreciate both you joining us, but also your leadership during this pandemic.
Thank you.
All right, thank you.
Yes, thank you again. And next we will discuss the ethical imperatives that social media companies and physician influencers have to act.
Hello, I think we are live. Nancy, are you here?
I am.
Hey.
Hey. Hey.
How you doing?
So Travis, nudged me to actually look at the questions we were asked to prepare, which was good of him, very thorough. And then Art and I had a sidebar about did we actually buy some of these things? So I've kind of reworded the questions so that you can both lift up things you talk about all the time around these issues. And if there are some things that maybe that are wrong in the premises of the question, we don't have to keep them going, you know? And then I added a couple of questions at the end. I think that they've asked me to be the moderator. Whatever. So I also said, since you both direct bioethics programs, I think it would be good, to just at the end to say, what are you doing differently in terms of how you're framing the teaching and learning in bioethics and for clinicians and for scholars and others, and also what does our field have to do differently? What are the things we have to, we all see this all day long, and the sorts of things that we're about, well, this is about individuals, and now we know, but it's not just, so I think it'll be just good for them, especially any undergraduates who are thinking of going into master's programs to hear you lift these things up. Then you'll get lots of applications.
It's funny, since we went tuition free at the medical school, we are quite awash with applications.
Oh, that's amazing. That's fantastic. It's interesting. We have a program for minority doctoral students, this program called the Sadler Scholars. And we did a workshop with them the other night called How to Get Good Career Advice and Spot Bad Advice. And it was interesting how several of them who are doing PhDs in philosophy were told directly, oh, you're wasting your time. You should just become a doctor. That's the quicker route, and they didn't know what to do with this. And sometimes the person telling them was a more senior person who was also Black, and it was interesting how these two young, they were both women, different programs, were sort of supporting each other, saying, what, we don't need Black philosophers?
Hi, I'm sorry to interrupt. I was just wondering if everyone could start by introducing themselves.
Sure.
Just so that everyone in the audience kind of has an idea of who's speaking, and then maybe start with the questions. But yeah.
All right, Nancy, as fearless moderator, do you want to call on us since we're in this weird virtual environment?
Yeah. Why don't I do that? Why don't I let's see, what did I just do here? I've got some notes to myself. I mean, if you like, you can I have very short introductions for both of you. I can say them if you like. What do you prefer?
Don't care.
Okay.
We can amend them.
Of course, exactly. I thought I'd say right off the bat that since you both direct bioethics programs, that might just be helpful for people to get that in mind, as if they don't already know that, but some may. And then there are just some things that I happen to know about both of you, and for one thing, Travis, I thought I would mention that very early on, you and several of your postdocs got one of those first ethical frameworks out there about public policy. And that was even before you knew what kinds of policy it was going to be about. You were just, we love our frameworks, but you were just trying to say, oh, hey, it's not all going to be in a hospital somewhere. And so I may ask you to kind of say, well, okay, given the topic we're talking about now, were you even conceptualizing that social media would be part of this? Because all of this question about who's responsible and what can social media companies do, I don't know. I haven't done really deep thinking about that.
Yeah. So Rachel, do you want to jump in, or do you want me to start here?
Oh yeah, I was going to say just to confirm, we're live and starting with the questions and everything, just so everyone's on the same page.
Okay, and I'll be the moderator, Rachel. Is that what I'm supposed to do?
Yes, we're live right now. Yeah. You
Great.
Can start moderating.
Great.
Okay, great. So how about I'll start there. So yes, I'm Travis Reeder. I direct the Masters of Bioethics degree program at Johns Hopkins University. And so what Nancy was just alluding to there is that I was part of a team very early in the pandemic. It started off with Ann Barnhill, Justin Bernstein, Brian Hutler, and then it kind of slowly grew over the next year or so as we added pieces to the project. Ruth Faden eventually got involved, a name that will be familiar to lots of folks in bioethics. But one of the first things we did, and one of the pieces that I took a lead on and wrote for the Hastings Center, was to really focus on the way in which values weren't being acknowledged in discussions around COVID-19. And so very early on, as crisis mode settled in, there was a lot of kind of immediate polarization and immediate fighting back and forth and people retreating to camps. And so there would be a kind of sometimes an epidemiology crowd that would be like, this is going to spread, it's going to kill people, whatever it takes, shut it all down, social distance, you know. And then there was a very predictable backlash to that, you know, an autonomy sort of argument. You can't make me shut down my business, you can't make me mask. And that sort of polarization was really problematic. But what it also did, we thought, is that it really did not make clear that there were really substantive, difficult value trade-offs at stake here. And so very often this argument has taken place in the public eye as if there are easy answers. And this happens on both sides. It's obviously correct that X, it's obviously correct that we should shut everything down for this many weeks or months. And so one of my areas of interest and expertise is on America's drug overdose epidemic. And I was very concerned from the word go, along with all of my colleagues in this area, that aggressive social distancing measures was going to involve a trade-off with skyrocketing addiction and overdose, because this was a powder keg situation. Isolate people, increase poverty, increase joblessness, hopelessness, boredom, and drug use will go up. You cut off people's access to recovery networks, that sort of thing. And so what did we see over the course of last year? All of these predictions were exactly right. Drug overdoses jumped from 72,000 the previous year to 93,000 in 2020. It was a catastrophic year. None of that is to say that we shouldn't have aggressively social distanced or had periods of shutdown. What it is to say is that there were very real value trade-offs that we pretended didn't exist. And so much of the conversation, especially in social media, especially in these kind of gotcha forums where there are trolls involved and people acting in bad faith, retreat to really bad methodology and having meaningful conversation. So that's one of the places that I think could be really helpful for us to think about as the way in which a moral framework that wasn't originally thinking about social media. We were actually talking to governors. We were saying, you know, hey, governors, you're gonna have to make statewide decisions. You need to be super transparent about value trade-offs and not pretend like there aren't costs, whichever way you land. But the same rules are gonna apply to social media, you know, squared or to the 10th power or something like that. So I'll stop there, but that might be fodder down the road.
Thanks. Thank you, Travis. Yeah, I remember back in the spring of last year when I was working on one ethical framework focusing on frontline workers and healthcare institutions. And then Travis and his colleagues came out with thinking about, you were almost like making a map for a place we didn't even know we were going to yet, but you were just sort of putting it out there. And I thought that was really, really helpful, even if we didn't even know what we were looking at. Art, one of the questions that has been a through line for this whole meeting is, it starts from the idea that disinformation is a problem, an infodemic is a problem. And I know that you very frequently engage with both traditional and social media. And we were talking a little bit about before the conference to say, to what extent do we know that social media creates antisocial behavior, behavior that goes against what how one would hope one would behave in a pandemic? Or how does it worsen it, or leads to motivated reasoning? What are your thoughts?
Yeah, thanks, Nancy. So I'm Art Kaplan. I'm at the NYU Division of Medical Ethics, where I've been for 9 years, not far from the Hastings Center, down the road a bit, and up the road a bit from where Travis is, actually not that far either. Anyway, I have been very actively engaged in a couple of topics pre-COVID. One was, we've had a vaccine and ethics and policy project for 8 years. We were looking at vaccine issues of hesitancy and resistance and misinformation around childhood vaccinations, many other vaccinations, hesitancy in Europe, hesitancy in Japan, which has had horrible vaccine hesitancy for decades. Today, by the way, still post-Olympics, vaccinated 38%, trailing many countries, developed, wealthy countries. And we had a project also on pre-approval access to unapproved drugs and vaccines, where we were looking at what do you do in distributing a drug or a vaccine before the FDA gives authorization for it. So in one sense, we were way into topics that were on COVID or COVID. In another sense, we've had to recalibrate some of the things we thought we believed about vaccination and about pre-approval access, watching what's been happening in response to COVID. But to get over to Nancy's question, I'd say a couple of things. First, I'm very active on social media. I have a Twitter account. I use it a lot. I have a lot of followers. I'm not particularly active on Instagram and TikTok because I'm out of time. A little bit active on Facebook, but that's really where I go as an old person to trace my friends' kids and to see what's going on with former students of mine. I don't really use it as a debate platform or a place to talk. Occasionally I'll post something about vaccines and what I consider to be sound information about vaccines, but it's not a debate forum. Twitter, probably the social media site where I go where the most fighting occurs. I also do a lot of stuff, just so you know, in the mainstream media. I have regular radio shows on WGBH in Boston, WOR in New York, KGO in San Francisco. I do regular weekly TV things for WebMD Medscape. And then I just do a lot of media things when asked. And I have a CNN connection too. So I have a mainstream media view. I have a view on the social media. I'm going to say three things. One, is there a lot of misinformation on social media? As we all know, yes. But there's a lot of misinformation about everything on social media. It's a hotbed of opinions, theories, biases, and so on. That's the nature of the medium. It's as if all the mainstream media took all the tabloid newspapers, all the stuff that you see at the supermarket checkout, those tabloids, threw them all together, and it became Twitter, where everything goes and lots of messages fly. Second, do I really think it's a place where debates go on? A little bit, but not much. More or less, it's assertions. More or less, it's people sort of posting ammo for their particular point of view. Don't really see long backs and forths, discussion, dialogue, and debate. A little bit. Some of the conversations go on a little bit, but for the most part, people tend to really block the hostile, and then simply there's a little bit, I think, as there is in the mainstream media, sort of talking to your friends and your buddies. So, does vaccine hesitancy and some of the COVID issues about masking and so on, is it fueled by misinformation? I'm going to say, as Travis started to, a bit, but I also believe it's a values difference. I'm not sure it's just a fact difference. I think people go out and hunt facts to support their values. So do you have to read Twitter to believe that you don't want to be told to wear a mask? No. Do people look for things like masks will poison me or my kids, or they don't work, or they're being sold to us because they're made by companies that want to sell them to us? I think what the media does, as much as it does trigger hesitancy, it reinforces value positions that people bring to Twitter. So in that sense, I would argue the best way to manage social media isn't just to try and clean it up so that the facts are accurate. You do have to realize you're in a values fight, and that's where the debate is.
So what do we, I mean, for people like us, and there's the funny little sound thing in the background. I'm not sure what it is, but I'm just going to try to ignore it. So what do people like us do? We spend so much of our time talking about frameworks and, as though there's a place where you all come together inside of it's all metaphor, and the idea that if we just have the right framework, we can get right thinking people together. Well, even in two of us live in blue New York State, we can see the fight that's going to be going on over the next few days and weeks over vaccine mandates. I mean, in healthcare, in schools, and you can see that it's tied to political fortunes. We've had a governor resign recently. It's tied to the start of the school date, the fact of that's where the anxieties are moving now, and the fervent desire not to have to send over 1 million children back home again. Again, I know, even if you're thinking about parents forums or how people share information quickly, I'm still trying to figure out how we have these conversations. I completely agree that there isn't this one forum where we all gather and we can look back and say, well, Walter Cronkite, well, that was a long, long time ago, So I know that. I'll just give a couple of examples from me, in my public facing role. In the past week, I've spoken to 3 outlets about the same case, which is, should I lie about my 11-year-old? Should I fudge? And I heard about this from USA Today, very mainstream paper, from NPR, more liberal leaning, and from an outlet that is for parents and children. So very, very child oriented. And it was interesting to hear that in each case, the reporters were saying, almost like, I'm really concerned because I've been talking with parents and they're giving me very detailed descriptions of how they are going about this falsification. They are talking about how they're going to lie about their child's birth date, which date they're going to choose, how they're going to fix it later, what they're going to tell the child to say, all of these things as though this is what must be done. And it's almost like, I'm really hoping that you won't say, well, gotcha, I think they're being wrong, but you're going to tell me some other reason why this is a problem. And, and I fortunately, I have an 11-year-old niece, so I'm able to talk to my sister and just say, how does this even sound to you? And some of it is very psychological. It's just like, I can't even imagine lying that much, let alone telling my child to lie. Who would, my truth teller niece would tell me, that's not my birthday, and she doesn't like it when you do things like that. So that, so some of it isn't just ethics. It's just down to a big word we use in ethics is context. What is the context of what you're asking someone to do? So I'm never using principles talk in this. I'm saying things like, if you're used to talking to your pediatrician about your child's health, talk to your pediatrician before you lie to your pharmacist. Before you start an untrustworthy relationship, and if you're ducking a conversation with someone you normally trust, that's the thing you should be worried, should be thinking about ethically. But I have found there's no one framework for doing this. I can go back to Cecil Labach's work from the 70s and 80s on lying and deceit and corruption and all of those things. But that gets me only so far when I'm talking about people who are saying, but my child.
So let me take a stab and then I'll let Travis add on if he wishes. I'm backing up not to your example, which I've heard about as well, about pushing the margins to get your kid vaccinated by some. Oh, my dog is protesting. But I think it's more, how do you use the social media to affect change? So I've asserted that social media is not a debate forum. It's a place where people express strong views that they may have about a variety of COVID topics, whether it's rationing, ICU access, penalizing people who don't vaccinate, mandates, passports, whatever it is. So what I do, this is just speaking for me, is I surf around in Twitter and I see what people are concerned about, objecting to, or worried about. And then I may decide to express an opinion about it in an op-ed or maybe on a post. What I'm trying to do there is garner attention to the point of view that I believe is right, and many mainstream media are surfing there and watching for that. So a common flow for me, in my experience, is people put their views up on social media, you watch the social media, you respond to something you agree with or don't agree with, or you think is being missed. Mainstream media types come along and fuel attention to what I've said, maybe more acceptable in an op-ed or opinion piece or Hastings Center's blog or whatever it might be. And then you can attract the attention of different audiences. And here's what I mean. Sometimes politicians will pay attention to the mainstream media because they live and die through publicity. But you also may attract attention, and this has happened to me in the past year, of employers. So I'm trying to get employers to do things like put in mandates or try to put in education programs for their workers. And they see it in the mainstream media, and all of a sudden they're policy leaders. It's not just the governor of Connecticut or the legislature of New York or the governor of Maryland. All of a sudden you see there are other actors. Similarly, professional societies may step in and have something to say. AMA endorsed mandates this week. We've seen petitions organized to get many organizations to try and require healthcare workers to get mandatory vaccination. And I don't mean to obsess just on vaccines, they're just examples, but I want you to pay attention, if you will, to what I think is one path. See what's floating around on the social media, take a position relative to that, it's wrong, it's right, reinforce it, see if it drives more attention into the mainstream media, and then see how it plays out with various actors who can shape policy. But it isn't just trying to talk to government. It can be, but I think for my money in this pandemic, major players turn out to be employers.
Travis, I wonder if you've had experience with that in your research and in your various public-facing roles at looking at drug policy, at the idea of using social media. I think that's really interesting, as a way to take the temperature of what people are worried or concerned about, and then use it, and then kind of nudging that along and saying, okay, here's a topic that a lot of people are interested in, including people who aren't on Twitter.
Well, I don't think I'm that sophisticated at serving the sites as art is, but part of my answer to your initial question, kind of, what do we do in this situation where it's not just about correcting facts? I've started to think of a job that needs to be occupied is something called an ethics communicator. And so all during this conference, there's been an extolling of science communication, and I join in with the extolling. Science communication is like the Lord's work, good translational work that society needs. But we need that same good translational work in ethics. And so we need the sort of thing that Art was describing. Sometimes it happens in op-eds, sometimes it happens in social media. But what I think this is constituted by is the sort of careful exploration of these underlying values that often get overlooked, right? So one of the things that happens is we all get out over our skis if we're asked to comment on something that is massively multidisciplinary as a problem, right? And so if you ask a virologist what to do about school closings, they have a really important perspective. They know some relevant science, but they are not policymakers unless they happen to do that as a side job, right? They're not on school boards. They're maybe not trained as an ethicist or a health policy person to think about these underlying value trade-offs, right? And so the sorts of discussions that we need to be having on social media, in the more mainstream media, with one another societally, have to involve a lot of different perspectives. And every time it comes to making decisions that affect thousands or millions of people that involve values trade-offs, we can't pretend like these are just discussions of the science. So science communicators, I've been amazed listening to some of the physicians and scientists on the calls today who are able to describe what they do beautifully and eloquently, and I'm riveted by them. But we have to do the same thing with ethics, because when they're going viral on TikTok, making the virology understandable, we also need to be making the trade-offs understandable to the same community who are going to have to be weighing these decisions out, so that when they give feedback to their school boards, they're actually thinking about, how to make this decision rigorously in a sophisticated way that recognizes the nuance.
Do you think at sometimes, I'm thinking specifically of school examples. I mean, I'm sure we can all think of certain scientists, epidemiologists, pediatricians who have put themselves into roles of interpreters for parents. Emily Osterett-Brown and various others. She's just one who comes to mind. And yet, you can always find someone who's going to agree with what you already think you want to do for your child. If you think I have to keep my child out of school, you're going to find someone who's saying, well, that's what I'm doing. I'm holding back. If you say to somebody, go ahead, you're going to find somebody who's going to endorse that as well. And in some cases, some of these sort of scientist communicators have then copped to the fact, they said, yeah, my kid does go to a private school, and I wasn't thinking about the problems of large public school systems and having to make a decision for 1.1 million children. Like in my city, I was thinking about, my kids with, classes with 16 kids in them. So how do you, I don't even know how you would even, just at this school year time, how you would help parents or school officials or others who haven't already decided on one position or another to decide to whom to listen. Because
I was going to say, good set of questions. I agree with Travis about the need for multiple disciplinary perspectives. I live in Connecticut, even though I work in New York. And last week, I assembled with a group of people here a open podcast, Back to School Connecticut. And I moderated it, and I picked myself to moderate it partly because I don't have any kids. They're too old going back to school. But partly because I thought I could play a little bit of that interdisciplinary role and ask questions that maybe people were a little embarrassed to ask or something like that. So we had 5 panelists. We had a person who is the coach, I guess, for the orchestra in the town of Ridgefield, where I live, in the high school. We had superintendent of schools, school nurse. We had a good cross-section of people, and not everybody was pro-mask or back to school or whatever. And off we went, and we took the questions. And I think bioethics or ethics in that way made a real contribution. Had a forum, ask what you want. Didn't really have a big agenda. Anybody who got rude, we kind of didn't let them ask a question. We didn't throw them out. We didn't have to. It wasn't a physical thing. But I think it went really well. And I don't think we do enough of that. I think we tend to talk to each other in the academy or maybe to mainstream media outlets that we love and respect. But, bringing these matters out into the community, trying to facilitate attention to the value side of the question. Again, Travis is right. It's not like there's one answer for every kid and it's clear and there's no downside. Everything has some costs and not every kid is the same. And it's not the same when you're 14 as when you're 4. And, a lot of variability there. But I think bioethics, our field, has a history or legacy of trying very hard over the years. Travis, you won't remember this, but Nancy might, to be accepted by the academy, to try and be professional, to try and publish in the right journals, to try and get slots that would let you get academic positions. But the other side of bioethics is kind of an activist one in the community. I don't think we do so well.
Yeah, no, I do. I don't have children, and so I have to use other parents as proxies. And so whenever I get a question about that, it isn't like answering a question about, ICU ethics or something like that. It's where you can go to talk to some doctors and nurses and get a sense. You really do have to say to somebody who would be making that decision on behalf of another person who cannot make that decision for themselves, what does this even feel like to you right now? What does it look like to you right now? Where are your sources of information? And no two parents will, even if they might make the same decision and have a child the same age, will describe exactly the same situation. It depends on, are they in Brooklyn or are they in Florida, or is their child is every child masked, or is their child the only one who's masked, and, or a reporter might say, I was talking to a woman and she has an older child who's been vaccinated. And the reason she fudged the birth date on her younger child was because she's a single parent and she does not have the time, the bandwidth to deal with a sick child. So she just crossed her fingers, I'm going to split hairs on that. It's just really churlish. But so, I do absolutely think we should welcome this. But the idea, but I always sort of cringe with, then it's framed as the controversy. I'm always saying, please don't ramp it up. Let's say this is some people are experiencing this in their family life, in their town life, in their school life, in things that are going on that are super important to their children. So I sometimes I wish we didn't call things debates or controversies, because that may not be how the family is experiencing it. Travis, I know you're a parent. I wonder how this, without anything, disclosing anything, how this plays out for you.
Yeah. So, take that, roll it up with your underlying question, which was kind of like, how do we actually move forward and do any of this value exposure work? So here we go. You heard it here first. Travis Reeder's patented first rule of ethics communication, right? Compassionate and thoughtful, respectful engagement, right? I think this is one of the things that social media makes the hardest for the sort of work that we're trying to do with the public, that we all must do with the public right now, which is, it doesn't incentivize that. It incentivizes the gotcha. It incentivizes the most entertaining, right? But if you're trying to do this values work, and you recognize that if a problem is hard, then there are going to be real trade-offs, right? This is just a basic principle. If there were no real trade-offs, the problem wouldn't be hard unless it's just weakness of will or something. So we got this school example. It's a genuinely hard problem. Do we send kids back to school? For my daughter, it's next week, right? And so there are genuine trade-offs here. My school system is going back. It's not online. There's a good mask mandate. We're going to see how it all goes. These are all bad options because we're in a bad situation, right? And so one of the things that she's going to do is she's going to be at a much heightened risk of contracting the Delta variant and spreading it to her family. But also, she's not going to continue to miss. She's only had one semester of school ever, and she's in second grade, right? And so these kids have missed out on something genuinely valuable. So we recognize all these values at stake, and we have to take them seriously. And so I want to say two things about that. You have to take them seriously. One is that this is actually a moral requirement. So you have to take them seriously because that's the way that you engage with other humans respectfully. And so the sort of like snappy shutdown of the alternative position is a disrespectful position. Now, no, I'm not talking about engaging with trolls here. I don't have rules for engaging with trolls. But when you're engaging with someone who's genuinely on the opposite side of something as you. So it's, I think, morally wrong to not engage with them respectfully, to kind of unearth this difference of values and then to see why you're weighting them differently, right? But then I also just think it's pragmatically wrong. You're just way less likely to do any good if you focus on snappy comebacks and entertainment than if you actually do respectful engagement. Because I want everybody to try to think of a single instance in which their sworn enemy politically or in terms of polarization convinced them of something by shutting them down. That just doesn't happen. It doesn't exist. Table thumping and yelling at people doesn't convince anyone. So it's also pragmatically useful to treat people with respect and unearth these values together. So absolutely, I think that what we're going to do with kids in my district next week is really problematic. And I think that choosing to keep them home would have been really problematic. And that's recognizing that we're in a genuine dilemma because there are such severe costs on all sides.
Yeah, I think, and I think that's a really good way to put it, to just say the stakes are very high, and the children themselves cannot really engage in these debates, many of them anyway. So there's that extra sense of having to decide for another. We've been asked to return to one of the questions that was posed, and it does touch on what we were talking about at the beginning, the idea of an ethical framework or frameworks. We love that term. Is there a specific ethical framework that supports the need for social media companies to play a more active role in limiting misinformation and disinformation? We'll take that question first. I know what I think, but I'd like to know what Art thinks.
Well, look, the companies claim to be carriers. They claim to be disseminators. They don't claim to be news organizations. That's their line of argument. It's like we're a billboard company and someone else decides about the content and puts it up there and we carry it. But I think even billboard companies have standards. They won't put up anything and everything that they might be asked to. I think some people worry that Facebook or Twitter might be too censorial, too restrictive on what they will carry. I think they could do better. I think there's a lot of stuff up there that is just flat out misinformation. There were days when I wish they would do something about bleach as an antidote to COVID before people killed themselves. So that seems to me to be something they could step in and say, we're pulling this down and this is false and it's really dangerous. At the other end, though, I don't think they're really going to be in a position to sort of purify the Facebook or the internet with messages that, the immunology division of NYU would be satisfied with. I don't think they're going there either. So it's noisy, it's ribald. It is better, I think, to remind people that you don't really want to go to get your medical advice just to the internet. It might be a place to raise questions. I think it's teaching people a little bit how to use it. So partially you could control it. I mean, just flat out dangerous. At this point, ivermectin has poisoned more people than it's cured. So it may be time to pull down some of that stuff or flag it and say, this is really dangerous. Don't use dewormer to get rid of your COVID. But beyond that, I don't think they do it very well. I'm not sure that's their mission, if you will. But I think it is reminding people, what do they got when they're wallowing around out there in the social media side? They got a big cacophony. It's like saying, in the olden days, I'm going down to the local coffee house and I guess I'll let that guy sitting next to me on the stool tell me what I ought to do about going back to school.
Yeah, I wonder, Travis, do you think you could, when the question suggests, is there an ethical framework? But it seemed like the right word should be, is there a regulatory framework? Is there a way to I don't know. I mean, there have been efforts, for as long as there have been different forms of media to impose some sort of standards or another. But this seems to be very slippery, So I don't know how far we get, other than, as that Art suggested, helping people to be more critical in how they're using something.
Yeah. So I do think there are regulatory options. We've seen some of that this past summer. There was a bill put forward to repeal a kind of protection for social media companies. The Facebook, Twitter, and Google folks who are on one of the early sessions gave a really nice overview of what they're actually doing. But I actually don't want to give up on the ethical framework too quickly. The regulatory stuff is working its way out. Politicians are really frustrated right now, especially with Facebook and Twitter. And so we're going to continue to see how that happens. But the reason I flagged Ashley's comment in the chat is because I thought she asked it exactly perfectly. She said, what would ground, it went away, so I'm going to do this from memory, right? But what would ground a responsibility and obligation to the platforms, to the influencers? Oh, someone very nicely put it back up. So to the platforms, what about the influencers, and then those who consume information from social media? So this is not, say, an established ethical framework of public health or biomedical ethics, but here's a framework that I've been thinking about a lot lately, because I think COVID-19 has revealed how useful it is to recognize the tensions between public health and individual decision making. And that is that we are facing more and more often massive, large-scale, catastrophic collective threats that each of us individually contributes to very little, some, or infinitesimally, kind of depending on the individual threat. And so then responsibility falls in various different ways. And when people start putting responsibility on actors, there's a lot of moral discomfort about that judgment because it's so confused. So climate change was the paradigm of this. Big, massive collective threat, lots of unintentional action by 7.5 billion people, and at the end of it, hurricanes and deathly heat waves, etc. COVID-19, infectious disease, has this same framework. It's modified because individuals can cause harm. You go maskless, unvaccinated, cough all over people. You could, in fact, be the direct vector that kills somebody. But by and large, the reason infectious disease is so hard is because we have to ask people to do stuff out of solidarity, to be part of the solution. What was the initial rallying cry? It was flatten the curve, right? Do your part to flatten the curve. And so I think if this conference was premised on the infodemic as kind of taking very seriously misinformation as an analogy with an epidemic. And you can see in this question that this distinction between individuals with power and the collective is really coming out when you're facing this big collective threat, which is disinformation that can cause a huge amount of harm, right? So most of us can't change it. My piddly 3,000 followers or whatever, they're awesome, not piddly, but the piddly number of 3,000 followers is not going to change the direction of the infodemic. But I can do my part. I can participate in with solidarity in a kind of greater movement. There's a question about how much responsibility I have to actively combat misinformation. I see this argument play out. Must you use Facebook as an environment where you call out your uncle, right? So that is a very real question. But when you ask, what's your job? One of the things that you often hear is, well, that's letting Facebook and Google and Twitter off the hook, because they're the ones that can actually fix this, right? So they're the ones that actually set the stage, they set the game up at the beginning, and they can actually do it. And so collective action problems call for policy. They call for collective solutions by people who are actually in a position of power, which is why we're asking them to do that. Rachel's here. Last thing, influencers. Influencers live in the middle, because if you have 2.5 million followers on Twitter, you are not me. Right? You are not just another pawn in this massive network of misinformation. Now you can actually do something. And that's why it's really important that Arnold Schwarzenegger is going on and talking to his followers about this stuff, right? So that was really long. I hope that was at least a little bit addressing Ashley's question. I'm done.
Yeah, there was one question there I just want to mention very quickly. Someone had said, is there a historical example of someone drawing attention to these problems? And the first thing I could think of was the speech that FCC Chairman Newton Minow gave back 60 years ago, where he condemned television as a vast wasteland. Now, that was the golden years of Walter Cronkite. But at the time, someone who was very powerful as a regulator was looking very critically at it. And so I this may be another one of those moments. I don't know how we use the incredibly vast and fragmented media that we have now to think about collective action problems like climate change, let alone COVID.
So Nancy, let me
go ahead
with a last thought before Rachel kills us all. Even if we cleaned up the social media, even if it was by somebody's standard more factual, would that actually bring to an end debates about what to do about COVID? I doubt it very much. So it's easy to believe that if we could only get the facts right and only get them disseminated properly, then we would have a kumbaya moment and reach consensus on many policy questions. I don't think that's the way it works. I think the way it works is you move with your values, you look for information that backs it up, you can clean up some of that, but that doesn't mean you won't find other things. The number of people who told me they weren't going to vaccinate because vaccines were emergency use authorized, the day it got licensed, I came back and said, now? And they said, well, they're not safe. I mean, they were looking for reasons to justify the fact they don't want to vaccinate. It wasn't like they were going to be moved by the facts over to a more modified position. So I don't want to say the facts don't count. I don't mean that, but let's not overemphasize where we are on the values. I mean, not paying attention to the values, excuse me.
Rachel, I see.
Oh, sorry.
Yeah.
I was just going to say thank you so much for your participation today. And I would like to welcome our host, Dr. Seema Yasmin, back to the stage for a summary of today's conference. Thank you again.
Thank you all.
Thank you so much, Rachel, and thank you so much to our audience, hundreds of you from around the world who joined us today for INFODEMIC, a Stanford conference on social media and COVID-19 misinformation and disinformation. Because we've had the privilege of learning from such a broad range of scholars and thinkers today, we've had ethicists, epidemiologists, infectious disease doctors, cyber policy experts, social media representatives, religious leaders, so many people. What I want to do is briefly go over some of the key takeaways from our panel discussions and presentations today. I don't know about you, but it certainly helps me consolidate my learning at the end of a long day to do this. And behind the scenes, we've had a group of students taking fantastic notes to really just help us summarize some of the key takeaways. So from the first panel of the day, which was our roundtable discussion about vaccine hesitancy, we learned how crucial it is to include context in our discussions about vaccine confidence, hesitancy, and crucially, vaccine access inequity. In many countries, and here in parts of the US too, it's really a conversation about access that needs to happen, not just a conversation about hesitancy. Trust came up numerous times in that roundtable. We talked about trust in government, trust in industry, trust in officials, and ways of building or restoring trust between those kinds of groups and the publics. However, we talked about this challenge of trying to build or restore trust in a crisis, how challenging that can be, and what we might need to do now and in the next years before the next pandemic hits. Dr. Italo Brown gave us a rundown of the racist history of medicine and public health in the West, a history that we do not cover in most medical school curricula. And I think we really need to think about why that deliberate decision is made. His talk was really important in helping us understand drivers of distrust in healthcare in communities of color. And he talked about restorative justice as a next step. From that vaccine equity panel, we learned that we need greater transparency around policy decisions, as well as enhanced international cooperation. So building on some themes that came up in earlier talks as well. We also learned that Twitter, Facebook, and Google have policies and systems in place for removing content, for adding labels, for deactivating accounts that promote misinformation. But one of the challenges that all of these companies, all of these platforms must face is navigating the influx of just constantly evolving information and thinking about how to remove misleading content quickly, efficiently, while promoting high quality and medically accurate content. The panel discussing social media influencers mentioned how effective science communication can foster confidence in vaccines, that when you have really good, nuanced, and targeted science communication, it allows people and their communities to make informed decisions and teaches them to be more discerning about information. We did also think, though, about those challenges of audience empathy, of respect of our audiences, of relatability, and how crucial those are in empowering people to seek information rather than antagonizing people who hold polarized beliefs, rather than shaming people for their beliefs. Our discussion with the Reverend and with Mayor Perkins revealed that the politicization of this virus has incited even more distrust where there perhaps already was mistrust and distrust. And we talked about how combating disinformation relies really heavily on collaborative efforts, so that when people choose not to put their trust in government officials, partnerships, and people with religious figures, for example, we can increase receptivity when we are collaborating with local stakeholders. So I hope that brief summary helps consolidate a bit of the learnings from today. I'm sure there are many more takeaways that you're mulling over. Myself and the INFODEMIC team hope that today's discussions and presentations have brought you new insights, and that these learnings enrich your work as we all contend with the challenges of COVID-19 misinformation and disinformation, the rise of anti-vaccine movements, as well as vaccine hesitancy on a much broader scale, And of course, this really critical point that we can't overstate, which is inequitable access to vaccines and inequitable access to accurate, credible information. So with that, thank you so much for your time and attention today. This ends the conference, but don't leave us just yet because we're not completely done. Starting at 3 o'clock Pacific, we have a 1-hour research symposium that you can join. There are going to be 8 research teams from around the world, and each of them is presenting work related to the themes of today's conference. All of the presentations are happening at the same time, but they're in different rooms. So it's labeled session on the Hopin platform. So this broadcast will end in a few minutes. And then at 3 o'clock Pacific, you can navigate to that tab where it says sessions, and you can enter whichever room interests you. You'll be able to interact with the speakers and directly ask them questions about their research as well. One final note for Stanford students who are joining us today, you're encouraged to join session 8 for a discussion with the student group Scientists Speak Up. This room is specially reserved for you, Stanford students. So once again, on behalf of the entire INFODEMIC team, thank you so much for joining us today. Thank you for your interest and thank you for your work. Stay safe.